الصوت اللي طالع.
والسلايد ادفانسر كمان لو ممكن. عليكم السلام، اهلا يا دكتور. مين؟ لا، عبد الرحمن راح في الدايبيس. ما هي دي اللخبطه ديت اللي حصلت. عبد الرحمن راح في الاوبيزيتي. سوري. صباح الفل يا دكتور، ازي حضرتك؟ اخبارك ايه؟ الله يخليك. عينيا.
السلام عليكم.
ها تمام. لا
الو.
تيست 1 2 3 تيست.
يلعب مظبوط الصوت. Good morning everyone.
اعتقد كده تمام.
لا هو هذا ليزر ده ولا؟ بس هي دي تمام. وفي البورتبل مايك. يعني هنضطر نوقف هنا. خلاص هو في اللي هناك. السلام ورحمة الله. كيف الحال؟ صباح الخير.
صباح النور. أنا أول بريزنتر. طيب
انا اول واحد اخويا.
لازم يعني نفتتح بحاجة ثانية.
الله يسلمك.
السلايد ادفانسر. عليكم السلام ورحمه الله وبركاته. كده الاخضر ده
نقلب
والاحمر بنرجع لورا. ان كيس ان انت عايز ترجع لورا.
طيب
تمام. عايزك تقف هنا وتتكلم. صباح الفل.
السلام عليكم ورحمة الله. كويس. إيه تمام.
هي مش آية المفروض بلغت حضراتكم، هي آية تقريبا ساعتين تقريبا. لا بس أنا I'm not sure. تمام؟ تستمر جدا.
صباح النور. كيف الحمد لله. كيف اليوم؟ إن شاء الله كويس.
بسم الله. احكي يا سيد.
بسم الله. بسم الله. تيست. الله. الله. بسم الله الرحمن الرحيم.
روح بعيد يا سيد، بمكان بعيد، امشي بعيد.
بسم الله.
بعيد،
إيش؟
امشي بعيد.
ايش؟ بسم الله.
بلاش تكلمني زي ما بكلمك، روح من بعيد.
بسم الله.
سامعني؟
الله.
إيه.
بسم
سيد،
ايوه سامعك.
اقلب التليفون بالعرض. تليفون بالعرض اقلبه. انت بتتكلم على تليفونك ولا اتكلم عليه؟ سيد،
ايوه سامعك.
اقلب التليفون بالعرض
كده.
بس. سامعني كويس؟ ها،
ايوه سامعك. ايوه.
خليك زي ما انت، اتكلم معايا شويه. سامعني سيد؟ اتكلم.
ايوه. ايوه سامعك. بسم الله.
بلاش تست ولا غيره،
سامعني؟
اتكلمني زي ما بكلمك. سامعني؟ سامعك.
كده سامعني؟
ايوه سامعك تمام.
اه.
بص للكاميرا وخليك وشك للكاميرا كده، ما تلفش حوالين نفسك وكلمني. اتكلم.
كده سامعني؟
ايوه سامعك. ايوه صوتك تمام.
كويس كده.
سامعني؟
بسم الله الرحمن الرحيم. بسم الله والحمد لله والصلاة والسلام على رسول الله. Good morning, dear friends and colleagues, and welcome to the first Faqih Congress. This is the annual Congress that, inshallah, will be continued every year. Without any more detail and more delay in the introduction, it gives me honor to introduce Dr. Ziad Al-Harbi, the main chairperson of the whole Congress, to officially open the Congress. Dr. Ziad, تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Welcome to everybody. Welcome Dr. Saleh, our Deputy CEO. Welcome Prof. Faisal, Dr. Hani, all the esteemed moderators and speakers. I think people waked up already and they are coming, still coming. And inshallah we will start our journey of the Congress over these 5 days with this important medical conference. And I would like to ask Dr. Ammar and Dr. Fahmi to start the first session officially. Please, the mic is yours. Thank you.
Assalamu alaikum. Good morning, everybody. Today we'll talk about very important topic about diabetes, which is the most common disease worldwide. We'll start with Dr. Ali Jamal Al-Lail. He has bachelor in medicine and surgery in King Abdulaziz University, Saudi Arabia, 2007. Internal medicine residency, Central Michigan University in USA, 2014. Endocrinology, diabetes and metabolism fellowship in University in Louisville, in USA, 2016. He worked as an endocrinologist at Medical Group in USA, 2016 till 2022. Currently, he is working as endocrinologist in Dr. Sulaiman Faqih Hospital. Floor is yours, Dr. Ali.
Thank you so much. Assalamu alaikum wa rahmatullah. It's a great privilege to be here, and I'll be talking today about SGL2 inhibitors class, and without further ado, we'll start the presentation. My outline today, I'll talk about the physiology of SGL2 inhibitors, which is sodium glucose uptake inhibitors, and then the effect on glucose control, and we'll review some studies on the cardiorenal benefits, and then we'll talk about adverse events and the latest 2022 guidelines. So the SGL2 receptors are located in the proximal tubule, with mainly the SGL2 type 2 are in the segment 1 of the proximal tubule, and the type 1 receptor located in the segment 2 and 3 in the proximal tubule. The SGL2 are responsible for 90% of the glucose absorption from the kidneys, and the SGLT1 are responsible for the 10%. And as we know, the filtered glucose that they average about 180 grams per day, and that threshold can change with diabetic; it can reach higher. So the effect of the SGL2 inhibitor acts on inhibiting glucose absorption and then excreting with the urine. The main SGL2 inhibitor that I had experience with was the canagliflozin, which is named as Invokana, empagliflozin, Jardiance, dapagliflozin, which is Farxiga, and ertugliflozin, which is Stiglatro, which is not available here. I believe also the canagliflozin not widely available in Saudi Arabia. And as you see, in the past 10 years, the amount of meta-analysis that we have that reflect how much data we have now on this class of medication. So what about the glycemic control? In this meta-analysis, it compared the major SGLT inhibitors with placebo, and compared also with other oral hypoglycemic agents. Important to mention, these are not head-to-head trials. And you could see that the effect of SGLT2 inhibitor range from about 0.6% to 0.9% with compared to placebo. Also, there is a great effect on the fasting plasma glucose up to 2 millimole per liter with the canagliflozin 300 milligram dose. The weight loss is about, it ranges from 1 to about 2.5 kilogram weight loss over the period of using of the SGLT2 inhibitors. And you could see maybe the canagliflozin, the 300 dose, maybe has a little bit more efficacy, and that may be postulated to be related to the some SGLT1 sodium glucose uptake the type 1 receptor efficacy, which is found in the gut as well. And this meta-analysis also showed that that the effect of SGLT2 inhibitor not only lasts 12 weeks, but you could see the effect up to 24 weeks with reduction in A1C and weight as well. And this slide shows that how the A1C lasted up to 26 weeks, and in some trial also lasted up to 52 weeks with reduction in A1C. This is when they compared to other agents. I mean, in 5 trials, they compared SGLT2 to metformin, and there was no major difference in A1C reduction. In about 1 trial, showed that maybe canagliflozin is superior to sitagliptin. And in 1 trial, that they compared dapagliflozin to glipizide, and glipizide had a little bit more efficacy in A1C compared to the glipizide. But if you add SGLT2 inhibitor to metformin, how does that differ from other oral hypoglycemic agents? This is a meta-analysis that looked into that and showed that maybe in the first 24 weeks the efficacy was not significant, but you could see that there is a better efficacy on lowering A1C at 52 weeks and 104 weeks. And that could tell you that there is a long-term benefit of using SGLT inhibitor compared to other agents like sulfonylurea and maybe the DDP4 inhibitor. Also might make us think that maybe the efficacy of sulfonylurea on exhausting the beta cells, and you might see less benefit later compared to the other agents. The purpose of this slide mainly to show that the efficacy of glycemic control does go down with lower GFR. So when someone is uncontrolled with diabetes and have very high A1C, you might consider to add other agents to control the blood sugar. As when you see the GFR less than 30, the effect on glycemic control become very minimal. The possible effect of SGLT2 inhibitor on our body rise from the glucosuria, and then there is immediate increase in gluconeogenesis. And this is just a hypothesis that after the glucosuria started, there is some increased glucagon and gluconeogenesis from the pancreas and from the liver, which lead to maybe decreased insulin production, and that might decrease the workload of the beta cells. There is also increased lipolysis and increased non-esterified fatty acid uptake, and that's some theories that that's what caused the weight loss with the use of SGLT2 inhibitor. Very similar effect to the fasting state that happen when, for example, in intermittent fasting and other diet. So now we'll turn to the cardiovascular benefit. I'll start with the EMPA-REG outcome, which is the study that involved empagliflozin. They involved patients with type 2 diabetes at high risk of cardiovascular events, and they randomized it to, which was a double-blind randomized trial. They randomized the 10 milligram and the 25 milligram to placebo. So this was one of the first trials that showed there is a decrease in the primary outcome, which is the composite of cardiovascular death, MI, stroke, for empagliflozin. So they appeared at 10.5% events compared to placebo, 12.1%. The A1C reduction was about 0.24% up to 0.36% with the 25 milligram. And as I mentioned, this is one of the first large-scale trials shown to improve in heart cardiovascular outcome with simultaneous improvement in glycemic control. The conclusion from this study was showed that the use of empagliflozin is superior to placebo in improving glycemic control and reducing cardiovascular events. The number needed to treat in this trial was 39, which is very significant in the cardiovascular world to decrease the cardiovascular mortality, non-fatal MI, and non-fatal stroke. What about the cardiovascular mortality? It showed that there is 38% decrease in cardiovascular mortality compared to placebo. There is 32% decrease in all-cause mortality with empagliflozin. The effect on heart failure, it showed that there is 35% decrease in hospitalization from heart failure. I won't go to all the trials, but this is just a summary on the effect of major adverse cardiovascular events. With the empiric outcome, which is involved the empagliflozin, it was significant on MACE due to cardiovascular death, but there was no effect on stroke or MI. In CANVAS, this is the study that involved canagliflozin, showed also significant on MACE due to contribution from MI, CV death, and stroke. While in DECLARE, which involved the dapagliflozin, and VERTIS, this is the ertugliflozin, showed only trend toward decreasing the MACE outcome, but there was no significant result in these studies. The cardiovascular death was the empagliflozin, only the one that showed significant reduction, but there was no benefit in CANVAS, DECLARE, or VERTIS cardiovascular study. But in the hospitalization from heart failure, all the studies from the all SGLT2 inhibitors showed significant benefit in decreased hospitalization for heart failure. And this benefit was independent of the cardiovascular risk, prior heart failure, and across the spectrum of the glomerular filtration rate. And this is just a summary also of the cardiovascular outcome with the different trials that we have. So we mentioned the empiric, DECLARE, CANVAS. The credence is the one, Invokana with chronic kidney disease, also showed decreased risk of major cardiovascular events. This effect could be related, so we start with glucosiuria that could lead to decreased tubuloglomerular feedback activation that lead to the decreased hyperfiltration, decreased intraglomerular pressure, and decreased albuminuria. These all lead to decreased fibrosis and the chronic kidney disease progression. But also, as you see, there is multiple effects. So one theory that it decreased the total body sodium and water from the diuresis that happened. The sodium hydrogen exchange also there is decrease, and that decreased the risk of effect of the stress on heart tissue and heart cells as well. The decreased weight, increased lipolysis, and increase in gluconeogenesis also has the effect on decrease the fatty liver side effect from the insulin resistance and uncontrolled diabetes. Now I'll go to the effect of SGLT2 inhibitor on renal outcome. These are the major trials that involved SGLT2 inhibitor with chronic kidney disease. We start with the credence trial, which involved canagliflozin. They involved patients with diabetic only, and they had no albuminuria. The key inclusion criteria was GFR more than 30, and the urine albumin creatinine ratio was more than 300. And the primary composite outcome was end-stage kidney disease, doubling of creatinine, or renal cardiovascular death. This trial ended in 2018 and showed positive result. I'll go in detail in the next slides. The DAPA-CKD that's involved the dapagliflozin, involved patient with proteinuric chronic kidney disease, but extra they added non-diabetic patient. And their key inclusion criteria was GFR more than 25 and urine albumin creatinine ratio more than 200. And the primary composite outcome was end-stage kidney disease, more than 50% sustained decline in GFR or renal cardiovascular death. And the study ended in March 2020, also showed positive results. The IMPA kidney trial recently ended and was stopped. Most of them was, or all these trials were stopped early actually due to benefit. They involved also patients with diabetes and non-diabetic in this trial. And the GFR was inclusion criteria was GFR more than 20 and to less than 45 with urine albumin creatinine ratio more than 200. The primary composite outcome was end-stage kidney disease, more than 40% sustained decline in GFR or renal cardiovascular death. Also shown positive results. Oops. So this is the Credence trial. As you see, it showed 30% decrease in the primary outcome, which is end-stage kidney disease and doubling of serum creatinine or renal cardiovascular death. This is the renal specific outcome, which showed about 30 hazard ratio of 66 with less.
2 minutes, Dr. Ali.
Huh?
2 minutes.
2 minutes, yes, I'm almost done. Also showed the there is decrease in the decline of GFR. We'll go to the summary of this slide here. So the summary of Credence trial was 30% decrease in cardiovascular death, about 34% decrease in the secondary outcome from end-stage kidney disease, doubling of serum creatinine. But what most important was that the canagliflozin attenuated the slope of chronic eGFR decline. That means less patient going hopefully to dialysis and end-stage kidney disease. This is the DAPA study, which showed that there is 39% relative risk reduction in the primary outcome with the use of dapagliflozin. And lastly, this is the empagliflozin trial, which showed also about 28% reduction in the primary outcome of chronic kidney disease. Important to mention this meta-analysis because it involved all the big, like 4 trials, and as you see that it's shown significant result that favor SGLT2 inhibitor in most of the kidney outcome, involving dialysis, end-stage kidney disease, or substantial loss of kidney function. The postulated, as we mentioned earlier, hypothesis behind that is maybe in diabetic there is increased hyperfiltration that put a big pressure on the renal cells, and the SGLT2 inhibitor does decrease that effect of or restore the tumor glomerular feedback mechanism. The major risk of SGLT2 inhibitor is maybe there is initial decline of GFR, but in the study showing that it maintained, or actually, as we've seen earlier, there is benefit in kidney disease. There is could be genital infection, UTI. I put possibly here because as you see in the measure, the trials, the UTI side effect was not significant change from the placebo. But the genital infection, where there was significant result on genital infection. To take from that is mainly advise the patient personal hygiene. From experience, if it happens, we treat with antibiotic or antifungal. But if it happened more than twice, you might consider to switch. On hypoglycemia, as you can see with monotherapy, is very minimal hypoglycemia, even as add-on to metformin. But when you add it to an insulin, the hypoglycemia does increase almost up to 50%. And what we advise patients, if the patient was well controlled, the recommendation may be to decrease insulin to 50%, or if he is on sulfonylurea, also decrease that by 50% and review blood sugar. But if the patient is not well controlled, you could continue with the current medications. So the last thing is what...
Time's up, Dr. Ali.
Okay, so...
We conclude.
Thank you so much. This is anyhow the last slide. So mainly now the American Diabetes Association recommend SGLT2 inhibitor with patients with chronic kidney disease, high risk of cardiovascular events, and have or chronic kidney disease. Thank you so much.
Thank you, Dr. Ali, for the nice and concise and updated presentation. Now, I will ask Prof. Faisal Shaheen to start his presentation. Professor Faisal Shaheen is well-known nephrologist in the country. He was the head of nephrology in King Fahd Hospital in Jeddah, and he was the founder and director of Jeddah Kidney Center till 2011. And in addition, he was the director of General Saudi Center for Organ Transplantation from 1993 till 2018. Currently, he's working in Dr. Suleiman Faqih Hospital as a senior consultant nephrologist and the head of nephrology department in Dr. Suleiman Faqih Hospital in Jeddah.
Thank you. Chairperson, thank you very much. I didn't find my talk, so probably you'll give me more extra time to find my talk if it is not here. Can someone help? Okay, thank you. First, I would like to thank the organizing committee for their kind invitations for me today. I am going to speak about one important issue which affecting the whole the country and probably worldwide as well. I'm going to speak about CKD and diabetic patients and the management and the new tools which we have it now as a nephrologist to help those patients having CKD in different stages. Globally, we have more than 500 million patients have diabetes, and 30% of them in any stage they will have CKD. And this problem is continuing to grow, and now the last statistics around 560 million, so it's almost around 9.7% of the total population of the world. So we have global problem. Probably it looks like epidemic of diabetes, and we should target how to control this diabetes before reaching to the end-stage renal disease. In Saudi Arabia, CKD is a common and it's very cost health problem in Saudi Arabia. The incidence of CKD, largely it is not known, but there is a sporadic report and in papers coming out from different area about the incidence, which almost it's come out to be 870 per million population. But the incidence of end-stage renal disease, which has been studied very well in different places like Medina, Jizan, Eastern region, estimated to be 100 to 150 per million populations. There is one epidemiological study done by our colleague, Dr. Abdul Karim Al-Suwaida and his colleague. It was in a center where he want to look for the prevalence of CKD in general population. But as you know that if we take it in a mall, it was in a mall actually. If it is in a mall, this means the healthy people usually go to the mall, not the sick people. That's why there is a little bit of bias around this study. But interestingly, that 7.1% of the chronic kidney disease patients were not aware about their problem. So this means that we have a lot of high incidence of CKD among us, and we don't know. And this is probably we need more screening. And the conclusion was to look further especially for the risk people and to investigate them. This slide is very important because this is a very old slide, but it shows to us that we are looking only in the tip of the iceberg, because we are looking for the end-stage CKD stage 5, dialysis patient, and the cost of the dialysis patient. But we have stages of chronic kidney disease, stage 1, 2, 3, and 4. All these stages, it need from us to look how to treat them and how to manage them and how to delay the progression of the kidney disease. This is a very old slide, But again, this is my own work, which I was looking carefully to all the populations in which have CKD. So you can see here that the patient stage 5 which have kidney failure is around 0.1% of the population. At that time, the number was 16,000. But if you look further, we take stage 1 and 2 and 3, the number is a huge number, which goes up to 2 to 3 million populations. So we have in the kingdom 1 in 10 suffer from some sort of CKD. It's not necessary to be end-stage renal disease, but it is one grade of chronic kidney disease. So all of us in one stage in his life, he will have some sort of chronic kidney disease. Very rare to have someone who had GFR when he is 80 years old of 100, no way. But at any stage, we will have some sort of CKD. Again, if we have CKD, this means that we have more problem. And what's the problem? Mainly, it is a cardiac problem. Usually, the CKD patient, either they are in dialysis or without dialysis, have high prevalence of cardiovascular disease. And here, you can see in this slide that if someone doesn't have diabetes and type 2 diabetes or CKD, the incidence of cardiovascular disease is 3.4%. And if he had diabetes type 2, the incidence of cardiovascular goes up to 6.7%. And if he had CKD alone, the incidence is 9.9%. If he had both CKD and type 2, the incidence of cardiovascular disease is 19.6. And by this means that he will have 6 higher-fold risk to have cardiac event in his life. Again, we have 2 elements to check and follow up our patient with type 2 diabetes and CKD. Is USR and EGFR. And probably some nation doesn't look carefully to these 2 elements, which give us how we can treat and prevent CKD and also prevent the end-stage renal disease. And this is USR and EGFR, and even in a very high standard countries like Netherlands, France, UK, USA, they don't look carefully to these 2 important elements which give us as a physician some tools to be treated and also prevent progression of the kidney disease. Now I'm coming to the main talk. What's happened in anyone who have CKD, who have diabetes? What's happened to him? He had 3 elements will affect his kidney. Either hemodynamically, this will affect the kidney, metabolic, this will affect the kidney, and some process which is known as inflammation and fibrosis. Inflammation and fibrosis, something which is take us from one stage to another very rapidly or slowly according to how we manage this. Hemodynamically, everyone knows that we are using ARB and AC inhibitors since 20 years, but yet we still doesn't have a good effect out of this, but this is our tools of management. The other thing is metabolic. The patients by metabolic causes, the diabetic patient will develop CKD. And for the hemodynamic, as I said, that we have ACE and ARB which can be used, and for metabolic, as we heard from Dr. Ali, we can give SGL2 and metformin. Both of them will help to decrease the incidence and the progression of kidney disease. But still, the untouched element in the progression of the disease is the inflammation and the process, and inflammation and fibrosis. So there is no existing treatment for such component, which I think one of the important components of progression of the kidney disease. I will not repeat what's been done by Dr. Ali now about the, just a short about some studies, like renal studies, which they were using losartan plus placebo, which showed that there is a regression of the progression of the disease, which is significant one, and but still, as you can see, that we have residual risk, which is important to look after this. And then we add, this is the renal study, look mainly about hemodynamic, and we have another study which is DABA CKD, is dapagliflozin versus placebo, and by this, again, this shows that still there is regression of the disease, but still we have a very residual risk factors. Here we come by the new things. Why we have such a progression of the disease? It seems that we have the problem again with the inflammation and fibrosis, and this is coming mainly due to very important factors which affections of mineralocorticoid and exacerbation of the mineralocorticoid will affect our kidney and will make progression of the heart and the kidney as well. And by this, a novel treatment, there is a drug which is known as finerenone. Finerenone will block the MRA overactivation, which cause fibrosis of the heart and the kidney. So finerenone, which is a new drug, will help us to target the third below of the causes of CKD and the progression of CKD, and also affecting the heart to decrease the fibrosis in both the heart and the kidney and decrease the incidence of cardiovascular diseases. So I will speak now about the phase 3 of finerenone, which is a new element for us and a new weapon for us to target the CKD progression. And this is just an example of any patient which we can see in our clinic, and in our clinic daily, probably 20 to 30% of our patients in nephrology having such a big problem. This is a patient is 66 years old, diagnosed with chronic kidney disease, type 2 diabetes, and for last 4 years, and CKD detected at the time of type 2 diagnosis. His blood sugar is 7.5, which is almost controlled, and he is a little bit overweight. BMI is 30.1 kg. His eGFR is 42 ml per minute, and USR is 410. His serum potassium is 4.4, and no signs of heart failure. And his LDL cholesterol is 50 milligram per deciliter, and his atorvastatin is 10 milligram. He had the maximum tolerated dose of AC and the standard care of diabetes. If we look to the patients, actually, this is the normal patient which we face every day, and we see him. But yet, you are controlling the blood sugar as the maximum. You give AC inhibitor as much as you can, but his urine albumin creatinine ratio is more than 300, which I said that it is very important to check urine albumin and creatinine ratio, and never forget in follow-up to do this. And his blood sugar, as I mentioned, is controlled. His blood pressure also controlled. Yet the patient still progressed to the other stages of CKD. So what to do with such patient? This is the common patient which we face in our clinic, and what we do. What the study shows to us, and as you see, we are going usually as an approach with KDIGO guideline, and KDIGO in 2020 they were recommend to have AC and ARB as maximum as you can, and to start to give SGL2 again. This is one of the important issue, and mineralocorticoid, they don't touch it at that time, 2020, and metformin, one of the tools, and GLB if SGL2 is not working.
2 minutes.
But in
2 minutes.
No way. I am yours. I am. So I think at least he should consider that I am his boss. And if he did that, I will return it back to him. So in Kidogo in 2022, they add a new things, which again very important, is MRA to prove non-steroidal MRA is very important to be added. And also they add that SGLT2 you can start it even if GFR is 25. So this is the two important changes. And ADA, American, again, guideline recommend against to add phenylenol to the treatment of CKD, MBD. And quickly I will mention about Fidelio studies and Figaro. Fidelio is people looking mainly to the kidney outcome, and they were late stage of kidney disease, stage 3 and 4, and Figaro was stage 1 and 2. And Fidelity is a study, is a statistical analysis which shows all the patients. So they were looking for all the stages, stage 1 to 4, and this means that they give us chance to use phenylenol very early when we have CKD. Just to be sure that you are choosing the good patients, and I have to go through here who is the patient to take phenylenol, which is the new tools to treat CKD due to the diabetes. The very important drug, which we are going to do it to start to prescribe it, and hopefully this one will lead to the regression of the kidney disease. We have to choose the patient which is more than 18. GFR is more than between 25 to 75, and tolerate the high maximum dose of AC and ARB, and they have albuminuria. Again, phenylenol showed that it decreased significantly the albumin, which we are as a nephrologist, we hate the albumin to see the albumin in the urine, and our target usually is to decrease the albuminuria, and phenylenol will help us to do that. And as you can see, the many studies which prove that phenylenol is a good drug, and it is not SGLT, and it is not competitive with SGLT. It is completely different. This is one tool and this is another tool. Combined tool is to help us again to decrease the disease regression. Again, I will not touch it, but quickly one of the side effects which people may think that hyperkalemia could happen. It is predictable, but it can be treated. And one of the things which we decide the dosage of phenylenol which is given, either to give 5 or 10. If it is increased or decreased, we manipulate according to the high potassium. It doesn't affect the blood sugar. It doesn't affect the blood pressure. So it is completely independent tools which we can treat our patients safely, and hopefully we can, by this new drug, we will help our patients to delay the regression of the chronic kidney disease. I want to just go quickly to my conclusion, so Fahmi will not be angry. This is, as I mentioned, Fidelity is a combined of statistical analysis, which again showed that phenylenol is a very good drug, can be used in any stage of kidney disease, stage 1, 2, 3, and 4. And again, one important is the reductions of the protein, which as all nephrologists know, that this will make a progression of the kidney disease. So I will conclude, Mr. Chairman, that the burden of cardiovascular disease is substantial in patients with CKD and type 2 diabetes. Despite existing treatment, persistent risk remains. There is a new focus in CKD and risk management across type 2 diabetes, cardiovascular, and CKD guideline. Phenylenol is a selective non-steroidal MRA, reduce the risk of CKD progression by 23%. And cardiovascular morbidity and mortality by 14% versus placebo in the largest trial program of patients with CKD and type 2 diabetes. Thank you very much.
Thank you, Professor. We really enjoyed your presentation, but unfortunately, we need to stick to the time.
Thank you, Prof. Our next speaker is Dr. Hani Shalabi. He's American Board of Internal Medicine and Endocrinology. He's consultant and chairman of Endocrinology and Diabetes Department at Faqiyah, and he's the Vice Dean of College of Medicine of University of Jeddah. Welcome, Dr. Hani. The floor is yours.
Assalamu alaikum wa rahmatullah. Good morning, everyone. So first, I would like to thank Novo Nordisk to sponsoring my talk. First, when they asked me to answer these questions about where does semaglutide fit, I thought maybe this is a big question. But honestly, I was busy thinking about other questions. Where is Messi? So it took us less, and it was a big question, but it took us less than a month to figure out that Messi is in the final. So I thought maybe the same will fit here. Like, maybe the answer is not that big. Maybe it's simple. This doesn't work. Okay. So I thought maybe let's answer it first. So even if the chairman wants me to finish earlier, I'll deliver my message first. So the answer is, yeah, start early. Most people with diabetes subgroups. So the answer for the questions, you can start as soon as possible for many of these patients. So if you agree with me, then maybe you can take a nap now. If you disagree, maybe I will take you through my answer, like why should we start early? I will divide it into three parts. Why should we start early? Why GLP in general? And then we'll talk about semaglutide specifically, why should we start it? So the why early. Maybe this is familiar for most of you that the patterns or how the natural history of diabetes, usually it doesn't start with the diagnosis. Usually it starts 10 years earlier. It will start with insulin resistance, with the metabolic changes, with the impaired fasting, glucose, the postprandials. Then 5 years also before the diagnosis when we start to have the insulin resistance and the prediabetes. If you can see that the micro and microvascular complications, actually it starts before the diagnosis. Like 5 or more than 5 years, patient will start to have some sort of the micro complications. This is another study also show how was the conventional treatment. Honestly, even like earlier, we didn't have a lot of tools to treat. So we start to use diet and exercise. Patient goes in the blue lines from 9 to suboptimal, still more than 7. Then you will add one more treatment, monotherapy. You start to titrate. Still the patient suboptimal. You can bring them down, but still they will be suboptimals. Where in the green lines, if you start with more aggressive, with multiple oral medications, if you need to use the injection insulin, you will keep the patient with the optimal treatment, which is, in most of the patients, will be A1C less than 7. But what's the consequence? What's the problem if I leave them more than 7? This is another study. It compares the patients who had A1C more than 7 with patients who had A1C less than 7. We can see that there was in the gray zone, that's the risk for complications. And here we are talking mainly about the microvascular complications, MI, stroke, heart failure, as well as the composite of cardiovascular events. In other studies, it showed the medical inertia, where we delayed the control of the blood sugars. Just for 1 year, if you leave the patients with A1C more than the target, which we assume usually most of the patients should be less than 7, you are increasing the risk of retinopathy, nephropathy by almost 20%, neuropathy as well as the microvascular that includes myocardial infarctions and stroke. And just more slides about the complications and why should we start earlier, that we saw it now in the guidelines. They are talking about the combinations, the cardio as well as the cardiorenal risk factors. Because we know, as Dr. Faisal mentioned earlier, that the prevalence of CKD is really high now, and also the heart failure. And once you get one, you will have some sort of the other complications. So it is interconnected, and we will see that's in the guidelines where they start to talk more about the cardiorenal risk. Now we will come to the second part, which is why GLP-1 agonist. And before we start, let's talk about why should we treat the patients, not just glycemic control. We are not sugaralistic, or we are not treating just glucose. We should treat all the risk factors or all the comorbidities. For example, in this study, where they control the blood sugars, where they manage the weight, control the blood pressure as well as the lipid profile, platelet inhibitions, not anymore for the primary preventions, but that was part of this study. We can see that in 2 years, the risk of mortality was decreased by almost the half. Survival increased by almost 8 years, as well as the time for the first cardiovascular events was delayed by almost 8 years. As well as we can see also the microvascular complication was decreased by almost 50%. So it is not just blood sugar controls, but also the other factors or other risk factors that we need to control. Let's take a look about the GLP-1 agonist and how it works. We know for now that the mechanism of action that it's glucose dependent, where it will increase the insulin, as well as also it will decrease the glucagon. And we know also that it works on the decreasing the appetite, decreasing the gastric emptying, and that's all lead to maybe some sort of weight loss, decreased blood glucose, decrease the lipid to some sort, as well as the blood pressure. And also there is a lot of studies about the inflammation and the progression for atherosclerosis. So just by looking at the mechanism of action, we can see that we can tackle most of these risk factors. And going back to why should we start early, this is another study. It showed the effect of GLP-1 agonist for according to when the patient was started on the GLP-1 agonist. And here we are talking about GLP-1 agonists in general, that we can see that the class 0 or 0 classes of GLP-1 agonists, the nearer they started the GLP-1 agonist, the higher the effect of the GLP-1 agonist. You could argue that that could be related to the higher A1C, but even when you go, the more you delay the start, the less the effect you will get. Some of the speculations about the pancreatic functions, beta cells, but the sooner, the better the effect that you can get. And again, now we are seeing the trend in almost most of the guidelines for diabetes talking about the holistic patient-centric approach. And that doesn't depend only on the medication for glycemic management, but you have to consider the other risk factors. Medications for weight management, for example, it become now part of the guidelines. Medications to optimize the cardiovascular risk factors as well as the cardiorenal risk factors. So let's see the guidelines. For example, the ADA last year or this year, we can see now, I will take you over this graph but let's see first. They're now talking head-to-head between the goals of cardiorenal risk factor reduction as well as the maintenance of glycemic and weight management. So now they are both equal. You have to consider the risk for cardiorenal as well as for the weight, especially for most of our type 2 diabetes patients are either obese or overweight. So if we go back to the cardiovascular risk factors, we can see that GLP-1 with proven cardiovascular benefits become head-to-head with the SGLT2 inhibitors. So you can choose as a first line, independent, and now, for the last few years, we were shy to say that or to take metformin from the first line. Now we started to see it more clearly that independent of the glycemic control, independent of the metformin, if you have established cardiovascular risk, cardiovascular disease or high risk for cardiovascular disease, you should consider GLP-1 agonists or SGLT2 inhibitors. Also in CKD, still SGLT2 inhibitors is the first choice for CKD patients or diabetic patients, but also you can consider GLP-1 agonists as a second after SGLT2 inhibitors for CKD patients. And that's regardless of the metformin, or if for the CKD, if the A1C is more than the target. When it comes also to the weight or the glycemic control, we can see that on the right side, for the glycemic control, dulaglutide and semaglutide, as well as the new tirzepatide, considered very high effective for glycemic control. When we are talking about the weight management, we can see also semaglutide was considered as very highly effective for weight management, also in diabetic patients. So we can see it in all of the scheme of the guidelines that GLP-1 agonists start to be part of the cornerstone for management. Now we will come to the third part. Why semaglutide? Again, just to take you over the semaglutide, we know it's one of the GLP-1 agonists that now it's available in the subcutaneous injection, as well as now we have it as an oral tablet. Both are working in the same mode of action. The pharmacological effect is achieved by both the daily oral medication as well as the subcutaneous injections. So is it effective for reduction of A1C? Is it like the other injection or other GLP-1 agonist? Most of the trials for the Pioneer, which was done for the semaglutide, oral semaglutide, in the higher dose, which is the 14 milligram, we can see in Pioneer 1, where was compared to diet and exercise, that it was highly effective. Of course, like every studies, they divided the patients with A1C less than 8, A1C more than 8, or A1C between 8 and 9. And we can see in the first Pioneer study that the A1C was way higher with the semaglutide oral and compared to placebo. Pioneer 2, when you compare it to empagliflozin, which is the SGLT2 inhibitors, when you add GLP-1 agonist, oral semaglutide, to metformin, and you compare it to the other group, which is metformin plus empagliflozin, again you achieved higher A1C reduction. Pioneer 3 was also to compare it when you combine it with the metformin and plus or minus sulfonylureas, and you combine it, you compare it to the sitagliptin, which is the DPP-4. We can see also that patients achieve higher A1C if you combine it with metformin and SGLT2 inhibitors in Pioneer 4. We can see also, and that was compared to another GLP-1 agonist, which is liraglutide. Again, we can see that the patients achieve higher A1C reduction. And no matter, like even if you combine it with, like in Pioneer 5, if you combine it with metformin plus sulfonylureas or insulin, you will achieve higher A1C reduction in compared to placebo. Pioneer 7, also that was like unique trials about which called semaglutide flex, where they tried to see the difference timing of the administrations. Also didn't affect the A1C reductions.
Dr. Han, 2 minutes.
Right. So what's about the weight reduction? Again, also in the Pioneer studies with the same combinations in compared to SGLT2 inhibitors, in compared to liraglutide, another GLP, also semaglutide, oral semaglutide was showing a better weight reduction. What's about the cardiovascular safety? There was a lot of talk about it. Sustain 6 was the injectable semaglutide. The Pioneer 6 was the oral semaglutide. it was designed the same. The only difference was the Pioneer 6 was shorter trial. So they have to end it earlier because they got the events, the 122 events. However, it showed non-inferiority, but it didn't show the superiority that we show it in Sustain 6. But with the meta-analysis, we can see that it's going toward the same line, which is in favor of semaglutide. Even when you combine it together, the Sustain 6 and Pioneer 6, we can see that it's almost the same. People also were worried, or actually we were worried about the actual life, like is patients going to be compliant? Are they going to get the same effect? This was real world data in US, and it showed that also with the 3 milligram, where was most of the patients, they achieved A1C reduction by less than minus 2.1. Other factors that you should consider it, patient preference mood. Also, this survey was done here in Saudi Arabia where it showed like 84% they preferred oral versus the injection. Of course, safety, it was safe. We know that it's low risk for hypoglycemia, and also it's simple dosing. Just you titrate every month until you reach your goal. So I hope by the end of this slide that I convince you that yes, we should start semaglutide in the selected patients, but as soon as possible to try to control the glycemic as well as the other cofactors. Thank you.
Thank you, Dr. Hani, for your concise talk. Our next speaker will be virtual, Dr. Ahmed Hassoun. He's a clinical professor of medicine at Dubai Medical College. He's a senior consultant endocrinologist and chairman of medicine at Faqih University Hospital in Dubai. Dr. Hassoun has participated in a lot of regional and international guidelines, and he was invited as a speaker to many local, regional, and international meetings. He finished his internal medicine, endocrinology, and at Brown University and the Mayo Clinic, respectively. Wish you very speedy recovery, Dr. Hassoun. Wish you if you have you here, and you may start now. Can we go to the virtual meeting?
ايه خلاص يا دكتور احمد دلوقتي اونلاين.
Can we have the slides?
اهلا دكتور احمد، شرفتنا والف سلام عليك.
Dr. Ahmed, can you hear us?
Yes, I can.
طيب دكتور عمار بيرحب في حضرتك
I can hear you.
you. طيب الحمد لله. دكتور عمار معلش ممكن
Can
ترحب
you hear
فيه
me?
بقى؟ احنا سامعين حضرتك يا فندم.
Yes, yes, Madam. Can we have the slides, please? You may start, Dr. Ahmed.
Yes, I can.
Open بقى the presentation لدكتور احمد. دكتور احمد ممكن تعمل شير السلايد؟ بيرحب بحضرتك
I can hear you.
طيب الحمد لله. دكتور عمار معلش ممكن احنا سامعين حضرتك يا فندم.
I cannot share my slides. Host disabled participant screen sharing. Can you hear me?
Yes, sure, Dr. Ahmed. We can hear you. We're just waiting for the slides. Yes, now we can see the slide. You may start, Dr. Ahmed.
Okay, I think if you can hear me, please let me know so I can start.
Dr. Ahmed, can you hear us?
Can you hear? Okay, I think I will start, but let me know if you are not hearing me, please. First, let me start by thanking the organizing committee for this exciting Congress to ask me to participate with you here from Dubai. Actually, I wished I was with you, but unfortunately I could not make it for a personal reason. And I'm going to cover in the coming 15 minutes or so an update on fatty liver and type 2 diabetes. I have nothing to disclose. I will try to come with some points about an introduction about the subjects, the relation between non-alcoholic fatty liver disease with diabetes, few points from the guidelines, presenting 2 cases, and leaving you with take-home messages. NAFLD, non-alcoholic fatty liver disease, we're going to say always NAFLD, is one of the most common causes of chronic liver disease in adults. To define it, we have to have hepatic steatosis, fat in the liver, whether it was found by imaging or by histology. In addition, we should have no causes of secondary hepatic accumulation due to, for example, significant alcohol or using some drugs that causes fatty liver or some other hereditary disorders related to fatty liver. This is the spectrum of NAFLD. We can start with NAFL, where we have only steatosis, and the more advanced one is NASH, non-alcoholic steatohepatitis, where we have, in addition to the steatosis, we have ballooning of the cells and inflammation, and that could progress further. We have more fibrosis in the process, leading to more advanced fibrosis with NASH and ending with cirrhosis and the complication of cirrhosis. The progression and the development is usually slow in most of the people, but in some other people, it's going to be fast, as you can see from this slide, starting about 25% having steatosis. About 1/3 of them actually will progress to NASH, and about 20% of those who progress to NASH will end with more fibrosis and leading to cirrhosis. And nothing to remember also, we have to remember also that in addition to this, we have increased prevalence in these people with hepatocellular carcinoma, as well as increased cardiovascular disease complication, and usually the death is from cardiovascular causes. The pathogenesis is simply related to our Western diet and lifestyle, mainly, and you can see here that the high calorie intake, excess saturated fat, high fructose and high refined sugars intake, sedentary behavior have led to the obesity and in turn to non-alcoholic fatty liver disease. Now, in addition to that, we have some genetic modifiers that has been identified. A minority of them have been studied very well, and these are two of them, PMPLA3 and TM6SF2. These are known to have higher liver content and increased risk of NASH as well as fibrosis and also cancer of the liver. In these people, it's not necessary to have features of insulin resistance. The risk of regression is really related to some of the important factors listed here: type 2 diabetes or prediabetes, age more than 50, higher BMI, more metabolic risk factors, and genetic factors that we mentioned just earlier. One of them is PMPLA3. The importance of this NAFLD is that it's very common, and you can see here from this global estimate, we have 25% overall globally. But more important, if you look at the other highlighted Middle East here, you can see that the Middle East, our region, having the highest of all other regions, including Europe and North America, estimated to be 32%. And another important point I would like to direct your attention, that NASH could lead to end-stage liver or cancer, hepatocellular carcinoma, and these people usually could go for liver transplantation. And because of the number, they are wait listed. And this graph A showing us the most common chronic liver disease etiologies and their proportion with regard of their etiology to the person who goes for wait list for the liver transplant. You can see CHC, which is hepatitis C chronic, is coming down while the NASH is increasing. More importantly, if we look at the proportion relative to that seen in 2002, you can see that the increment here is 24-fold for NASH, leading to wait listed for liver transplant, especially when they have the hepatocellular carcinoma. The relation with diabetes is important. This slide showing us that the prevalence of NAFLD among type 2 diabetes globally estimated to be 55.5%. And the more important part of this global map is to look at our region. Here is mentioned West Asia, and you can see West Asia is the highest of all regions, estimated to have 67.3% of people with type 2 diabetes having NAFLD. So it's much more common in people with type 2 diabetes. Another important factor here is in this study, which was done in the United States, looking into screening people in type 2 diabetes, where they go to outpatient clinic setting, whether it's primary care or endocrinology clinic, measuring their liver steatosis as well as liver fibrosis. A big study, about 561 in the total numbers. And when they looked at the screening, they found 70% of them, of this group of patients, having steatosis. And more importantly as well, is 21% of them have the prevalence of fibrosis. Another important part in the B part of this slide, you can see that the elevation of ALT or AST is only 10% or less when you look into these people who have already steatosis and fibrosis. So the liver enzyme transaminases are not much of help in majority of these patients. Even if you look at those in A who are having fibrosis stage F1, 2, 3, 4, 4 is advanced cirrhosis, you can see that the percent of proportion of the people who have high ALT and high AST, even in the moderate to advanced fibrosis group, the maximum is 28%. So the majority of patients, even with the fibrosis and advanced fibrosis, is even the majority having normal liver enzymes. Few points about the guidelines. It's important to know that we have some barriers to the optimal diagnosis because most of these patients are asymptomatic or having just a non-specific symptom such as fatigue. And also, as we mentioned earlier, many will have normal liver function tests and enzymes. And also there is at this time, no reliable diagnostic blood tests. For that reason, many trials have been looked into how we can screen and find these cases. And I highlighted for you the one in the red triangle those are important ones that used usually in this screening. For example, the NAFLD fibrosis score, or called NFS, excuse me, and FIB4, and also the ELF test, which has recently been used. This is the FIB4 index, and you can find it, by the way, in your iPhone or your Android. It can be downloaded, and you can measure here the prediction of advanced fibrosis in the liver using the age, ALT, AST, and platelets count. And there is a cut point, as you can see there, a score of less than 1.3, low risk, a score of more than 2.67 is high risk. And if you look at the NAFLD fibrosis score, NFS, you can see it's not much different in the criteria to measure, except for the addition of albumin, BMI, and presence of hyperglycemia. And again, down you can see the cut point for the scoring for low or for high prediction for fibrosis. Moving to the most recent guidelines, the American Diabetes Association in 2020 recommended that patients with type 2 diabetes or prediabetes and elevated liver enzymes or fatty liver on ultrasound should be evaluated for the presence of non-alcoholic steatohepatitis and liver fibrosis. More recently, again, the American Association of Clinical Endocrinologists this year actually have in their clinical practice guideline discussed this important NAFLD, and here they recommended in person with type 2 diabetes, clinician should consider screening for clinically significant fibrosis F2 to F4 using FIB4, even if they have normal liver enzymes. Another recommendation here is should further risk stratify persons with type 2 or type 1 with cardiometabolic risk factors and or elevated aminotransferases using the cut point here of 30 to use FIB4, elastography or fibroscan and or ELF test. I just want to show you, this is from the Italian group, their recommendation and the algorithm they use. I just highlighted for you that not only FIB4 they use, but also they use NFS. As you will see later in my cases, it's relevant in these patients sometimes. And this is what we call the elastography, transient. This is measuring the liver stiffness. And this is what we call the fibroscan, and we use it in our clinics. This is very important. I don't have time to discuss all the details of this practice guideline, but this is the reference down. You can see it published just this year, recently, and looking into NAFLD and the management for people who are in primary care and endocrinology clinical setting. This slide is important to focus on who are these people that you need to look into, the highest group for the development on NAFLD, prediabetes, or type 2 diabetes, obesity, or those high cardiometabolic risk factors, 2 or more, or those who have found by imaging they have hepatic steatosis or elevated liver enzyme. These should be studied well, taking history and physical examination, also to rule out secondary causes, as we mentioned earlier, that could cause fatty liver. When we reach to these people and found them, we need to look into how to prevent cardiovascular disease, because this is the most common cause of their death, but also to look into prevention of cirrhosis. And for the prevention of cardiovascular, as we all know, we need to focus into managing diabetes, obesity, hypertension, and dyslipidemia. With regard of the fibrosis risk stratification, I'm going to move to this slide here, focusing into the center where you use FIB4 index, and again, a cut point of low risk and high risk there, and the intermediate. Many of the indeterminate will be indeterminate risk. And for those indeterminate risk, it's recommended to have the liver stiffness measurement by elastography or fibroscan, or doing ELF blood test when it is available. Again, this will subtype them into low risk again, or high risk or indeterminate risk. And they are the cut points that we probably see in our cases there. I will take you to the indeterminate risk. Cut point is between FIB4 1.3 to 2.67, LSM fibroscan measurement for the stiffness 8 to 12, and for the ELF test 7.7 to 9.8. And you can imagine the higher and the lower, the higher is the high risk, the lower is the low risk. Now, for the indeterminate risk and high risk, it is recommended that we should refer to a liver specialist for additional studies and evaluation, and to be included in multidisciplinary team to prevent not only cirrhosis, but also cardiovascular disease.
2 minutes, Dr.
I would like to draw to your attention here to the management of diabetes in these people who have NAFLD. Now, in general, we have to achieve all the good goals for controlling the sugar using the medication that you probably already heard this before my lectures about the good drugs that help in coronary vascular disease, cardiovascular disease, or those who are good for CKD and heart failure. But I draw your attention down to the preferred diabetes pharmacotherapy. If somebody is in the lower risk, you can use, again, pioglitazone have shown beneficial effect, GLP-1 receptor agonist, and SGLT2. But if we move to the indeterminate risk, which is somewhat higher than the low risk, now we need to recommend using the medication that have shown efficacy in NASH, and these include pioglitazone or GLP-1 receptor agonist. Here we don't have, at this time, evidence for SGLT2 that improve NASH. If you move to the high-risk group, they strongly recommend that to use, again, the one that have shown evidence in NASH, again, the same pioglitazone GLP-1 receptor agonist, but in people with cirrhosis, we don't have any data to recommend. Now, with regard of the, I think I will move now to give you the cases because of the time. This is a first case. This is an Indian gentleman, 32-year-old with type 2 diabetes. I saw him in the clinic. He is obese. His BMI, you can see, almost 40. And these are the lab tests seen, the liver function, ILT and AST, both are elevated. Platelet count here, lipids profile shown here.
Dr. Ahmed,
his
1 minute
A1C
remaining.
is not perfect, 7 or almost 8%. So we did for him, we have already done an ultrasound for him, showed fatty liver, but then we jumped into doing the elastography or fibroscan. And you can see the number here. If you remember, we said up to 12 is indeterminate, more than 12 is high risk. So it was 19.4 kilopascal, his liver stiffness, which is very high. And if you look at that, the staging of him would be an early stage 4 for fibrosis. And retrospectively, if you look at the FIB4 in this case, and that's what's important I discussed about NFS, it was only low, 1.03, which is considered low. If you look at the NFS, it was minus 1.14, which is indeterminate in this case. And you can see from the other yellow rectangle I put for you, the high risk by definition. For this case, I highlighted liver stiffness measurement, which was more than 12. So this is really a high risk patient. So we recommended that this patient should see a liver specialist. Unfortunately, he was reluctant to do that and to go for biopsy, liver biopsy. And he decided to stay on our treatment, which we already started him on semaglutide in December of last year. And with that, he continued to have successful weight loss. He lost about 10% of his weight. And then he requested again, and we agreed with him to repeat the fibroscan after 10% of weight reduction. And you can see the result, his 19.4 liver stiffness became 9.1 kilopascal, more than half of the reduction. The second case is an Arabic gentleman, 58-year-old with type 2 diabetes, with hypertension and dyslipidemia, again obese with a BMI of 35.2. He also underwent the liver test function enzymes. Transaminases were elevated. The ALT, the AST is in the high normal range in our lab. Platelets count 294, lipid profile shown here. And also his A1C is not perfect, 7.9%. And when we looked at his FIB4, in this case, he was only again low, which was 0.71. And when we did the NFS, actually in this case, again, see the NFS is different here, showing it is actually high. And for that reason, we did for him the fibroscan, elastography, and shown here, as you can see, that his liver stiffness was 14.2, which is again more than 12, which is putting him at the high risk group. And for that reason, he was advised to see our liver specialist. Unfortunately, he was traveling soon after that, and he went to UK, where he went actually to see Cleveland Clinic London liver specialist there, where they did some testing, as you can see, which is not available everywhere, the ELF test, and showed to be 9.71 indeterminate risk, which is not in the high risk, unlike the fibroscan. And you can see that the normal level for indeterminate risk. And also they did a liver biopsy, as we wanted him to do, and that confirmed the presence of NASH, steatohepatitis, with bridging fibrosis, but fortunately there was no cirrhosis, and the fibrosis stage was 4. He continued to be on the same medication that we started him. He was on semaglutide, and as you know, semaglutide was coming out of stock in many of the countries in the world, I'm assuming including in your country as well. And for that reason, recently he was switched to tirzepatide, which we expect that it has similar effect, if not better, but we don't have the evidence yet.
Can you hear me, Doctor?
I would like to end with giving you some take-home messages. Non-alcoholic fatty liver disease is extremely common, especially in people with type 2 diabetes. People with type 2 diabetes are at the highest risk of development of NASH and fibrosis, even in the setting of normal plasma aminotransferase levels. Lifestyle modification, including diet, exercise, and weight loss, remain the most effective therapy and actually prevention for NAFLD. Screening for NASH in type 2, particularly in obese patients, should be encouraged, since only early intervention is likely to modify the natural history. And last but not least, as the rate of obesity and diabetes continue to increase, NAFLD, NASH, end-stage liver disease, hepatocellular carcinoma will bring a tremendous impact on healthcare in the upcoming years. It is a healthcare priority to increase awareness about non-alcoholic fatty liver disease. And with that, I would like to stop here. And thank you very much for listening.
Thank you, Dr. Ahmed. Now we have 10 minutes for the discussion. If anyone has any questions, you want to ask any one of the speakers. Well, I would like to ask Dr. Hani and the other team in that regard of NASH. Now we have 10 minutes for the discussion. If anyone has any questions, you want to ask anyone of the speakers. Now we have increasing evidence of the role of GLP-1 and NASH, and we have maybe in the coming year we might see it in the guideline. We have seen the 52 and 56 weeks trial on GLP in that regard as a treatment of steatohepatitis or NASH. Any insight which patient, for my practice, anyone with F2 and more fibrosis, I would refer him to endocrinology, yet we don't have any conclusion from the endocrinologist in that regard.
Of course, again, as Doctor just mentioned, any sort of, we have like NASH or NAFLD, we know that GLP-1 agonist is coming now strongly in this field. With the lifestyle modifications, with the GLP-1 agonists, with the weight reductions, we are seeing dramatic changes. So yeah, I would encourage every patient to be screened first, and then to be referred for first to lifestyle modifications plus GLP-1 agonists, especially with the semaglutide and all these coming drugs now. Yeah.
Thank you, Dr. Hani. Any question from the audience for any of the speakers?
Assalamu alaikum. My question to Dr. Faisal Shaheen. I enjoyed the presentation, but regarding the new medication, a promising medication, Veronone, have been also added to the congestive heart failure as the treatment for the edema and etc. So those patients or category of a renal patient they may have hyperkalemia. And as you know, in the compliance follow-up on our patient, they don't come for their appointments. So how are we going to make sure the hyperkalemia is the leading cause of death in those patients? Thank you.
Thank you, Dr. Saleh, for this excellent question. I think one of the important issues is how to choose your patient. We are choosing the patients before starting epinephrine, and if he's hyperkalemic, we exclude him. This is the first. Second, if his potassium is less than 5, this can be included, and we repeat the potassium in 1 month's time, and according to the dose, either he is in 10 or 20. If he is in 10, we continue. If the potassium is normal, if he is less than 5, we can increase to 20 and follow up again. So it is important to follow up the potassium, but if we notice from all the study that the potassium is not a big issue using epinephrine, because it is predictable, you can know it, and it is treatable. And if you wait for 72 hours, the potassium will come down again, and you can restart again the medication. So, and it is not fatal because no one have any death due to the hyperkalemia. If we compare it to another drug like aldactone or some AC sometime, which can cause hyperkalemia, this can be fatal in one instance, but in epinephrine it is not. Thank you.
Any other question?
Thank you very much for this elegant session. And my question to Professor Faisal Shaheen regarding the Flozine group, the DABA and EMBA group, the sodium glucose linked transporter 2 inhibitors. So my question is regarding the pathophysiological action of the Flozine group. Are they working through after excretion from the kidney or through perfusion into the kidney? And my question is directed regarding the GFR, target GFR, that we can use in our therapeutic approach. So they started with 45 ml per minute, and then it dropped to 30, and now they are talking to more than 20. And I predict in the future they may go down more than this, because I know that they are talking about dialysis patient to preserve the diuresis during the dialysis with those medication. So my question is directed, is it working through only excretion from the kidney or also through the blood supply? Thank you very much.
Thank you, Ahmed. I think it's a very important question as well, because once we use SGL2, like in DABA and study, you will notice that there is a rise a little bit in serum creatinine in the first 4 to 6 weeks. And this can be due to the diuretic effect. And again, we are controlling the blood sugar, which is important, the fluid, but it is noted that the creatinine, even if it is dropped, if it has become high and GFR become less, it returns back to normal for a long term. So this doesn't let us not too afraid about this. And by a trial, it noted that we can start use this drug when the GFR is less. So it is recommended now by KDICO is to go down with GFR less than up to 25. And as I agree with you that I think in the future we are going to use phenylalanine and SGL2 in a patient with IgA nephropathy, with the patient who start to have fibrosis. It's not yet. We need randomized study to prove that. But such a drug is important for the future. And I am sure that this will help a lot. So by controlling the blood sugar, by diuresis, this could help the patients, and the diuresis also will control the blood pressure as well, not only the blood sugar. And this will help in pathogenesis and to prevent the CKD progression.
If you allow me, Prof. Faisal, just to add, I mean, the GFR cut line was not for safety issues as more as efficacy issues. And that was also only for the glycemic control. We know that it's not going to be effective with the lower GFR, but with all these new benefits, we started to see lower and lower in the GFR because we know it's not a safety issue for that.
Agrees. Thanks, Hadi.
Thank you. Any other question from the audience? Right. Dr. Hani, do we still talking about superiority of subcut semaglutide in cardiovascular outcome? Do we stay talking about superiority of subcut over the oral in cardiovascular?
Yes, I mean, right now, we cannot say that the oral semaglutide is showing cardiovascular benefit. And that, if you give me the time, I would explain it more. But that was because for the oral semaglutide, it was shorter trial because the cardiovascular events, the target cardiovascular events reached, so they have to terminate the trials. However, it showed non-inferiority. They were in hurry just to show so they can market it in the market. So it showed non-inferiority. However, all the analysis, the subgroup analysis, it's going toward that it might have some cardiovascular benefits. But right now, we cannot say that it's cardiovascular protective, but at least no harm.
Thank you.
Dr.
Sakhar?
So is there any concern that using these drugs in a very wide range without long-term phase 3 studies that follow these patients might be a little bit risky? Thank you.
I mean, we know that diabetes itself, it will increase the risk of malignancy. However, almost most of the trials, it proved that there was no increased risk of malignancy. There was a new meta-analysis study about the thyroid cancer, which showed increased risk of malignancy, especially for thyroid. But there was a lot of questions about it. Is it because now we are more oriented about the thyroid? We are doing more screening for the thyroid, and that's how they picked all these patients. Also, when you go into the details of the studies, there's few points that it didn't make sense. That with the lower dose, there was higher risk. In compare with the higher exposure, there was less patients with thyroid malignancy. So till now, according to all the trials that was done in most of the GLP-1 agonists, no matter what kind of GLP-1 agonist, it didn't show any increased risk of malignancy. Do we need to do longer term trials? I got your points. I think we will get it most probably from the real world data, more than trials. Because I think to do a study like that, maybe you need more than 10 years to see if there is real risk for malignancy. Not anymore.
But do you think that if the patient takes this drug for 2-3 years and then she develops thyroid cancer, do you feel guilty or?
Actually, my patients are telling me about this risk. Most of the patients now, when you talk about GLP-1 agonists, they are asking about the thyroid malignancy. But at least from what we know right now, it was only in rats. Up to my knowledge, we don't have GLP-1 agonist receptors in the thyroid. So right now, I tell them there is no risk for malignancy.
Any other questions? I think by this we conclude our session. Thanks all speakers for the excellent presentation, and thanks all for listening.
Now it's our turn to thank all the speakers and the moderator for the great presentations, for their cooperation, dedication. I know because I'm the first one contact all the speakers. I know that we gave you a headache to present your presentation, prepare it and send it very early. Also the moderator, thanks for your cooperation and support. Now, again, I'm going to ask Dr. Ziad Al-Harbi to give a small trophy. We wish to be like a nice memory for our all presenter and moderator. Dr. Ziad Al-Harbi, Dr. صالح الحربي, تفضلوا.
السلام عليكم. يعطيكم العافية. Very nice presentation and discussion. So,
طيب احنا نبدأ بالتسلسل مع حفظ القامات. الدكتور هاني شلبي تفضل. الدكتور فيصل شاهين. الدكتور فهمي الظاهري. الدكتور عمار الدباغ.
Let's have 15 minutes break and we will be back 10:45 for the next session. Thank you.
اشتغل كده.
طيب بسم الله الرحمن الرحيم. Welcome back after the break. Dear colleagues, let's resume our Congress and let's start the second session with our great moderators, Dr. Ahmed Aql and Dr. Ala Darwish. Doctors, floor is yours.
Thank you very much. We will start our OncoHIM session. I have the honor to introduce Dr. Marwan Al-Hijli. He is board certified internal medicine, Him Onco from Lombardi Cancer Center, Washington, USA. He is also chief of internal medicine and onco in King Abdullah University Hospital. He will present a very interesting topic and advanced in gene therapy in oncology. تفضل دكتور مروان.
شكرا. Thank you so much. السلام عليكم. بسم الله والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه ومن. It's my pleasure and honor to be among you today and present to you a very important topic in the field of oncology, and hopefully we'll get some benefit after all for all of us. All right. So I'm going to speak about gene therapy in oncology, which is a new field, maybe not so new, but in the field of oncology itself, gene therapy is a new thing. This is a picture of Watson and Crick, the two pioneers who discovered the DNA in the 1950s. They won the Nobel Prize for that reason, and I think since then we have been discovering so many options of treatment in the field of medicine overall, and especially in the field of oncology as well. Well, what is gene therapy? Basically, gene therapy is a new era in the field of medicine, and the whole idea of gene therapy is to change the gene of a cell so it can function in a different way, most likely in a normal way rather than abnormal way. So the whole field has been going actually since the 50s. However, in the therapeutic part, still we are behind. Only in few diseases, maybe in pediatric diseases and hematology diseases, we have some treatment options. However, in other field of cancer of medicine, still we are behind. So how we can deliver, change the gene of a person? We have two ways of delivering or changing the gene of a person. One we call it conventional, and the other we call it gene editing. Basically, conventional way is when you have a virus who has a special gene, and you deliver that virus into a body or a human, and that virus will go in a special cells and try to incorporate its DNA into the human DNA and change the gene. If it's conventional, it's a random process. So the gene that the virus carry will go anywhere and change the gene in a different location of the DNA. Gene editing, it's a new novel method, and basically what it does, it goes to a specific DNA sequence and change a specific DNA or gene in the person or the human who are intended to have the gene change. When we say change the gene, there are two actually way of changing the gene. One is called germline gene therapy. And what it does is actually, I don't know if the laser, basically, if you see in the left side, the green side, we implement the gene therapy into the embryo, the fetus. And at that time, we change the whole gene of the fetus. And that's the practice, that was the direction that gene therapy was taking in the past. We go into the embryo in the fetus and we implement a gene therapy. We change the genome of the whole fetus. We call it germline. So, for example, let's say someone who has one of the genetic disorder as a pediatric genetic disorder, like Gaucher disease or something of the weird syndrome that we have in pediatrics. We incorporate a gene change into the whole embryo, and the fetus or the baby will come actually with a normal gene after delivery. The other one, which is more interesting and more difficult to do, but that's what we are planning to do in actually in cancer therapy, is actually somatic gene therapy. Somatic, it means just special tissue of the human. We go and for a normal adult person, and we implement the gene therapy, whether with a virus or any other process, and that gene therapy will go into specialized tissue, only one single tissue, for example, the tumor cells only, not the other cells, and implement the change over there, and afterward we will have maybe a normal tissue or a tissue that is non-cancerous or so on. The way we implement gene changes, we have two ways, okay? Look at the right side first, which is in vivo. In vivo, it means we inject the new gene delivery into the human itself, and whatever we inject, whether it's a virus or something that carry the new gene, will go to the tissue that has a problem and implement the changes over there. Ex vivo is actually, we take some human cells outside the body, like for example, the lymphocyte of a human or a T lymphocyte. We bring it to the lab, we take it just like we do with the blood donation, we do apheresis, we get the T cells, and then we implement the changes into the T cells itself. We inject the T cells with, for example, a virus that carry a new DNA, and we change the lymphocyte DNA, and then after that, we bring the DNA and infuse it into the human again. So that's the difference between in vivo and ex vivo. So one directly to the human, the other one with the cells outside the human body. The aims of the gene therapy, basically, to provide a functional gene copy of the damaged gene. So if someone carry any disease, or have a change, a mutation in the body that have abnormal function, we implement a new gene that replace the damaged gene and have a normal function. To increase the availability of disease-modifying gene, and to suppress the activity of a damaged gene. For example, if we have a gene that is so active inside a human body causing cancer cell to replicate, we put a new gene, a tumor suppressor gene, for example, to suppress that gene and kill the cell. So gene therapy can change the function and sometimes can also kill the cells if we want to do that. All right. So what is gene editing? Basically, gene editing is just to go and change certain gene. And there are so many ways to do that now, okay? We all know that the DNA or the chromosome are double helix, two chromosomes next to each other. What we do is we separate those two chromosomes, two DNA sequences from each other, and replace the gene in both chromosomes, okay? There are many ways to do that, and basically it depends on one single enzyme called nucleases. This nucleases family is huge, and we have so many, and usually they are very specific. And we implement those changes based on the nucleases activity, which I will show you in a minute. What is it? Okay. All right. So basically what you see here in the picture is true. It's just removing a piece of the DNA outside and putting a new one. And the nucleases enzymes that I told you about, there are 4 types of nuclease enzymes. I don't want to bother you with the names, but meganucleases is basically when we go into a large DNA sequence and change it. Zinc finger, it's a special process that we do. Transcriptional activator like nucleases, which is usually a DNA that is synthesized in the lab. It has a specialized sequence of smaller gene. And CRISPR, which is very famous. You will hear CRISPRs all the time now in treatment or in gene therapy. This is how it goes. As you see, they separate the 2 DNA. They implement a piece of a new gene into one of the DNA sequence, and then it will go back right and attach to each other again. This is the zinc finger process and how it does it. That's why I told you I'm not going to bother you with the procedure or the technology itself, but usually it's being done and for a long time so far now. And this is the tandem nuclease activity as well. All right. How we can use this gene therapy in cancer? We have different methods of using it in cancer. Maybe the most important one is oncolytic virotherapy. Oncolytic virotherapy, basically we have a specialized DNA. We implement it into a virus, and then we, with that gene, new gene, and then we implement it into the human body. It will go to the cancer cell, and once it reaches the cancer cells and the virus attach its DNA to the cancer cells, the cancer cell go into something like apoptosis or lysis or death, programmed cell death. That's oncolytic virotherapy. And then we have the immunotherapy, which I'll explain in a moment. And we have angiogenic therapy, suicide gene therapy. We have something with the RNA therapy, and we have also other procedure that we can do. So the oncolytic therapy, basically, as I explained earlier, is that virus carry the DNA, it goes to the cells, it activates a system inside the cell that causes apoptosis or death, and the cell will lyse. And this is one of the famous actually area in gene therapy. One of the DNA or the gene that we implement is actually the p53 gene, the famous p53 gene. We all know that the p53 gene is a tumor suppressor gene. So once that gene is active, it kills the cell. We all have it in our body, and usually it's active when we have an abnormal cell developing in our body. It gets activated, kill the cell, and get rid of it. We use this technology actually to treat cancer. So we have a specialized virus that go into a specialized cancer cell, implement the p53 in there, and kill that cancer cell. It sounds fancy and it sounds just amazing. Yes, it is, but still it's in the process. However, we have some treatment in that area now. Gendicine, which is one of the drugs. It's a Chinese drug, and actually it's been there since 2003. It has very few studies that was done, mainly in China. Unfortunately, the studies were not big enough, and that's why it's not actually everywhere. We don't see it everywhere. It's only in China. As you see, the studies are small. You're talking about 20 patients. So basically, they have this drug, and the study showed that it has a better response rate. It is used in head and neck cancer, mainly, and nasopharyngeal carcinoma. And if you see a response rate, it has a complete response rate of, in the first row, 60% compared to 22% when you don't use it, or if you use the standard therapy. So the numbers looks great, actually. However, so far, it's only approved in China, and the company that made the drug did not do a bigger study or include other countries, so it can be actually approved in other areas. But to tell you the truth, the numbers looks great, but they are very small. I wish to see a bigger study so we can implement this therapy in the future. So gendicine, that's one of the drugs. I think that's the most famous drug in that category. Okay, come to the second part, which is immunotherapy. What does it mean to do gene cell and immunotherapy? This is what we call CAR T-cell therapy. It's now one of the most treatment that the oncology part is actually invested in. It's CAR T-cell, basically we take the normal T-cell from a human body who has cancer, any specialized cancer, We take the normal cells outside, and we take some of the tumor cells outside the body. We try to create an antigen from the tumor cell, and we expose that antigen to find the DNA that is abnormal, and then inject the T cells with, or change the DNA of the T cells so it can become active against the tumor cells, as if we are programming the T cells to be active against the cancer. After we do all of that, we replicate the T cells, and then we infuse it inside the human body. So CAR T cells was started around the 2013, 2014. And now we have approval of 3 CAR T cells, and we have approval in lymphoma and myeloma. And most likely in the next year, we will have FDA approval for gastric cancer as well. The response is amazing. In the first study that was done in acute lymphoblastic leukemia in kids, out of 11 kids who were heavily pretreated, 9 of them had complete response, which was never heard of actually before that. So CAR T cell, it's an amazing technology. It requires a specialized lab to do the activation of the T cells. That's all what you need. And now in Saudi Arabia, we have 2 centers that are actually starting to do CAR T cell. For now, we bring the technology from Germany, but the lab itself, it will be established in Riyadh very soon. So CAR T cell, amazing result, mainly in hematological malignancy, but we have 1 study in gastric cancer, also heavily pretreated, that shows 60% response rate. So these are amazing, actually, results, and hopefully it will be more active soon. Just to remind you, it's called gene therapy, but this is another way of looking to gene therapy. So we don't inject the human with the gene therapy itself, no. We do it outside the body, and then we inject the cells into the human. We have gene silencing. Gene silencing, basically, the gene or the DNA, usually it creates a new RNA. Our RNA go to the lysosome, and RNA then create a protein. Gene silencing is actually active against the RNA itself. So as if the product of the DNA, which is RNA, we go and we suppress it. We prevent it from making the protein or the enzyme or the active cell receptor. So this is an interesting area. So far, we don't have drugs approved in that area, but it's an area that is being actually studied heavily for now. And suicide gene therapy, it's interesting, the name. We all know some of the oldest chemotherapy, 5-FU, that we use. So when we give 5-FU, the chemotherapy, it goes to all the cells and kill all the active cells in the body. So it kills the cancer cells as well as some of our active cells like bone marrow and GI normal cells. Suicide gene therapy, basically, we take the 5-FU itself and we implement it into a virus with a specialized DNA. That virus will go into the tumor cell only, and once it reaches the tumor cells, it activates the 5-FU into an active drug and starts killing within the cancer cell only. So it does deliver the chemotherapy to only the cancer cells and activate it over that area. It's also an area that has been actually now studied very well, and hopefully we will see few drugs in the future. So the whole goal is to do a specialized delivery to the tumor cells and to reduce the side effects. And also we have something called anti-tumor angiogenesis. Part of the cancer development is creating new blood vessels to supply all the tumor cells. So we call it angiogenesis, but it's only happen in the tumor cells. It can lead to tumor metastasis, growth, proliferation, and more invasion. We have drugs to prevent angiogenesis now. It's a monoclonal antibody. It goes and it suppresses angiogenesis, and actually it has a good result. The same idea is now being applied, but in a different way. Instead of having a drug, a monoclonal antibody, to go and suppress angiogenesis, we want to go to the gene in charge of angiogenesis and suppress that gene. Many drugs are actually being in the development, and there are some phase 2 and phase 3 trials actually now are ongoing. Well, this is some of the approved drugs in gene therapy. So I told you in the top is gendicine, which is approved only in China, and it's used in head and neck cancer. We have oncorine, which is similar to the gendicine, and also working in head and neck cancer, also approved in China. Chimera, which is a CAR T cell technology, and it's approved mainly in ALL, acute lymphoblastic leukemia. And as you see, it's ex vivo, it means outside the human body. We have Yescarta, which is another CAR T cell. And we have Emelgic, which is an HSV, and it's used in melanoma, approved only in Europe. And actually, it does oncolytic activity and also works in melanoma. So these are the drugs that we have so far. Maybe not a huge practice, but the CAR T cell, yes, it is a huge practice. But hopefully in the future, we'll have more and more. And with that, okay, I come to my conclusion. So gene therapy is promising treatment or field in the field of cancer. CAR T cell is evolving, and we have it now in Saudi Arabia, and hopefully we'll have more use of it in solid tumor. One thing I just want to bring out, we learn all of that from doing the genetic testing as a diagnostic part in all cancers. So that's why we all, as oncology, believe in molecular profiling for all tumors and learning more about the genetic of the tumor. So that area, we have to continue exploring the genetic profiling of all tumors, and hopefully in the future we'll have more drugs as well. And with that, I thank you.
Thank you very much, Dr. Marwan, for this elegant lecture. Thank you.
Now we are going to introduce Dr. Shamil Suaida. He is a lecturer and consultant of clinical oncology, Faculty of Medicine, Cairo University. He is a radiation oncology consultant at Dr. Sulaiman Faqih Hospital. Dr. Shamil will present a radiation oncology session in our conference, and he will talk about new technologies and update in radiation oncology.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning. It's quite a pleasure to join this first remarkable conference. And today we're going to talk about radiation oncology and the advances and updates. So it's going to be like a quick and specific tour into advances in radiotherapy. Hope it'll be interesting for you. So briefly and easily, let's talk about radiotherapy, because radiotherapy actually plays a huge role in cancer management. Like 50% of all the patients will have to receive radiotherapy once or more along the course of the treatment from cancer. So it's a technology-driven treatment modality in the management of cancer. And it can be used in several ways, either in a curative setting or palliative setting. Curative setting, it can be offered as a solo management, as in case, for example, of head and neck cancer, and also can be used intraoperative, neoadjuvant before or adjuvant after resection or systemic therapy, and it can also be used in organ preservation and in cases of larynx, breast, urinary bladder. In palliative setting, in like hemostatic to subbleeding, like in reducing bony pains and metastasis, so multiple uses actually. But first of all, let us discuss what is the goal of radiotherapy. The goal of radiotherapy is to maximize any tumor, by the way. It's a tumor surrounded by normal tissues. So we need to maximize the dose given to the tumor while minimizing the dose given to the normal surrounding tissues. That's increasing the tumor control probability while reducing the normal tissue complication probability. And all the techniques and all the advances in radiation therapy actually goes around this point. So we'll briefly discuss the high precision radiation therapy, which will need us to discuss the advances in treatment techniques, planning, tumor localization, the treatment planning, tumor localization in treatment delivery, adaptive radiotherapy, which is the state-of-the-art, and biological advances in tumor targeting. So the first step today is the advances in treatment techniques, which is state-of-the-art. Like we used to give radiotherapy in a 2D and a 3D conformal way, which simply use a trial and error approach. Means that in the planning, we specify certain fields, certain angles, certain volumes, and then we calculate it and see whichever plan is better than the other. But now actually with the advances, we're using inverse planning. Inverse planning is a very interesting issue, so because it's also plus our physics and radiation oncologists, technology plays a huge role here because we specify the dose and dose volume constraints of the tumor and the surrounding normal tissues, and then the computer system will help us to design the optimal treatment plan, and then we can choose from it. So in the past, IMRT was usually delivered using conventional LINAC. Let's go first before we discuss IMRT, because we shifted from the 3D conformal into the IMRT, intensely modulated radiation therapy, using inverse planning, and we'll discuss all of this later. And it was usually delivered using conventional LINAC with static field geometry, which means that the machine will go around the tumor at static stop and shoot, giving the radiotherapy at different angles to the tumor. But now we are using the IM80, which is arc therapy, intensely modulated arc therapy, using either the tomotherapy or the VMAT, according to the whichever system is being used, to deliver continuous radiotherapy in an arc form around the tumor. And these techniques made it possible to deliver different levels of dose to different parts of the tumor. For example, an hypoxic area in the tumor, and also it allowed us to use a simultaneous integrated boost, and we'll see it later in our applications in the talk, and the delivery of dose escalated conventionally fractionated or hypofractionated radiotherapy using IMRT techniques are now being utilized. So this is an image showing the 3D conformal radiation therapy. It's just static, large fields, no conformity of whatsoever. A huge area is delivered, and these are the old techniques, and sometimes used it till now in palliative radiation therapy. But then we move to the arc therapy, or the VMAT, or the tomotherapy, according to the system used again, where we can conform very well to the shape of the tumor. Not only the tumor, giving, for example, this breast case, and then a boost is given to the tumor bed. So we can deliver a certain dose to the whole breast, then we can deliver a boost dose to this tumor bed location, which is very highly specific and conformed treatment, which reduces, and that's the goal mainly, the side effects of normal tissues. And also this is an example of the VMAT. We discussed volumetric modulated arc therapy, which is a type of IM80. It shows here for the treatment plan of the prostate cancer, where we can give the regular dose, and we can boost again to the highly active, or the most active tumor parts inside the prostate. However, with all these high-tech new generations, the IM80 or arc therapy, the problem is that whenever you are going around the tumor, around the body, giving radiotherapy continuously, even if you are changing the field shapes and sizes, yet you are giving a lot of low-dose radiation therapy to the normal tissues, which will actually in some reports said there's an increase in risk of secondary malignancy from 1 to 1.75 along 15 to 20 years later in the patient's life. So from here came the idea about the stereotactic body radiotherapy, SBRT, which are capable of producing very conformal treatment plans with steep dose gradient outside the target, thus protecting the normal tissues outside from these low doses. And this is very important when treating critical organs like lesions besides the spinal cord, or when you are treating a previously irradiated patient with prior radiotherapy field, which you cannot overlap in this case. So the essential requirement of the stereotactic body radiotherapy are the accuracy of target delineation, which we'll discuss in tumor localization later, and implementation of inter and intrafraction tumor motion compensation strategies, and also the wider availability of in-room imaging and advanced treatment delivery systems. So at present, there are a variety of systems available for stereotactic body radiation therapy. Some of them are based on the initial LINAC gantry, like in the Versa HD, like in and others also are moved from this design to search for greater non-coplanar beam arrangement, like in the CyberKnife. So either we use the LINAC system or use new devices like the CyberKnife. So the local ablative capability of SBRT, and this is a nice part in it, it challenges surgery actually as a radical treatment instead of surgery, like in early cases of lung cancer, when you can give very specific high doses to a very early case of lung cancer, which can take place of surgery, actually, in these cases. So this is a view of a syntactic treatment plan delivered with CyberKnife, for example, as an for an early stage of small cell lung cancer. It is very specific, and look at the surrounding shadow of low doses. It's very limited. It's no more widespread along the whole chest. It is just around the tumor itself, while the high doses inside the tumor itself. So the next part in our talk will be about the particle therapy. We go through it very quickly because it's not just so widespread yet. The particle therapy, it simply depends on the Bragg peak effect, which I will show you later. The idea about particle therapy, like the most common is a proton therapy, is that these energies, whenever they go inside the body, they don't just keep going and then drop gradually with the energy inside, so irradiating along the track. No. These particles, whenever they get inside the body, they will deposit all the energy at a certain depth, then there is a steep downfall of the energy. I will show it to you later. And also there is proton therapy is the most common, and also there are now 10 facilities in the world using carbon therapy, which are particularly indicated in severely radio-resistant tumors. So this is a Bragg peak. The original photon beam, which you are using in the regular Linux, it shows it's the deposits, for example, the 6 MeV, maximum dose at 1.5 centimeters, then drops gradually inside the body. But actually in the proton it's totally different. It goes with a steady dose, low dose inside the body, then at a certain depth it deposits all the energy and then drops down steeply, which will be very helpful, for example, in a small tumor like in the eye, like besides the spinal cord, when it deposits at a certain depth and then it doesn't cross beyond this tumor into the body. So we get back to our original talks, advances in the treatment planning. We said going to treatment planning and delivery and tumor localizations, these are the main aspects. So the advances in treatment planning, it is all based upon one big word, it's a key word, which is imaging. Whenever you have proper imaging along the whole steps and integration of these images with new biological imaging like PET-CT, like MRI, structural imaging, so this now will have a great planning system. So all the technological advances have mainly been the result of integration of imaging information from simulation to planning to delivery. Sophisticated image registration and fusion algorithm help us actually to properly plan, and then I'll discuss how to properly deliver the treatment. This will lead also to accurate tumor localization for the treatment planning and adaptive radiation therapy. The advances in technology have led to an escalation of the prescription dose. Of course, whenever you can precisely hit a target while avoiding the normal tissues, then you will be tempted to increase the dose, which will be met by a better clinical result, while avoiding the normal tissues, of course. And also sometimes change in the fractionation schedule, which is actually a little bit like, which is coming now, because many of the cases like in prostate, like in breast, like in rectum, we are reducing hypofractionation, the number of radiation therapy, while increasing the dose per fraction, which proved to be equivalent to the old regular long course of radiation therapy. And this also is mainly based on the accuracy of the treatment delivery. Now, the tumor localizations, the treatment planning is very important. As we said, it is mainly based on fusion between the CT simulation. CT simulation is a CT we do to the patient to be the base on which we do the contouring, the planning, and everything. So we do a CT series, and then we make the plan over it. But we have to fuse this CT simulation with other more advanced imaging techniques, like an IMRT or positron emission tomography, PET-CT, where we can see the actual tumor and fuse it with the CT planning, and this fusion will be later on, as we will discuss, moved inside the treatment machine to implement on the patient. So tumor localization immediately before and during treatment delivery by means of image-guided techniques become a part of clinical practice and a fundamental prerequisite for high-precision radiation therapy. This is an example of using PET-CT in this lymph nodes in the treatment planning and delivery. So by the PET-CT, we know where is the most active tumor site. So for example, if the whole neck will receive like a 60 gray for high-risk areas, but the active tumor itself will receive a simultaneous integrated boost of 70 gray, which is the dose needed to kill this target. And also in these images of cancer larynx, this is a very high dose area, but again, the neck and the rest of the larynx have to receive a dose of like from 54 to 60 gray, but the disease itself, the active tumor, must receive a 70 gray, which is This is called the dose wash, the lower ones. How we distribute with this nice technology, how we can distribute all the dosing difference inside the tumor and outside it. Now we'll go to the tumor localization during the treatment delivery, which is a very important part. So we did a nice plan and everything looks fine, but how can we deliver this to the patient? So the increasingly conformal dose distributions that are possible with modern radiotherapy made it even more important that the patient position is the same from the simulation and during the treatment. So positioning is very important. And this high precision techniques combined with dose escalation, as we said, and hyperfractionation. The integration of radiological and metabolic imaging like MRI and PET, as we said, with the CT simulation done, provide useful information to accurately visualizing the tumor volume. Again, all these are nice. And several working groups now between radiation oncologists, there's always a difference. Should I contour this like this or is this like that? So several work groups actually made like different atlases so that it can be a little more like a guide for radiation oncologists. It's a worldwide practice. So this will get us to the image-guided radiation therapy. As we said, we did a very nice plan how to implement it on the patient. So image-guided radiation therapy, it simply uses multiple images before and during treatment to make sure that you are really targeting the tumor and not giving it and not mistreating this patient. Of all the soft tissue-based IGRT techniques, the cone beam CT is the most widely used. Directly before treatment, for example, the first session, we'll do a nice plan, everything is ready, and then we'll do the CBCT, which is a cone beam CT, a CT series taken on table with the patient on the machine, and then we'll make a fusion between the CT and the treatment plan. We'll make sure bony landmarks, soft tissues, tumor, everything is exactly as the plan we did, so we are doing before the treatment session itself. And to mitigate or decrease the effects of tumor motion due to respiration, for example, this is another very interesting issue. Because the tumor is either moving by itself inside the tumor, like in prostate, or it is moving because of the movement of the respiration, like in upper abdominal and lung tumors. So there are many ways how we can move around and detect these lesions, and so that we can give accurate radiation therapy. So this is image-guided radiation therapy. We'll discuss it shortly now. So IGRT didn't only make it possible to improve the accuracy of treatment, but also when we are doing regular imaging to the patient, we can detect any changes in the tumor size or in the patient's anatomy, like weight loss. This is called adaptive radiation therapy. We'll discuss it shortly. This is an example of a CBCT, cone beam CT before treatment, fused with the CT simulation. It is 4 quarters. We can move all around the picture, making sure that the bony landmarks, the soft tissues, everything is totally fused and coinciding between the CT planning and the CBCT. We'll go back to this very interesting part. What about the breathing? So we have breathing adaptive radiotherapy, which is a top-notch actually in the past few years, because real-time monitoring of the patient position significantly reduces intrafraction movement, movement during the radiotherapy fraction itself, due either to physiologic movement like the prostate or respiration like in tumors of the lung or upper abdomen. Several techniques have been proposed, like motion encompassing technique, respiratory gating, dynamic tumor tracking, and very briefly, motion encompassing techniques. You will know how much the prostate moves, for example, so you have to increase your internal target volume, then you're planning target volume, so you're not only treating the disease, you have to make a wide margin to encompass inside it the internal motion, but this will lead to a large PTV at the end, so a lot of normal tissues will be radiated. So the next step keeps the respiratory gating, either in breath-holding techniques or in free motion using detectors on the body to detect the phases of the respiration, and radiotherapy is delivered only at a certain phase of respiration, which coincides with how we did the plan also. And the most sophisticated is the dynamic tumor tracking. Now we are not just following the motion of the respiration, you are following the motion of the tumor itself by multiple imaging techniques on board of the treatment machine itself. Like the 2 systems, very common one, the robotic Linux, the CyberKnife, or the View, which use orthogonal gimbals, allowing pan and tilt rotation of the beam itself. So during the treatment, you are seeing the tumor and following with it all around the treatment session itself. Whenever there is movement of the tumor, again, not the chest wall, not like gating tumor, you will be following it with the radiotherapy field. For example, look at the lower one. This is a non-gated plan, a regular plan with a large margin. This is a gated plan when you follow the respiration by markers, for example, put on the chest of the patient. And this is a tracking. From each picture to the other one, you are reducing the field size, reducing the more concise high doses of the tumor, and reducing the lower doses around the tumor. Thus, your tumor control probability are high, normal tissue complication probability are very low.
Dr. Shamil, 1 minute more, huh?
Oh, okay. So adaptive radiation therapy, this is a very important one. During the radiotherapy, you're taking multiple images. You can know whenever the tumor is shrinking, whenever the patient is losing weight, so you can do re-imaging, replanning during the treatment itself, or you can adjust the delivered dose, or you can adaptation of the treatment strategy itself you are using, like adding chemotherapy, for example. This is a very nice topic, adaptive radiation therapy. Biological, of course, when using like sensitizers, like chemotherapy during the radiation therapy to improve how the cells will receive the radiotherapy, as well as there's actually a huge gap between many exciting ideas and actual clinical trials, like using T-cell checkpoints, hypoxic radiosensitizers, and anti-angiogenic agents, DNA repair inhibitors, all of these with radiotherapy. We're still, yeah, hopefully one day. So in conclusion, but I will need 1 minute of this conclusion, please. Radiotherapy has undergone tremendous progress over the years, and we must not forget that the multifaceted nature of this discipline makes an interface between physics, chemistry, biology, and medicine, not just medicine. And only by exploring all these aspects, we manage to produce individualized treatment radiotherapy with target delineation, avoidance normal tissue, dose escalation, dose fractionation, better prediction of treatment response. Now, give me just 1 minute. Because radiation therapy in Faqih has been for 4 decades now, from 1986 cobalt and deep X-ray, linear accelerator in 1990, variant 1998, variantology is the current advanced machine we have now, 2015. We are treating around 300 patients per year, new patients per year and rising, average daily 30 patients on the machine. And we provide a full spectrum of radiation therapy between radical, adjuvant, neoadjuvant, palliative radiation therapy, and also radiotherapy to benign cases like keloids. We have 2 cases, locally advanced, I will just a few of success stories, 2 cases, locally advanced nasopharyngeal carcinoma. I will show all the high techniques we are using in Faqih. Locally advanced nasopharyngeal are very challenging cases, especially when there is intracranial extension, bulky lymph nodes. So both of them are stage 4A. They received neoadjuvant, and although they are poorly differentiated or undifferentiated, they didn't respond. Usually these cases respond very nicely to neoadjuvant chemotherapy, but they didn't. I received the patients with bulky nodes or bulky nasopharyngeal. We gave them 60 gray to the whole areas as 70 gray boost, integrated boost to the tumor itself. And this is the PET-CT we used, and then how we make the plan and fuse the plan with the PET-CT to make sure we are giving the high dose. This is the 70 gray. And then the blue one is a 60 gray to cover the whole nasopharynx. This is how we use the fusion with the PET-CT. And this is the treatment plan, actually. Again, the lymph nodes, not only the nasopharynx. And we use 3-dimensional axial coronal sagittal sections for the planning, like you see. And this is a patient now, after 1 year, it is complete remission by PET-CT, total resolution of all the disease. And this is other case the same, but bulky lymph nodes in this case. And this one who did adaptive radiation therapy repeated the CT planning because there was weight loss in this patient. And also the same, this is using the PET-CT in the planning. And this one is a re-CT we did in the middle of the treatment as an adaptive radiation therapy. And then the patient in complete remission. This is physiological. Thank you very much. God bless you.
Thank you, Dr. Shamil, for excellent presentation overview, and also about the service we have in our hospital. Now I'm going to introduce Dr. Sakhra Abdallah. He is consultant medical oncology in Dr. Salman Faqih Hospital. He is also chairperson of oncology department, and he is American Board Internal Medicine certified. He is going today to talk about update in immunotherapy according to international guidelines. Welcome, Dr. Sakhr, and you can start your presentation.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى الطاهرين. Thank you for the introduction. So cancer is increasing all over the world. I chose a few countries from this interactive website. You can choose any country and you can see how is the cancer doing. So crude rate per 100,000 increasing, and incidence and mortality. Mortality is increasing also over the last like 30, 40, 50 years. So cancer is increasing. The sense of people that cancer is increasing is correct. A lot of reasons, but we're not there. We really understand some of it. So immunotherapy in cancer, New England Journal, 200 years anniversary. Two prominent, DeVita and Rosenberg, very famous oncologists, wrote a review article, and they said until 2012, mainly treating cancer was surgery, chemo, radiation, and they said now it's the era of immunotherapy. So immunotherapy includes vaccines, cytokines, small molecules, cell therapy, like Dr. Marwan talked about CAR T cell and other gene therapy. It's all in the field of immune therapy. We're going to talk today about immune checkpoint inhibitors. So the atmosphere around it's called around the tumor, it's called microenvironment. It's a very interactive atmosphere. So the T cell will try to attack the cancer. So it needs to be prompted and educated by other cells, like dendritic cells and other immune cells. So when this process is successful, you see at the green area where the cells clear the cancer. When it's not successful, tumor-induced immunosuppression. So the interaction between the T cell on the right-hand side with the tumor, it starts with the yellow box. First signal, interaction between T cell and the tumor, between the T cell receptor and MHC, major histocompatibility complex. This is on the tumor cell or the antigen presenting cell. After this interaction, the second signal, either it's a stimulatory signal where the T cell is stimulated to attack, or it's a suppressant signal. So above the signals that are stimulatory and below the signals that are inhibitory. So we're going to talk about the two inhibitory signals, which are the CTLA4 and PD1. These two interact with receptors on the other side, CD80, 86, and PDL1. So what's the importance of this interaction? This interaction is new. Before 1995, there was no mentioning of that. So two scientists, James Ellison and Tasuku Honcho, Japanese and American, James Ellison worked on the CTLA4 and discovered it and worked on it, and Honjo worked on the PD1, PDL1. They won Nobel Prize. The reason was for their discovery of cancer therapy, cancer therapy by inhibition of negative immune regulation. So as we said, there's immune regulation. It's negative by PD1, PDL1, and CTLA4, and its receptor CD80, 86. So this interaction, if we break it, then there will be no negative interaction, no suppression. So here the drugs come. So for PD1 inhibitors, we have about now, at the time of this slide, 5, but now more. PDL1 inhibition, we have 3, and CTLA4 inhibition, we have 2. So we'll talk about these drugs in the coming slides. So to understand immune therapy, new principles need to come in mind. What are these principles They are new in oncology. Before, like few years ago, 4 or 5 years ago, there was no mentioning of this. So it's really, it's a new oncology practice in the last 5 to 7 years. So we'll talk about PD-L1 staining. So we give a score, combined positive score. And sometimes we give tumor score only. So also, to understand immune therapy, you need to understand the mismatch repair proteins. So there are 4 important ones, MSH2 and MSH6. They make like a combination, and MLH1 and PMS2, they make a combination. These proteins are famous for the last like 30 years because they are the ones that are affected in Lynch syndrome patients. But up until the last few years, there was no mentioning for them in treatment. Now, MMR is mentioned, and you will see how many times I will mention it in the coming few minutes. So when you have mismatch repair functional, when there is DNA replication, it's corrected if there are mistakes and there are no mutations. If those proteins are dysfunctional, then you will accumulate mistakes in the DNA, and then you will accumulate mutations, and this will accumulate tumorigenesis, and we call it microsatellite instability high. These microsatellites are pieces of the DNA, and they show shortening during this dysfunction of proteins. We can test it. So it represents the end result of mismatch repair deficient proteins. Another principle you need to understand, which is also new in the last few years, tumor mutation burden. So they count 1,000 bases, and they see how many mutations. So it's the number of mutations in each megabase. And they stratify tumors according to how many mutations. So we find that melanoma, bladder, non-small cell lung cancer, endometrial cancer are the top ones. Other tumors have less TMB score. We give it a score. The score depends. It might be arbitrarily, they chose 10. But however, you see some studies that the benefit of immune therapy was when it's above like 15 or 20. The interaction between microsatellite instability, tumor mutation burden, and PD-L1 is complex. And they sometimes interact, they sometimes overlap, and they sometimes don't overlap. So it adds to the complexity of stratifying tumors. So all this is an introduction to how we use these drugs. So is this immune therapy functional, working? Does it change the life of patient? Yes. On the left-hand side, we see up until like 2010, 11, the expected survival for a melanoma patient. You can see that after 3 years, there's hardly like 5% alive. On the other side, you see after giving immune therapy, after 2 years, you have over 80%, 85% alive. So this is within 10 years only. This is not over like 100 years. So now we're going to quickly go overview on immune therapy in different cancers. We'll start with melanoma. So really, we didn't have any functional drug for melanoma up until 2011. And IL-2, I mean, it was used, but it was very harsh. Very few centers did it, and it was not practical. So starting 2011, ipilimumab, which works on the CTLA-4, was the first immune therapy in practice. And then after that, a lot of drugs. The blue ones are the immune therapy drugs. So between that time and now, you see how many drugs and combinations are approved. So now the favorable combination is the Nivo-Epi 2015. This is our favorite first line now. So in melanoma, we try to use immune therapy firsthand, even if there are mutations. About half of the melanoma has a driver mutation, usually BRAF mutation. About 45%. However, we prefer to use immunotherapy as first-hand usually. So this is about 7.5-year follow-up. This is one of the oldest studies in immunotherapy. And this is a follow-up in melanoma about using nivo and epi. I'm putting this to ask you to look. This is 5-year slide. Look at the tail. What we like in immunotherapy, we like the tail of the graph. The light blue graph, when you look at it, you see that if you survive, if you are one of those who respond and survive the first 2 years, you have a chance of being a very long survivor. And this is a malignant metastatic disease that used to kill people. So after 90 months, you have about 50% of the patients alive. About 8.5 years, you have 50%. So this is almost like, I mean, diabetes, we heard 2 hours ago, that if it's a bad diabetes, you might die from it within like 10 years. So we go to another skin cancer, just to refresh you a little bit and to believe in immune therapy. So squamous carcinoma of the skin. This is phase 2 of using Keytruda pembrolizumab, which is an immune therapy against PD-1. So look how first patient, all of them are elderly. The first patient at baseline, after 6 weeks only, just giving this immune therapy, which breaks the connection between PD-1 and PD-L1 and lets the T cell stay active. See how it attacks the cancer, and after like 35 weeks, this tumor is almost resolved. The other patient had a jaw squamous cancer, and again, after like less than a year, nice remission. Axillary, those are patients on this study. Look at this ear. So this is like really life-changing for those patients. I mean, it's not, here you're not talking about how long you're gonna live when you are 85, but at least you wanna live like the rest of your life, which is whatever, it's 2 months or 3 months or a year, like without oozing blood on your pillow every day. So this is like really impressive. So there's something also in immune therapy that is also new, which is agnostic approval of an immune therapy drug. Agnostic, it means it doesn't care what is the name of the cancer that you have. It looks at the genetic or mutation that you are treating. So the company used pembrolizumab in like a big phase 1 study used to search for so many cancers. And then what they found that in the blue, if you have high tumor mutation burden, that I mentioned to you, that you have high number of mutations per megabase of your DNA, then you have a better chance of responding to pembrolizumab. So in June 2020, FDA approved Pembro for the treatment of any cancer with high TMB. This study used TMB of 10 or above using foundation medicine test, genetic test. They could have used 11 or 12 or 13, but they chose 10. So we're following now. We send this test usually to our for our patients. Another approval that's agnostic, the same drug, Pembro, in mismatch repair deficient. So I mentioned to you that there is mismatch repair deficiency in some proteins that are dysfunctional. So any cancer that has this deficiency also can respond. So they gained approval for any drug, but this is an old approval in 2017. Any cancer that has deficiency in these proteins. Mainly, we see this in a large part was colorectal cancer. So now, in renal cell cancer, after success in melanoma, and after success in improving itself, the next step success was in renal cell carcinoma. So between 1992 and 2020, you can see that the main thing was really just tablets, sunitinib, temsirolimus, axitinib. These were like drugs that held the cancer at bay. But then starting in 2015, 16, 17, we started to see immunotherapy and combinations. So the best combination in 2018, Nivo and Epi, is like my favorite first-line treatment for metastatic renal cell carcinoma. Others can use some tablets. We call it tyrosine kinase inhibitors with immunotherapy. So the funny thing is, this is not a game. This is a real thing. So these are drugs in the left-hand side, different drugs or families of drugs that are approved. And then whatever you use as a first line, it dictates what you might use as second, third. Those patients might live for a long life, renal cell carcinoma. So imagine how many possibilities you might end up with in a renal cell cancer patient. Then we go to mismatch repair deficiency colorectal cancers. This is interesting. We know we talked about the agnostic approval of Pembro in cancers that are mismatch repair deficient and with high TMB, regardless where they are coming from. And I will mention a slide about using Pembro now, but this is using in second lines or later lines. What about first line using immuno in colorectal? This is Keynote 177. Another drug, it became a star a few months ago when there was a news about using it in rectal cancer. So, and it's called dostarlimab. Nivo-Epi also is used in later lines in colorectal cancer mismatch repair deficient. So this is a first line, metastatic colorectal, needs to be mismatch repair deficient, and we test it, as we told you. There's immunohistochemistry and there is sequencing. Whatever you choose. So this was Pembro versus the standard of care chemo, and it was a positive study. Progression-free survival, it was significant. Overall survival, it was significant, but it did not meet the specific criteria because there was a crossover. So Pembro became approved as a first line for these drugs. So you have a patient comes to you, you might give him immune instead of chemo, and you expect better results. The dostarlimab, this is the study that came in the news 6 months ago about using it rectal, and they had 14 patients in the study, here the data of 13, and when they gave this drug, they were expecting they will follow and then see if they do surgery and radiation and stratify. They were surprised. All the patients had complete remission. And for following them for 6 months, they are still in complete remission. So is this applicable to our patient with 10 patients, with a small study? If I have a patient like this, I might offer it to him. This is a nice study in the last few months. Again, they said metastatic colorectal, if you give them Nivo-Epi, only for 6 weeks before resection. So it's resectable but locally advanced. Nivo-Epi for 6 weeks only, 1 dose of Epi and 2 doses of Nivo. Take them to the OR. Amazing 67% complete remission. But we're talking about colorectal that is MMR, mismatch repair deficient, not all patients. Then we go to gastric esophageal GE junction. So in these tumors, we divide them into HER2 positive, similar to the breast, HER2 positive and HER2 negative. If you have HER2 positive, the study used Pembro on top of the standard of care. The study was positive. In the first, like 250 patients, interim analysis, it showed response rate was better, and it became now like standard, although we don't have the final results of overall survival. If you have HER2 negative, you have Nivo and added to the chemo, better than chemo alone, but not in all of them. We go back to the CPS, PD-L1 staining. If it's, as you see the red arrow, if it's less than 5, then it will not work. So it's approved for above 5. Pembro is approved for also for esophageal and esophageal junction, but the CPS, the PD-L1, needs to be above 10. So now you see how complicated it is becoming. Hepatocellular, as it's increasing with the obesity and NASH, so we are concerned about the systemic therapy. So for so many years, there was nothing for hepatocellular. Again, the sorafenib was not really doing anything. So in 2017, 18, 19, the last few years, things like exploded. And now our first line and preferred first line is Atezo and Bev, and we have been using it for 2-3 years. I have seen significant results with so many patients. And even when I stop the treatment, some people lose their insurance after 8-9 months. They still are doing very well. So the results for this overall survival, hazard ratio 0.6 for the combination of Atezo-Bev compared to standard. Recently, in the last few months, another approval for combination durvalumab, tremelimumab, again in hepatocellular, overall hazard ratio 0.7. And Nivo-Epi as a later line, if somebody in the past has used like oral TKI and then progressed, Nivo-Epi is a choice. Combination, it was approved, small study. So HCC is a competitive area now. So many studies using immune therapies now are ongoing. Triple negative breast cancer has not been very successful with immune therapy. Triple negative, if it's resectable, we need to give neoadjuvant chemo and then surgery. Adding Pembro to neoadjuvant chemo improved pathological complete response. And this was a positive study. Keytruda now, Pembro is standard of care in these patients. We can use it. Now in metastatic, first line, triple negative, so we can use chemo and add Pembro, and the study was positive, but in PD-L1 above 10%. Look at the red arrow. Below 10%, it's not. So if we have metastatic breast cancer triple negative, we have to send the tissue. So he's waving to me. I need probably to, I'm in the last 2 slides. So in urothelial, we have multiple approvals in all lines. In non-muscle invasive, we have in muscle invasive, we have in metastatic first line and later line. And we have maintenance after using chemo, avelumab. Head and neck, the good thing, if you have CPS above 20%, you can use Pembro alone. Metastatic head and neck, you can use immune therapy alone and better than chemo. For cervical and uterine, for second line, Lenvima and Pembro, after in uterine metastatic, they used chemo, it progressed. Lenvima or Pembro is approved and better than other lines of treatment. There was median overall survival, hazard ratio compared to standard of care 0.6. In cervical, first line cervical, this is important because it's practice changing. First line cervical, we're using chemo, adding to chemo, pembrolizumab, added to chemo, it improved survival. So overall survival, but not in all PDL1. PDL1 above 1% and above 10%. It worked. Below 1%, if you look at the red arrow, below 1%, there was no significance in overall survival. Non-small cell lung cancer, we prefer chemo. Just one, we prefer immuno firsthand. Just one thing, if you have PDL1 above 50%, you can use immuno alone in some patients. I have a patient, we started chemo, the PDL1 came back 90%. He had super aggressive disease. We switched to immuno, and he continued with immuno, and the disease is like in remission. We are multiple combinations. What our preferred combination is carbo, alimta plus pembro. So this is a new spectrum of adverse events. We are stimulating the immune system, so we are like rheumatologists now. When our patients come to us, we see eczema, we see uveitis. I have seen it. I have seen thyroiditis, hepatitis, enterocolitis, arthralgia, pruritus, myalgia, myositis. Some of them are serious. You have to be very fluent and comfortable in dealing with these side effects. Sometimes you have to use, when you have serious side effects, you have to use steroids, and sometimes you have to be able to use one of the drugs to suppress the immune system. So, finally, challenges, many challenges. Number one, testing for PDL1, MMR, TMB for any patient that comes to you. This is really challenging. The tissue, how much tissue do you have? The tissue is not enough to do all that. Cost of these tests, logistics of sending them and getting the results, cost of the drugs, and keeping up with the changing updates that are changing every month. Thank you for you, and thanks for our patience.
I would like to introduce our next speaker, Dr. Ramadan Saad. He is Associate Professor, Medical Physiology and Pathophysiology, originally from Faculty of Medicine, Ain Shams University, Egypt. Now he is a faculty staff in Faqih College for Medical Science since 6 years, and he is one of my best colleagues in the college. Thank you. تفضل دكتور سعد.
السلام عليكم. السلام عليكم. يس هو ده. هو بس حاجة أرابيك شوية صغيرة كده. هو أنا يعني من المرات القليلة إن أنا أبقى فيها more than 20 years وأنا في مجال التيتشنج، ولكن من المرات القليلة إن أنا أقف فيها أمام حضراتكم يعني في مؤتمرات. in spite of I have many publications ISI، ولكن فقيه كير is my home. فعشان كده أنا يعني والدكتور زياد الله يكرمه يعني صمم إن أنا أعمل presentation في هذا المؤتمر. فشكرا جزيلا. I would like to thank the organizing committee, especially Dr. Ziad and Dr. Abasant. I am physiology and pathophysiology. I'm not a clinician. كنت أتمنى أن أبقى clinician، ولكن بعد ما دخلت البيزك I proud إن أنا أبقى بيزك، إن أنا physiology and pathophysiology. أعتقد إن many of you, especially the Arabic students، ذكرياتهم مع البيزك أو الميموري of the basic is مش ذكريات حلوة أوي يعني. أعتقد ذكريات أليمة. في ال first year and second year due to the language barrier. Physiology and pathophysiology is very difficult for all students, especially in the first and second year. ولكن I think when you become a clinician, you discovered the value of the basic informations to explain many of the diseases or many of the disorders, I think. Now, I present a very, very important topic in our life, is the iron deficiency anemia. About 1/3 of the people in the Middle East have an iron deficiency anemia. This is very, very important. And I think in Saudi Arabia, it is not due to low iron intake. I think in Saudi Arabia, especially in the adolescents or children, due to the errors in nutrition, not due to low iron. I think that Saudi Arabia is not in this area. I think it is due to error in nutrition. Most of the students, most of the adolescents depend on the fast foods, and this is low in all nutritive materials, I think, and all of you, you know more than me. Anemia observed in 40% of the Saudi women. Many publications about the iron deficiency anemia, recent publications. This is one of them, 2019, done on the female undergraduate students in one of the Saudi colleges. About 35% have an iron deficiency anemia. Another one, I think it is the most recent one, and this is very important, 2022. Please concentrate in this. In children, about 40. Microcytic anemia, many causes, but a major cause of the microcytic anemia is the iron deficiency. Some basic information. Low iron, low heme, low hemoglobin. So the bone marrow will design a membrane on the new amount of hemoglobin. So the volume of the red blood cells will be decreased. So this is called microcytic anemia. The most common type of anemia, as you know, the blue column is the iron deficiency anemia. Another types of anemia, normocytic, macrocytic, aplastic, hemolytic, all of these rare in comparison to the iron deficiency anemia. Please look, this is a very, very, very excellent publications or excellent research or excellent study done in Saudi Arabia about 2022. This is also a new one, 2021. All of you know what are the causes of iron deficiency anemia. Pregnant women, I think that is an error in nutrition. I want to bypass this because all of you know this. Some basic information about the iron metabolism. The iron. About 2/3 of iron in your body, present in hemoglobin. The other, or the remaining part of hemoglobin, present in other tissues, like muscle, like liver, all. But 2/3 of your hemoglobin, of your iron, present out, used in the formation of hemoglobin. Can you know, can you guess, what is the actual number of hemoglobin molecule in a single red cell? Anyone know? Amount of hemoglobin molecules in each red cell. Can you know? Anyone, can you know? Amount of hemoglobin molecules in each red cell. Anyone know? No, anyone? Amount of hemoglobin molecules in each red blood cell is a very huge number. 250 million hemoglobin molecule in each red cell. 250 million. اعملوا زي ما انتوا عايزين، اصنعوا زي ما انتوا عايزين، ولكن ربنا بيدينا إشارة بيقول لنا لا، ربنا موجود، وربنا يعني كل اللي احنا بنعمله ده حاجات صغيرة قوي بجانب قدرة ربنا. ريد بلاد سيل اللي بتتشاف بالالكترون مايكروسكوبي بتتكبر قد ايه؟ بتحتوي او contain about 250 million molecule of hemoglobin. This is very important. Hemoglobin, 90% of iron coming from aged red cell. When the red cell, about after 20 days, the red cell will be destroyed by the macrophages or the liver and spleen, give the iron, and the iron recycled again to form the red blood cell. 10% of iron coming from your diet. 90% of the iron used in the formation of the red blood cell coming recycling. The iron absorbed mainly in the duodenum. And as you know, there's a very essential substances absorbed in the early part of the intestine. خلص ده very important. خلص في الديودنم، الله أعلم بالإيليوم والجيجينم ممكن يحصل إيه. Then the iron transported from the intestine to the blood by a special protein called ferroprotein. Transport iron from the intestine to the blood, and in the blood transported in a special protein called the transferrin. Transferrin carry iron to the liver, stored in the liver, combined with the apoferritin and the form ferritin. Ferritin is the storage form of iron in your liver. What is the actual requirements of iron in male and female? Who need more iron per day, male or female? You know? Who need more iron? You know? Male or female? Huh? Who need more iron per day? Male or female? Female. Female needs about 40 to 50 milligram per day. But the male about 10 milligram per day. And when you ask the students, why the female need more iron? First one, because of menstruation. What is the menstruation? What is this? All of the students, all of us, all of you, most of the residents, most of the small doctors. Why the female need more iron? Because iron, because of the menstruation. No. Why? Each month, the uterus of the female waiting a guest each month. If this guest come, these preparations in the uterus continue about 9 months. If the guest is not coming, these preparations will be lost in the form of menstruation. This is what happened. So why the female need more iron? Because there is a new tissues built up. Not a menstruation. Menstruation is the result of these new tissues built up. New tissues built up. Need more oxygen. So we need more red blood cells. So we need more heme. So we need more hemoglobin. So we need more iron. Because of the build up of tissues. So why female needs more iron? Not because of the menstruation. Because change this. Because the female, there is a new tissues build up every month. عشان دكتور أحمد هيقول لي دلوقتي فاضل دقيقتين عشان من إيه؟ This is a very important topic. This is my topic today. This is my very important topic today as we are in the oncology. In the oncology session. What is the difference between absolute and the functional iron deficiency? Absolute, all of you know the absolute iron deficiency. Low iron intake, low iron in your body, low iron stores. This is called absolute iron deficiency. There is no iron. There is a little iron in your body. So this is an absolute iron deficiency. What is the very, very important? Another one is a functional iron deficiency. The iron stores more than you. You are normal. But in this person, the iron stores more than you as a normal person. Because the iron trapped in the liver, trapped in the intestine. It's again, جوه, trapped in the liver, trapped in the intestine, and not allowed to pass out through the blood. So the bone marrow does not find the iron to form the heme or the red blood cells. What are the causes of this? This is called functional iron deficiency. What is the functional iron deficiency? In spite of the iron present in a huge amount, but the iron not allowed to pass out of these stores, out of the intestine, out of the liver, out of the spleen. So there is no iron for the bone marrow to form red blood cells. This is called functional iron deficiency. What is the cause of this functional iron deficiency? عشان دكتور أحمد خلاص أنا خلصت يا دكتور أحمد تمام. What is the cause of this iron deficiency? Many causes, but I will concentrate on the two causes of functional iron deficiency. Obese, especially obese male, not obese female. Female lucky in all. Female lucky. Little of disease is common in female, but many of the diseases common in in male. Why obesity is one of the causes of the functional iron deficiency? Why? Obesity, especially in male. Do you know the difference between obesity in male and female? Obesity in male is called android obesity. Obesity in female called gynoid obesity. Obesity in male, the fat concentrated in the abdomen. Obesity in female, the fat concentrated in the buttocks. Here, the fat press on the bone, and the bone can tolerate this pressure, no problem. But in male, the fat in the abdomen press on the liver, on the spleen, on the intestine, causing mild damage of these organs. And damage of these organs associated with inflammation. And the inflammation associated with more and more inflammatory markers, like interleukin 6, like tumor necrosis factor. All of these tumor markers stimulate the liver to produce a very, very important substance which is called hepcidin. And the hepcidin is the cause of trapping of iron in the intestine. Prevent the iron transport from the intestine to the blood. Prevent the iron release from the liver. Prevent the iron release from its stores. So, the cause of trapping of iron in case of inflammation is the very important substance which is called hepcidin. عمرنا شفنا واحد بيتعالج بأنتي انفلاماتوري لسه قاريها. الأنتي انفلاماتوري can correct iron deficiency. أنا مش كلينيشن بس أنا عندي بارامترز بقيس بيها 1 2 3. 1 زائد 1 يساوي 2. اديله ايرن، give oral iron. واحد عنده inflammatory، واحد عنده inflammation. Inflammation any side. Any type of inflammation. And has an iron deficiency. If you fault this patient by more and more iron, no benefit. Please treat the cause, treat the inflammation first. And no need to give him iron. I'm a basic, not a clinician. But I have a parameter. أنا بقيس عليها. Yes, this is the main cause of iron deficiency in case of obesity. But in female lucky have a gynoid obesity. So if you compare between obese male and the obese female, iron deficiency common in obese male because of this problem I said now. And this session is the last one. Yes. This session, the oncology, the same mechanism of iron deficiency, or one of the mechanisms of iron deficiency in cancer patient, also because cancer causing tissue damage, and also produce inflammation and produce inflammatory markers like interleukin 6. And the interleukin 6 tumor necrosis factor also release of hepcidin, and the hepcidin will trap iron and also cause functional iron deficiency. Cancer patients, when you take a chemotherapy, please, chemotherapy also cause more tissue damage. Chemotherapy treat another
2 minutes.
thing. Chemotherapy if needed. Yes, thanks, Dr. Ahmed. Chemotherapy treat the problem, the primary problem, but increase iron deficiency anemia, because chemotherapy will produce tissue damage, additional tissue damage. So, please, I'm not a clinician. I repeat this, ولكن أنا عندي parameters بقيس بيها. Please, for oncologists, try to give, if your cancer patients have iron deficiency, try to give intravenous iron, not oral iron. Oral iron is not benefit at all. Intravenous iron. Because if you give oral iron already trapped in the intestine because of the inflammation. Yes? Not allowed to pass to the blood. So there's no benefit from oral iron. So please, give him intravenous iron infusion. Ferric carboxy maltose, ferric inject. My colleague preferred this. I'm not a clinician. Please give him intravenous iron. Don't give oral iron. Oral iron, not benefit for this patient. Intravenous iron infusion is benefit for this patient, this cancer patient, because of one of the major mechanisms of iron deficiency in case of cancer is the functional iron deficiency due to release of more and more hepcidin. شكرا جزيلا. Thanks Dr. Ahmed على الإطالة.
شكرا جزيلا Dr. Ramadan for this elegant lecture and your stress on the iron trapping and functional iron deficiency. And now the panel is open for discussion. So please, anyone having a question, start. So until everyone is ready, I will start by the first question. And my question is directed to Dr. Marwan regarding gene therapy. Through the last years, gene therapy was the subject of many science fiction. Even I think the story of zombies started from a wrong gene therapy in the community and resulted in zombies. So from my perspective, I would like to ask about our recent experience, the global experience of COVID-19 vaccines. From your side and your perspective, do you consider the COVID-19 vaccine is a kind of gene therapy? And my second question, do you think after we are, because this is, you know, this is a common question in the community as well. After we took the vaccines, are we subjected to gene editing? So we can have mutations, we can have in the future cancer. So please start the question. Thank you very much.
Thank you so much. And this is an excellent question. And I think just like you asked the question to me, I always ask myself about that. I think just first of all, we have to know that as long as we have infections and we get exposed to pollution and everything, our DNA can change with time. That's why we get gray hair. That's why we had wrinkly skins. That's why we have all the damage that we have in our tissue is a genetic change. One of them, of course, is, and those genetic changes in the future can lead to cancer. Now, whatever virus we get, sometimes actually it can incorporate into our DNA. We know that very well with viruses like that has reverse transcriptase, like HIV, but also other viruses also can incorporate into our DNA. Now, the story of the zombies, yes, they think that because of the vaccine, people had developed some certain genetic changes and became zombies. With the vaccine, the COVID vaccine itself, it's actually an interesting technology, because usually we want the body to get exposed to a special antigen or protein and produce antibodies. With the COVID vaccine, what they did is actually, it's a different. All what they have is an RNA, and the RNA did not go to the DNA, did not change our gene. But that RNA went into the lysosome and led to creation of more antibodies, or either antibodies or gene or a protein that get exposure to create more antibodies in the future. But it did not go to the DNA. Now, one very important idea is just like we get exposed to in our life, it doesn't change all our DNA. It doesn't get incorporated into all the cells in our body. It actually go to a certain area and lead to the change, okay? So, and that's what I meant initially when I said that, like, we have germline genetic mutation that happens in embryo, and that can lead to the change in the whole DNA of the human being. And we have other somatic genetic changes, and that's what happens during our lifetime. So unlikely to have something that goes into all our cells and lead to a genetic change. So if I don't have hair because I'm bald, I cannot have just a genetic that goes into all our body and change my hair type or my color or my whatever you have. It doesn't. So that's the interesting part. Yes, and basically in cancer treatment, we focus in that area, that we can change the genetic in one area or one tissue, not all the body. But I hope that answered the question.
Thank you very much. Anyone having a question?
Assalamu alaikum. I can ask a question to Dr. Shamil and Dr. Sakhr based on what we have seen in your slides about the new techniques and new technology and new medication. I think it's still, we have to follow our patient maybe more and more to see if there is more or more long-term side effects that has been seen now with the previously used medication for the last decades, also for the new technology, because as we see most of these trials, they are recent and they don't have still long-term follow-up data. What do you think?
Well, regarding the new techniques of addition therapy, there are new techniques, but actually they have been out there for more than 20 years. So like VMAT and IMRT and all these new techniques and even SRS have been out for so long. So there are regular follow-up of cases worldwide and trials and everything. So they have proved to be safe actually, and actually they are trending to reduce the side effects more than increase them. And as we said, the use of the ARC therapy increased secondary malignancy after several years. That's why they progressed into the more confined treatment like SRS or SBRT. So it's evolving actually to more safer techniques rather than more dangerous techniques, because concising and reducing and protecting the normal tissues, this is the mainstay of all these technological advances. But yes, of course, changing in the dosing and the fractionation, these are the fields that will need longer follow-up more than the technological advances. What the technological advances led to, from higher doses and lesser fractions, this will need longer follow-up for sure, of course.
Bismillah. Actually, the immune therapy is a clean therapy. It just simulates your system to attack the problem. It's as clean as it gets. The problem is in the chemo that we have been using for like 40 years, which might cause a lot of side effects, including leukemias. It might cause cancer. But this immunotherapy is very clean, very nice. But it does, the problem, also one of the challenges that I didn't mention, although we have criteria to use it like PD-L1 and TMB and MMR, but about 40 to 50% of the patients do not benefit, and we lose them quickly in the first few months. So a lot of work now is on how to salvage these patients before we lose them. So this is the challenge. Once you survive the first 6 months with immunotherapy, you have a long chance of, and we have those patients. I mean, they are doing very well now without treatment. But the issue is losing them in the first few months, and a lot of research is doing there. Thank you.
شكرا يا جماعة. Thank you very much for our great presenter and great moderator. Now it's a time to thank our presenters. Really, I know that you had a hard time, especially with me, asking you many times for the CV presentation, صح? Thanks for all your contribution, your support, and your effort. And big thanks for our great moderators for moderate such a great session. Now let me ask Dr. Ziad Al-Harbi, the chairperson of the whole Congress, to come and give you some small trophy to be as a memory for the Congress and Basant Hidek. دكتور شامل اتفضل. حاسب يا فندم، انا خفت عليك بس. اتفضل. دكتور مروان اتفضل. دكتور رمضان اتفضل. understand that he started all the headache with us during the preparation and asking the speakers. يعني late according to our schedule. Let's have 30 minutes only for lunch and praying, and we will be back inshallah 1:15 بمشيئة الرحمن. We will have a very interesting session with the microorganism.
You mean 1:15, right? 1:15 after 30 minutes. Okay.
حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي من البيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصتي قدام جدتك؟ هذه أمك؟
اليوم أنا رايحة حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي من البيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي من البيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي من البيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي من البيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
ان شاء الله أمي.
قبل ما نلاحظ صار عمرك 18 سنة، خلصتي المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا لأنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة فحصت دم جدتك، هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
ان شاء الله أمي.
قبل ما نلاحظ صار عمرك 18 سنة، خلصتي المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا لأنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة فحصت دم جدتك، هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
ان شاء الله أمي.
قبل ما نلاحظ صار عمرك 18 سنة، خلصتي المدرسة وقلت إنك تبغي تصيري دكتورة لما تكبري. ما تفاجأنا لأنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة فحصت دم جدتك، هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله
قبل ما نلاحظ صار عمرك 18 سنة، خلصتي المدرسة وقلتي إنك تبغى تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله
قبل ما نلاحظ صار عمرك 18 سنة، خلصتي المدرسة وقلتي إنك تبغى تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله
قبل ما نلاحظ صار عمرك 18 سنة، خلصتي المدرسة وقلتي إنك تبغى تصيري دكتورة لما تكبري. ما تفاجأنا إنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغى تصيري دكتورة لما تكبري. ما تفاجأنا لأنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغى تصيري دكتورة لما تكبري. ما تفاجأنا لأنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي للبيت قبل سنوات. كانت أمي تقول لي إني كبرت بسرعة زي ما أنت كبرتي بسرعة.
إن شاء الله.
قبل ما نلاحظ صار عمرك 18 سنة، خلصت المدرسة وقلت إنك تبغى تصيري دكتورة لما تكبري. ما تفاجأنا لأنه ما شاء الله عليكي شاطرة في المدرسة.
عايشة، فحصت دم جدتك؟ هذه أمك؟
اليوم أنا رايحة نفس المستشفى اللي انولدنا فيها أنا وإنتي، المستشفى اللي انتي جالسة تتدربي فيها الآن عشان تصيري جراحة وبتعالجي جدتك.
كيف صرتي جدتي؟ الحمد لله.
ما صدق 3 أجيال تحت رعاية واحدة.
شو أبغى أكثر من كده؟
رعاية الأجيال. حبيبتي عايشة، للحين أتذكر اليوم اللي أخذتك فيه من البيت من مستشفى الدكتور سليمان فقيه، نفس ما أخذتني أمي من البيت قبل.
السلام عليكم. Assalamu alaikum. I'd like to welcome you to the afternoon session, the first session in the afternoon schedule. It's going to be about infectious diseases. Ms. Basant, can we go ahead? You have everything ready and a virtual attendance is already connected. طيب يلا, very good. أنا سمر بدر الدين, consultant infectious diseases, and I have with me my colleague Dr. Anouf Na'matullah, who is also consultant infectious disease. We both work in Dr. Suleiman Faqih Hospital. We're going to start by the first speaker. And I asked to introduce Dr. Batul Ali because Dr. Batul not only is a friend, an old friend for a long time, but Batul is probably the HIV person for the Western region. She is seeing the largest number of HIV patients in this part of the country. Batul graduated from King Abdulaziz University, went to Canada where she had her fellowship in infectious disease. Before that, she did residency in King Faisal Specialist Hospital, then Canada infectious diseases, then came back King Saud Hospital, and then now in East Jeddah Hospital. What do you call it, ya Batul, other than East Jeddah? هيك اسمه East Jeddah.
HIV Center.
HIV Center. She's now director of the HIV Center in the Western region, and she's a practicing physician. And she's going to give us some update about HIV. Where are we now? Go ahead, Dr. Batul, and thank you for honoring us by attendance today.
Many, many thanks to the organizing committee and Dr. Badruddin for inviting me today. And I hope that you are awake now after lunch. Any coffee? Because I need you to be awake. So, where we are now regarding HIV. First, I would love to know from the audience, like how many physicians we have. If you can raise your hands. Okay. And technician, nurses. Okay. So, do you think we have HIV? Do we have HIV cases? Do we have a lot of cases? Is it a small number? Is it a large one? Do we need to be ready? Are we in danger? All these things. I will go through it, but quickly. So I'm going to touch a bit about the global data and the local data, and then we'll go by the guideline, what's the first line, antiretroviral therapy, and then we'll go to the future with injectable agent, and finally, are we ready? So to start with, I will start with the global data from WHO by the end of 2021, which showed 38.4 million people living with HIV, and the people acquiring HIV globally by the end of 2021 is 1.5 million. Is it good? Is it bad? We'll see. To know if it's good or bad, we need to compare it to the previous data. If we compare it to the data on 2000, we can see that people living with HIV is 26 million and now 38.4 million. So it's really increasing. But this is good because of the good access to treatment and good antiretroviral therapy we have. So the people life expectancy with HIV, it's almost equal to the non-HIV. What about the number of new infections globally? If we compare 2000, it was 2.9 million, while on 2021, it's only 1.5 million. This is great. We did not achieve the 90-90-90, but at least it's less, which is 1.5 million. What about the AIDS-related death? It was 1.7 million, and by the end of 2021, it's 650,000. Again, this is very good. What about HIV in our region? I think we are the same like this guy who's hiding under the box. We still We cannot talk about it. People are afraid to come and even ask for testing. We're still having the stigma that's really affecting our patients. So we don't have a new data even for the Middle East and North Africa. The last one showing 240,000 people living with HIV, with new HIV infection 20,000. But what about the new infection? Globally, it's decreasing. But in the Middle East and North Africa, as you can see in the chart, the new HIV infection is increasing. What about in Saudi? I couldn't get any new data because it was not released from Ministry of Health, but at least the number of people living with HIV by the end of 2018 in Saudi Arabia, as you can see, the graph is going up. What about, what is the largest population? Jeddah. We are the largest. Those data was on June 2018, and you can see that Jeddah contribute to a major number, almost like 70 to 60% of the total people living with HIV, followed by Riyadh and then Dammam. And if we analyze the cause of HIV based on Ministry of Health data, we can find that 26% of the new infection was suspected because of sign and symptom, and that's mean AIDS-defining condition. Still, we are seeing AIDS-defining condition. What about in East Jeddah Hospital in the HIV center? If we compare the data from 2019 until now, you can see the total number of HIV new infection was 194, and then it was dropped down because of COVID and the lockdown. No people is coming to hospital. And then lastly, in 2022, those data, 300 new HIV infection until October only. So you can see that we are almost doubling our numbers for the new infection. So how we can end this epidemic, if we can? Do you think we can end the epidemic? I think we need to focus on two pillars. We are happy with the treatment. Yes, we have a new treatment, new drugs, injectable agent, but what about prevention? We are not doing anything regarding prevention, actually. We need to increase the awareness. We need to distribute condoms. We need to have sexual education. We need to start PrEP clinic for infectious disease. So are we doing this? No, unfortunately, and that's why we'll continue the HIV to spread. If we move to the antiretroviral therapy and what we have and what we don't, actually based on the international guideline globally, DHHS, IAS, EACS, WHO, all of them recommend to start antiretroviral therapy regardless of CD4 or viral load, plus integrase inhibitor have been agreed upon to be the first drugs to start with, or the first group, which, as you can see, we have bictegravir, dolutegravir in all the guideline, and in addition to that, in the European guideline, they add also doravirine and raltegravir. The most interesting things is that most of the medication have been co-formulated in one single tablet per day. This is one of the drugs that have been approved, which is bictegravir. It's a single tablet. It has a high genetic barrier. It has a less side effect on bone and lipids and less drug-drug interaction. And it can be given also not only for HIV, also for HIV with hepatitis B co-infection. And actually, the approval has been done based on studies that has been done for years, called 148.9 and 1490, and the data have been studied for 5 years, and the outcome was that 99% of people who have been adherent to treatment have a viral load suppression less than 50. This is called Dovato, which is a bi, that's mean only 2 in 1, which is dolutegravir lamivudine, And it's an excellent drug, has been shown based on many studies and also real-world data. The advantage of this drug is that it's also a single pill, but two combination, less side effect, less drug-drug interaction, and the only thing, it should not be given to patient with viral load more than 500,000 and CD4 not preferable if it's less than 200. And those are the data that based on it, those medication has been proven. Triumic, again, it's a dolutegravir-based regimen, but with abacavir. So for this medication, again, it's co-formulated in one single tablet. It's given once daily. You need to have the HLA-5701 test to be negative, and you need to have that hepatitis B is supposed to be non-reactive. Plus, in this medication, if you want to start patient on, you need to calculate the risk for cardiovascular disease. This is Genvoya, which is 4-in-1. That's mean 4 medication in one drugs, and it's called elvitegravir. It's a low genetic barrier with many drug-drug interaction because of the cobicistat component of this medication. Again, it's a single tablet. It has been used for many years now. It has an excellent outcome in viral suppression. All of those medications are one single tablet. The common problem with this group, integrase inhibitor, is weight gain. Most of the patients have been suffering from weight gain. So that's why this study have been studying doravirine-based regimen, which is an NNRTI, in a study called DOIT study versus darunavir, which is a protease inhibitor, in a study called DEFINE, to see if switching those patients on integrase inhibitor will affect the weight gain. So, from all those medications, why should I choose, or which drug should I choose? It's supposed to be a single, potent, safe, tolerable, easy to adhere by the patient, less side effect, and less drug-drug interaction, isn't it? So this is the thing I want to take if I will be an HIV patient. This is what we have right now. What about the long-acting injectable HIV treatment? We have one regimen that has been approved by the FDA on February 2022 called captogravir rilpivirine, which is again an integrase inhibitor with an NNRTI. It's a complete injectable regimen that can be given monthly or Q2 month. It can be given as an IM in the gluteal region commonly, and plus the good thing finally that it can be started without for patient without being suppressed. And now there are many studies seeing that if the patient can give this injection to themselves also. And the approval was based on ATLAS and FLAIR study in experienced and naive patient, 1-to-1 randomized with non-inferiority for injectable versus the current antiretroviral therapy. What about the future? So Q2 month was not enough, actually. So the future long-acting injectable agent called lenacapavir, it's a novel class. It's a capsid inhibitor that prevent the multiplication of the virus in many levels. And the basal of this study, or the most common study that have been for this drug, is Capella and Calibrata, and again, it's on naive and experienced patients. The good thing about this drug, it's supposed to be given every 6 months. It's subcutaneous, so it can be given by the patient themselves. But the disadvantage so far that it needs to be given with other antiretroviral therapy, and still it's not approved yet. Long-acting oral therapy. We discussed the injectable, we'll move to the oral therapy. There is a drug called islatravir. Islatravir is a first-in-class nucleoside reverse transcriptase translocation inhibitor. It has a very prolonged half-life, around 50 to 60 hours, so it can be given once weekly. It has been now co-formulated with doravirine in one tablet to be given once daily, or with lenacapavir orally to be given once weekly. Still, it's not approved by FDA. Another oral medication that can be given orally for once weekly called MK8507, which is a novel oral potent NNRTI that's still under investigation. What do we have also? Intravenous for antiretroviral therapy. We have a large class called broadly neutralizing antibody against HIV-1. It's under trial for treatment, for prevention, and also under trial for vaccination. The commonest of these classes, VRC01 and VRC07, and still it's under investigation, but it's showing really a promising data. What the future carry more? We have a micropatch transcutaneous with TAF. We have a new implant technology also. The most interesting is the gastric reservoir that can be taken orally, and the antiretroviral will be released in the stomach for 2 weeks. So what we have been learned? First, integrase inhibitor is the first globally, and it's one of the most effective in viral suppression and excellent if patients adhere to it. Second, the long-acting antiretroviral therapy, it continues to show a high efficacy in viral suppression and will have more and more, but in danger. This have been announced by UNAIDS on June 2022. Are we in danger? Are we in danger? I think yes. What about those on the other side? Are we in danger? If we're still not talking about HIV, if we will not still educating our new generation about HIV, if we'll not distribute condoms, if we'll not have PrEP, I think the number will be more and more. So are we ready now to end the epidemic? I think no. I'm worried about increasing the epidemic, increasing the spread of HIV as long we are not talking about it, and we're still looking in a different way, like an HIV person is a monster that will not treat him, I will not teach him. I don't want to talk with him even. I don't want to let him work in my place, no. So it will continue to spread more and more if we'll not work on this. Thank you very much.
Thank you, Dr. Batul. We're going to leave the questions till the end of the 4 speakers. I myself have a few questions for you. So let's welcome our next speaker, Dr. Anouf.
So our next speaker, Dr. Muna Al-Faris. She's an American board-certified internal medicine and infectious disease. She did transplant and oncology postdoctoral fellowship in infectious disease from Johns Hopkins University and is currently working as a consultant at King Abdulaziz University Hospital and at DSF FMH, right? MC, part-time. Welcome, Dr. Al-Faris. The floor is yours.
Thank you. Thank you for your introduction.
Well, so
شو اللي talk about tuberculosis was update in the management. أهلا دكتور منى شرفتينا.
أهلا وسهلا. السلام عليكم. طيب, today we're going to talk about what's new in management of TB. As we know, in Saudi Arabia, we are known to have endemic TB cases, and we're still seeing this problem on and on. And it's biggest concern for the WHO, especially for the regions that has endemic TB. So 1 in every 4, so 25% of the world population will demonstrate an immunological response to MTB infection when they're exposed to. Some of them will keep it dormant, and the others will keep it, will activate into TB at that time or later on in their life. So the chances for a person who has a latent TB could switch to positive 5 to 10%. And there was a study done in 2019. They estimated around 10 million new incident cases of active TB worldwide. So what does effective anti-TB therapy depends on? The first thing is the prompt diagnosis, and immediately we should interfere with the patient who come with symptoms suggesting of TB, especially if they're known to be in an endemic area in the Middle East, Asia, Africa. We are more higher than the Western regions. and also to know the drug resistant for those for the MTB, and also the adherence to the regimen, which is sometimes a problem here in Saudi Arabia because most of the patients, they fall into the crack and they never continue the full therapy and they come back again with reactivation or untreated, effectively treated TB. So we go into that concern. And also the other thing is to trace the latent TB patients and identify the risk factor. Are they a risk factor for developing active TB in their life, and shall we give them a prophylaxis treatment or no? So how do you diagnose TB? As we all know, the sputum AFB culture is the first thing to diagnose. We do, but the problem with the AFB, it depends on the person who's doing the smear. So some of them can read it +1, some of them can read it +2. So it helps, but it's not very like accurate in that thing. And also we have the molecular testing, which is the gene expert we've been using now in Saudi Arabia. It comes immediately, we'll get the results, and it shows you that it has positive PCR for MTB and can identify some resistant, can tell you there is no rifampicin resistant mainly. So the problem is with the TB is the drug resistant. As I mentioned before, most of the patients don't adhere to their long course therapy, and some of them develop side effects, so they switch between drugs. For their chances of developing that is a problem. So there is a lot of new medications that's been updated to cover mainly the XDR-TB, which is the multi-drug resistant tuberculosis. And also they updated the terminology. If we remember, we have the drug-sensitive TB, then rifampicin resistant TB, then we have the MDR, the multi-drug resistant TB, then we have the XDR, which is more resistant, especially to certain group A medication like the fluoroquinolones. So now they call it the pre-XDR. So this is the medications that we usually use and their side effects. We're all familiar with rifampicin, isoniazid, pyrazinamide, ethambutol. Those are like the standard of care. Then we have also levo and moxie can be added. And then we have other options for IV in the cases of XDR or MDR tuberculosis. And what are the latest guidelines? It didn't change in the last couple of years, but it's by the American Thoracic Society and the CDC and the IDSA. They recommend for rifampicin-resistant TB to treat as per MDR guidelines. And for the INH-resistant TB, there will be a little bit of changes, but they're still focusing on the 6-month duration and can be extended depending on the severity of the disease or the extrapulmonary manifestation. So the MDR TB, we have the first line, second line, and third line, which will use a couple of this medication in combination and depends on how the patient can tolerate this combination. There is a couple of around like 14 to 17 drugs now are in development. We have couple as phase 1, we have couple in phase 2, and we have like these 3 drugs. One of them was approved in 2019, are from phase 3 to approval already, with a very promising results. And also the one in phase 2, the Telisipec, is also being approved recently. So they approved this, the pretonomide, in 2019. It's very good medication per the studies, and it works by inducing the bacterial cell death by inhibiting the MTB cytochrome. So that is responsible for the ATP synthesis. And the routes of delivery. So it's not a novel idea that they try to deliver the anti-TB through, like, for example, inhalation. But the problem is it was really toxic and increasing the side effects for the lung, which is not fully functioning with the disease itself when it's full of cavities or disseminated TB. So some of them published potential inhalation therapy to try to augment, not to take over, the P or IV option, but there is no data so far like promising. So the drug-sensitive TB. Now the recommendation is to give a 4-month shorter regimen with rifampicin in combination with moxi. Has been recently shown non-inferiority to the current standard of 6-month regimen with the INH. Okay, and another shorter 2-month regimen in the Trunculate trial also gave non-inferiority compared to the 8 weeks and potential like 12 weeks, like 3 months. So the 2 months was similar to the like 3 months. So they recommend now mainly the 4-month for the drug sensitive. Those are a couple of the new drug regimen under evaluation study. We have the REDEFINE study talking about higher doses of rifampicin in the treatment and how can the patient tolerate which maximum dose and for which duration. And there is the other one assessing the 6-month therapy for MDR instead of 9 to 12 months. And some of them are changing between the combination of TB to try to reach less complication, faster clearance from the sputum. So the drug-resistant TB, there is an updated in the STREAM study. They evaluated the short regimen for the MDR TB based on the current WHO practice, which is done in Bangladesh. So they did a 40 weeks of oral regimen, so it's around like 10 months, and a 28 weeks regimen after an 8-week intense regimen, which we does the induction therapy, then we give the maintenance dose. So they found like it's okay to give for the MDR resistant TB around, or the rifampicin resistant TB 6 months. Also in the MDR, there was the next trial that was published in 2020, and we're waiting for the final results for this trial. They compared 6 to 9 months with this combination of linezolid, pediculin, levaquin, and pyrazinamide and ethambutol with a higher dose to the standard of care to see if we can overcome the resistance by increasing the dose. The XDR-TB, there is a couple of most of the study actually of evolving this new evolving drugs is to work on this XDR-TB and to try to find another alternatives to the one we have now and we've been using because of the common side effects and toxicity that those drugs have. So we have a couple of trials that shows a very favorable outcome at 24 months following treatment with patient with MDR and XDR-TB. So what do? Some researchers recommended adjunctive therapies. So some of them, they used to use some therapies that targeting the bacillary consequences in a so-called host-directed therapy. So basically they're trying to induce like the host immunity so it can fight the disease itself at the initial presentation. And some of the drugs that has been suggested also is working around modulating the macrophages activity since it's the primary thing of fighting the MTB. And some studies included vitamin D, everolimus, and one of the research drugs still for an anti-inflammatory compound that helps to minimize the speed of converting from latent TB to active TB. So some studies predict the biomarkers. So what do? The biomarkers that we like to follow the patient, there is nothing, no standard test that tells you that the patient is cleared of TB. The first thing we do is we get the acid-fast bacilli and follow it till the patient is cleared for 3 negative consequent acid-fast bacilli. Some of them wait for the drug resistant. If it doesn't have any drug resistant, then they adjust the patient treatment. And they did use some newer technologies in doing diagnostic imaging with the presentation to follow the response of the patient to the therapy. So the direct observation therapy and the video observation therapy are the recommended things. So the direct observation therapy is when you give the patient face-to-face the medication and watch him take it and go a couple of times per week. We don't have this technique yet established in Saudi Arabia in a lot of areas, but the newer thing is the video-assisted technology, where the patient can take a video of himself taking the medication, uploading it to a secured website, or someone watching through a live stream and make sure that he's taking the medication. This can help to make it sure that the patient are taking the medication. So if we talk about prophylaxis, we do the quantiferon TB test or the standard PPD test. And those will show us if the patient is positive, then we'll assist them for possible prophylaxis if they're high risk to develop TB because of receiving immunosuppressive therapy, and there will be another lecture about that tomorrow by Dr. Samar, inshallah. So some of them advocate with WHO the 4 months of rifampicin or 6 to 9 months of INH. That's the basic thing. And there was also another one that was approved, but it's a little bit toxic, the 3 months of the rifampicin with the INH weekly doses, and it has very high level of toxicity. Vaccination. There is a couple of vaccines that's been growing and been studied in the market. Some of them mimic the PCG idea or technique. So they want to give it, or they're trying to implement it for pre-exposure or post-exposure prophylaxis for TB. So one of them is like a live recombinant PCG vaccine, and it's undergoing phase 3 studies. And the other one is a pre-exposure live attenuated vaccine, which with the, it has a higher protection against TB than the PCG. Another post-exposure candidate, there is one experimental vaccine that's been working to prevent pulmonary TB, but not the extrapulmonary TB, in around 54% of the patients. So this will be really good to implement, especially for healthcare workers and who are exposed always. So if I ask you a couple of questions to make sure you're awake or sleeping, let me ask you this question. What's the proportion of the world population of TB infection, the estimated one? Is it 5%, 10%, 25, or 25, or 50%? Please, someone. 1 to 4, which is like 25% of them developed TB worldwide. Okay, which of the following is a WHO recommendation for the first line test to diagnose TB? Nothing? Just say A, B, C, D. Just guess. The biomarker, the gene expert, and whoever of you are residents or fellows, that's board exam questions, because they can give you this with the culture, and then the biomolecular test is more the gene expert. Okay, so the pre-XDR TB is defined as TB that's resistant to rifampicin, isoniazid, and what else from the medication? What do we use most commonly with the TB as second line? The fluoroquinolone or moxifloxacin. Okay. Which of the following regimens are not currently recommended by the WHO for preventive treatment of TB? So we have the rifampicin for 4 months is approved. The isoniazid daily for 6 to 9 months is approved. And then we have the rifampicin plus isoniazid daily for 3 months. And then we have the rifabutin and isoniazid weekly for 1 month. So the last option is the one that's not approved because it's highly toxic, because you give a higher dose of INH up to 900 milligram. and we don't have rifampicin anyway in Saudi Arabia yet. So we have a bright future, inshallah, for TB. They're aiming by 2035 to have eradicated like around 95% of TB cases worldwide and vaccinate patients by that time. And we need to have a better effort to develop a new technology and treatment for TB patients and combine this advancement so we can reach a targeted patient therapy based on each patient proteins or molecular studies with the genomic expression and the mutation and resistance in those patients by developing more drugs and more studies. Thank you.
Thank you, Dr. Faris, for this excellent presentation and on a problem that we're facing every day still in our clinical practice. Thank you so much.
You're welcome.
Our next speaker is Dr. Noura Azhari. Dr. Noura did residency in pediatrics in Dr. Suleiman Faqih Hospital, then had her fellowship in infectious diseases in King Faisal Hospital. Noura, in pediatric ID.
Yeah, in King Faisal Specialty Hospital in Riyadh and National Guard Hospital.
National Guard. And she's currently consultant pediatric infectious disease in Dr. Suleiman Faqih Hospital. And she's the chair of the Antimicrobial Stewardship Committee and in charge of that program. And she will give us some update about antimicrobial stewardship and what's new with that.
Good afternoon, everyone. Assalamu alaikum wa rahmatullah. It's my pleasure to be here today. I will talk about a few points in antimicrobial stewardship. I think some of you or all of you are familiar with antimicrobial stewardship. It has been a booming subject in the last couple of months and years. Today we will just highlight what is the antimicrobial stewardship. And before talking about antimicrobial stewardship, for sure we have to mention why we started antimicrobial stewardship. I have nothing to disclose today. And my objective, we will define antimicrobial stewardship. We will highlight the purpose of antimicrobial stewardship. Later, we will demonstrate common infection-based intervention that can be done in the hospital. And we will discuss a few questions and evidence-based practice upon these questions. And then we will, lastly, we will just highlight a new modality in applying antimicrobial stewardship. So, Dr. Al-Batul, she was saying that we are in danger because of HIV, but I'm telling you that we are in a more dangerous, in a serious danger because of the antimicrobial resistance. But 8 million infection. From these 36,000 deaths. And also we can see C. diff infection related to antibiotic use for more than 230 cases with almost 13,000 deaths. So what we are facing today, that we have so much multi-drug resistant organism with no new antibiotic in the development. Unfortunately, I can tell you that the last antibiotic approved was in November 2019, which is very dangerous and really worrying that we have this kind of organism without any new drug developed. So, how can antimicrobial resistance happen? There is a lot of germ and few are resistant to antibiotic in our body. So when we are using the antibiotic to kill the infection, they also kill the good bacteria protecting the body, the normal flora. So the antibiotic-resistant bacteria, they will grow and take over. And after that, they will share their resistance to the other bacteria. I know that this is a basic, but we have just to highlight this is quickly. So how bacteria and fungi fight back against antibiotic? They either have developed new cell process, they can change the target site of the antibiotic, they can also destroy the antibiotic. By their enzymes, they can get rid of the antibiotic. And after that, if we have like an resistant bacteria, they also change, or they are also transfer the genetic resistant to the other bacteria. That's why what we have antimicrobial resistance increasing in the hospital setting. So, coming to the cost associated with increasing bacterial resistance, why we care about increasing bacterial resistance? Because it will increase the treatment failure. It will increase the mortality and morbidity for the patient. It will increase the risk of hospitalization. It will prolong the length of hospital stay. And also we will need an expensive and broad spectrum antibiotic, which will again put us in the same cycle of developing resistance. So how can we prevent antimicrobial resistance? The CDC have defined 4 core actions to prevent antimicrobial resistance. The first one is infection prevention, is an antimicrobial stewardship. So when we are trying to prevent infection in the hospital, when we are doing the guidelines and following the guidelines for the specific infection, when we are following the bundle of care regarding all the infection, when we are doing hand hygiene, this is all part of antimicrobial stewardship. The other thing is tracking infection prevention data. This is what we are doing in antimicrobial stewardship. We are collecting the data for CLABSI, central line-related infection, CAUTI, catheter-related urinary tract infection, and MRSA. Hospital-acquired infection prevention, and to inform antibiotic stewardship program about all these infections so they can do the investigation and take the proper action. The other thing is what we are talking about here, improving antibiotic prescription. And lastly, bacteria are constantly evolving, so we need a new antibiotic to be developed. So, what is the best way to keep the matter in order? What do you think? The best way to keep antimicrobial agents useful is to use them appropriately. So, what is stewardship? It is the job of supervising and taking care of something. And this is what we are doing in antimicrobial stewardship. It is referred to a set of commitment and activity designed to optimize the treatment of infection while reducing the adverse effect associated with the antibiotic use. So what is our goal? Is to have the right drug for the right person over the right time frame. So what is the goal of antimicrobial stewardship from the CDC? The primary goal, as we said, is to optimize the clinical outcome while minimizing the unintended consequences of antimicrobial use, putting in consideration the toxicity of the drug, the selection of pathogenic organisms, such as C. diff, and preventing these, and emergence of resistant pathogen. The secondary goal is to reduce healthcare costs without adversely impacting the quality of care of the patient. So why we need antibiotic stewardship? To improve the quality of patient care, to reduce the adverse effects, including C. diff infection, and to improve the antibiotic susceptibility, and also to optimize the resource utilization and the cost for the hospital. We cannot talk about antimicrobial stewardship without mentioning the core element of CDC in antimicrobial stewardship program, which is include hospital leadership commitment. That this is the element that should be applied in each antimicrobial stewardship according to the hospital or institution that contain this committee or program. So first of all is hospital leadership commitment. That means that it has a dedicated team, human resources, financial and information technology resources. Second thing is accountability. There should be a team, an appointed leader and co-leader for this antimicrobial stewardship. And pharmacy expertise, this is we have to have an appointed pharmacy. Ideally, they are co-leaded to the stewardship, because pharmacists in all around the world, they are the cornerstone of antimicrobial stewardship. And thank for them, they are usually the one who's doing all of the work for the antimicrobial stewardship. The action that we are doing, it contains a different implementation intervention. There is pre-prescription intervention, and there is post-prescription intervention. The most common one that we are using in our hospital, in a different hospital, is the pre-authorization and prospective audit and feedback. And after implementation of these two, there was a much reduction of antimicrobial abuse. Another thing that we have, we should mention also tracking, as I said, in the CDC. We have to track what we are doing, if we are doing in the right way, or we have to monitor to change the guidelines or to change the practice. We have to report any hospital-acquired infection and any MDR infection. And lastly, but not least, is the education. And I want to emphasize about these things. The antimicrobial stewardship, it's not only our part as ID. It's the job of all the physicians. It's the job of all the pharmacists. It's the job of all the nurses. You have all to be involved in educating the patient, educating the trainee, the resident. We have all be involved. There is one study was done by Dr. Khalid Al-Ja'ali. It was only observing the antimicrobial use after implementation of the restriction of antibiotic through the pharmacist. They observed that initially in 2019, June, after the implementation of restriction of antibiotic, there was decreasing in antimicrobial prescription through all around the pharmacists and in the Saudi Arabia. But like after 4 months, they saw that there is another increasing again to the antimicrobial prescription. This study was aiming just to observe the conception and the part of pharmacist and doctor, and also patient in implementing these antimicrobial stewardship. So they conclude that pharmacists also need to be educated. What is the indication for antimicrobial use, and what is the duration for that? And they noticed that there is a pressure from the patient to the pharmacist and to the doctor to prescribe antibiotic. And that's what we need to stop, and by educating the patient and the doctor as well. Okay, so what common infection-based intervention that has been done in some hospital and can be done in other hospitals to improve antimicrobial prescription? For example, for community-acquired pneumonia, intervention have focused on improving diagnostic accuracy, and this is what we meant by introduction of the PCR, upper respiratory tract infection, and lower respiratory tract infection PCR. These two diagnostic tests have been shown that they decrease the antibiotic prescription in the hospital. Tailoring of the therapy according to the culture result. This is what I want you to do. Whatever you have, like pneumonia, and in adult per se, in pediatric it's difficult a little bit. But before starting antibiotic, take a sputum culture, please, and take a proper culture. This is my message to the nurses. Please take a proper culture from whatever we are taking. If we are having like pneumonia, we need like a sputum culture. We don't need a saliva. If we have a wound, take a deep wound. This is by observation of the doctor. And also optimizing the duration of treatment to ensure compliance with the guidelines. All the new guidelines that they are saying that community-acquired pneumonia does not need more than 7 days therapy. And later on, I will present one of the cases in pediatric, also lesser duration of antibiotic. Another common infection-based intervention in urinary tract infection. Please avoid obtaining unnecessary urine culture. And when you are taking urine culture, take urine analysis. And don't treat asymptomatic bacteriuria, an asymptomatic patient, unless there is specific indication for that. And for patients who need treatment, intervention can focus on receiving the appropriate antibiotic according to the susceptibility for the recommended duration. For skin and soft tissue infection, intervention have focused ensuring patient with uncomplicated infection does not need to receive the antibiotic to cover a broad spectrum antibiotic to cover MRSA, whose MRSA or gram-negative organism. This is individualized, but I mean for the low-risk patient who have not been admitted to the hospital before, he was not being treated with antibiotic, and especially in pediatric, we don't need to cover. And prescribing the correct route, dosage, and duration of treatment. And when the patient is improving, tolerating orally, please switch from IV to oral antibiotic. And lastly, regarding sepsis, I want to emphasize that early administration of effective antibiotic is a life-saving in sepsis. And the hospital should put an effort in developing antibiotic recommendation and guidelines according to the antibiogram and microbiological data. And ensuring that there is a recurrent review of the antibiotic every now and then to ensure that this is going with the microbiological data through in the hospital or in this institution. Okay, now I will come to common question in antimicrobial stewardship. For the
Dr.
internal
Noura, just for the
medicine.
sake of time, maybe 2 minutes, couple of minutes if we can wrap up.
I will go quickly through this one. So do we need to cover Enterococcus organism in abdominal infection? And what is the oral dose of amoxicillin to treat community-acquired infection in children, and for how long? So in a randomized trial showing the organism identified from complicated intra-abdominal infection, it was shown that most of the infection was related to gram-negative bacteria, mostly E. coli, while Enterococcus faecalis was around only, Enterococcus species was around 15%. So the guidelines regarding empiric coverage for Enterococcus from the IDSA for mild to moderate community-acquired, it was not necessary. For high-risk community-acquired infection, it was recommended. And for healthcare-associated hospital-acquired infection, recommended, especially post-op, prior exposure to cephalosporins and immunocompromised patient. From the Surgical Infection Society, also not recommended in mild, and consider adding AMPI and Vanco for high risk, and recommended in post-operative. This is a meta-analysis showing empiric enterococcal coverage in intra-abdominal infection. It was continue of 23rd RCT, 13 observational study, and this is the first plot. It showed that enterococci covered antibiotic regimen provided no improvement in treatment success compared with control regimen, with relative risk almost 1.99 and confidence interval 0.97 to 1. And p-value 0.1. Given that the patient is not a high risk, given that this is a community acquired infection, and also this study was included only a young patient. Okay, the other one is, what is the dose and duration of antibiotic? I was mentioning community acquired pneumonia. So this is a study studying amoxicillin dose treatment duration on the need of antibiotic retreatment for community-acquired pneumonia. It was a randomized multi-site non-inferiority trial from 2017 to 2019. 840 children was included. They discharged from emergency department in less than 48. It was subdivided to 4 groups. The first group was having high dose amoxicillin 70 to 80 with 3 days. The other group was high dose with 7 days. The third group was having a low dose with 7 days, and the fourth group was having a low dose with 3 days. So, and 45% was having one criteria of severe pneumonia, and severe pneumonia outcome similar for antibiotic retreatment within 28 days based on the dose, 17 compared to 14 in high dose, and duration also was 16 in 3 days versus 15 to 7 days. So there was it was not significant change. And this study showed non-inferiority of having low dose and 3-day duration of antimicrobial in community-acquired pneumonia in children. And to conclude, this is a study just showing impact of clinical decision support system implementation at community hospital with an existing antimicrobial stewardship program. This is the new modality. They are now all over the world, they are implementing an antimicrobial stewardship software, and it's contain a clinical decision support system, not only surveillance system. So this study was done in Pittsburgh in a community hospital. They just compared the result of antimicrobial intervention before and after the implementation of the clinical decision support system. And the result was an immediate 11% reduction in antimicrobial use, and antimicrobial usage was already trending to 0.25% per month. And they saw that the conversion from IV to oral was increased from 38 to 57%. So the implementation of clinical decision support with an established task as a community hospital decreased the antimicrobial use, high rate of oral usage, and also faster time to optimal therapy, and improve as well the pharmacist's efficiency. So to conclude, in summary, antimicrobial resistance is a public health threat. Antibiotic is important for combating life-threatening bacterial infection, but can have a side effect. Antibiotic overuse promote development of drug resistant. Antimicrobial stewardship can assist with appropriate use. And the last message and take-home message, antimicrobial stewardship is a responsibility of all of us. Thank you so much.
So now we'll move to the last presentation that will be presented by Dr. Traud Adnan Telmisani, who is the Assistant Professor of Family Medicine and Geriatric at Al-Baha University, a consultant of Family Medicine and Geriatric at Faqih Executive Clinic. He did the American Board of Family Medicine at Texas Tech University, an American Fellowship in Geriatric, Oklahoma University, and then Clinical Research Fellowship at George Washington University. He'll be presenting on preventing shingles with recombinant zoster vaccine, which is the new buzz by Minister of Health. Thank you, Dr. Traud, and the floor is yours.
Thank you. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا الأنبياء المرسلين سيدنا محمد وعلى آله وصحبه وسلم. Good afternoon, everyone. First, I'd like to thank you all for being here today. Then I'd like to thank the organizing and the scientific committee and GSK for inviting me and giving me this opportunity to be standing in front of you all today. And today my talk will be about the talk of the hour, the new vaccine that was approved by the Saudi FDA and the Ministry of Health, and being incorporated in the adult vaccination schedule, the recombinant zoster vaccine. But before I start, I have a little story to tell. A couple of months ago, I was called to see a patient. I do a lot of home visits as a concierge medicine. I was asked to see an 88-year-old male who have just a history of BPH. He takes a medication for that, and that's all. He's very active, very interesting person. This 88-year-old is very unique. The fact that he doesn't live in Saudi. He comes and goes. He lives in Europe. But until now, he do snow skiing, and he swims every day if the weather permit. And he was coming to Jeddah just for a few weeks. I was asked to see him because he was complaining from some abdominal pain and some back pain. when I went to see him, he was telling me that before I visit him, he visited one of the top pain specialists in Jeddah in the morning for that complaint of a back pain. I saw him. I usually spend a lot of time with my patients, so we dive into a lot of things in the history. And he was telling me this pain is like a stabbing pain in the back. Tell him, listen, I have two things in mind. This could be a herpes zoster, or it could be, as the pain specialists say, that this could be just, you pulled a muscle strain. The pain specialists prescribed tizanidine, sulfadine, and a patch for that. And for older adults, for geriatric, this is not usually the ideal combination, especially that he sometimes have some dizziness that he can suffer from. So I told him after the examination, I examined him, I saw that he had this paraspinal muscle pain from the thoracic down to the lumbar on the left side. I told him, listen, I would lean toward the pain specialist opinion that this could be a muscle strain. And I just did some of the medications for him, so day number 1, number 2, number 3, everything was fine. And day number 5, he started having the rash of herpes zoster. This unfortunate person, who was 88 and very active, was seen by 2 consultants, one in pain management, and the other one is a family geriatrician consultant. And we all missed the diagnosis. Even though I had an initial thought about it, but we still missed the diagnosis. So, I'm going to give you more details about this patient condition, how things evolved after that as we go through the presentation. Okay, let's see. Maybe I'm not pushing the... بس معايا. Okay, so my agenda for today, first I'm going to be talking about the burden of herpes zoster. Then I will talk about the complications that we anticipate from patients who are suffering from herpes zoster. Then we'll talk about the new available vaccine and is it safe or effective. Okay, so herpes zoster, a lot of research was done globally to look into how common is it. Okay, we have a few studies that were done here in Saudi Arabia for a small population of patients, but a study that was published in the BMG by KY et al. And team in 2014, they did a meta-analysis to look into, can I have the pointer please? To look into how common it is. And they found that patients who are 50 years and older, globally, they tend to develop herpes zoster. And the reason behind that is that patients who are hit the milestone of 50 years and above, they develop something called immunosenescence, where the immune system weakens, and thank you. So the immune system weakens, and when that happens, the T cells, B cells, and antibodies decrease inside our bodies, and so we have the tendency to develop herpes. But our history with herpes zoster, with the virus itself, is not new. Our first exposure to the varicella zoster virus happens during our childhood, okay? At a very early stage in our life. That's when any one of us who get al-angas or the chicken pox, so that is our first exposure to the virus. Usually the acute phase lasts for one week. Then after that, it goes dormant in the dorsal ganglia and the paraspinal ganglia and stays there under the check of our immune system for many, many years and decades, until we hit again the milestone of 50 years old. And if someone get under the psychological, emotional, or a physical trauma, the immune system again will get weakened, and the virus will escape the dorsal ganglia, giving the characteristic dermatomal red rash with the vesicle. So the graph in the left is the study I told you about, the one that was published in 2014, with a meta-analysis looked into a global perspective of how common is the incidence of developing herpes zoster. Again, age 50 was the milestone globally where the number of cases increased. The chart on the right, it just gives you an idea that one of the most severe complications of developing herpes zoster is postherpetic neuralgia, and as we get older, the chance of developing the postherpetic neuralgia increases with age. As I just mentioned, one of the feared complications of herpes, of the reactivation of the virus, is the postherpetic neuralgia. Unfortunately, there's a decent number of patients who can develop that, like 25 to 30% of patients. It is estimated that 99.5% of all adults from 50 years and above, they have the virus inside their body. So I would assume that the virus is present in all of us, unless you are able to get the vaccine for the varicella. But even though we don't know still if taking the vaccine for children at a young age, to take the varicella vaccine will prevent that from happening. We still don't have data about that. But it is estimated that 1 in 3 adults will develop the herpes zoster, or the shingles. So the postherpetic neuralgia is a very severe pain that lingers around and stays with the patient for a very long period of time. One of the second most common complication that may happen is the herpes zoster ophthalmicus. The lesions or the reactivation of the virus can, of course, involve the trunk, so the chest and the abdomen, or the neck or the face. And if it hits the face, it will hit the ophthalmic branch of the trigeminal nerves. And that will cause the complication of herpes zoster ophthalmicus. Here just another representation of the different herpes zoster complications that may happen. Okay, again, the postherpetic neuralgia is the most common one. Then the ophthalmic complication. Then we have the cerebrovascular and the cardiovascular complication that may account for 1%, and there is other complications that may happen. So the problem with the postherpetic neuralgia is that it is very severe. Of course, for those patients who are unfortunate to get this virus reactivated and they get the acute infection, they develop something called acute neuritis. When the pain starts or when the rash starts, we tend to prescribe antiviral treatment for those patients. Hopefully, if we do that very quickly, within a 72-hour window, we can fasten the recovery to happen and prevent the postherpetic neuralgia from happening. But unfortunately, that doesn't happen most of the cases. So for those patients who develop the postherpetic neuralgia, we tend to prescribe pretty strong medications for them. I'm going to give a little bit of details about these medications, but patient described the postherpetic neuralgia as a pain when it was compared by different kind of pains. For postherpetic neuralgia, it was put at the level of the fibromyalgia. And for the acute neuritis pain, it was just above the labor pain in terms of intensity. Some patients would describe the postherpetic neuralgia as the pain that worse than my cancer and chemotherapy, and it had made me depressed and suicidal in the past. Unfortunately, for older adults who suffer from the postherpetic neuralgia.
5 minutes remaining.
Sorry?
5.
Okay. they will develop something like very bad quality of life and poor sleep. And of course, for those patients who are immune compromised, those patients will suffer from very severe cases of reactivation of the virus, and they will be more susceptible to develop the post-herpetic neuralgia and other complications. So for those patients who develop the rash or the pain and they get started on the antiviral treatment within 72 hours, those patients may suffer from post-herpetic neuralgia later, but in order to treat that very severe pain, we tend to prescribe pregabalin like Lyrica or gabapentin. And unfortunately, these medications are under very severe restrictions nowadays. And these medications are not favorable for older adults because it can promote dizziness, confusion, and increased risk of falls. Other medications that can be prescribed are the antidepressants, like tricyclic antidepressant, and these medications cannot be prescribed to older adults because of the very severe anticholinergic side effect. So the recombinant zoster vaccine recommended in Saudi Arabia is a vaccine that was approved by adults who are 50 and above, and for immunocompromised patients for any reason, like either they're receiving chemotherapy or radiotherapy, or they have some sort of malignancy, so who are 18 years and above. So this recombinant zoster vaccination, it's not a live attenuated vaccine. Many years ago, a vaccine was developed that was like 20 years ago. A vaccine was developed which was a live attenuated one, but this one that approved by the Saudi FDA, it's not. And it have two components. It have the glycoprotein E, which is the most important part of the service of the virus, and it have an adjuvant system to stimulate the immune system to give very strong immunogenicity and reactivity toward the glycoprotein E. And it is indicated for patients who are 50 and above in different parts of the world, and it is given in 2 doses in Saudi Arabia in the intramuscular region, preferably in the upper deltoid part. Okay, so this is the component of the vaccine that was approved by the Saudi FDA, the glycoprotein E and the adjuvant system. So, but in order to get the full benefit of the vaccine, you need to take the full 2 doses, okay? So if someone received the vaccine today, the second dose should be at least after 2 months from now. They have a window between 2 months up to 6 months. But in order to take to the full, again, benefit of the vaccine, you need to take the second dose, and that will increase the benefit and the efficacy of the vaccine by 3-folds. But for patients who are 18 years and above and they have suffered from immune compromising condition, they can have the vaccine with 1 month interval. Okay, so someone received the vaccine in the upper deltoid muscle. It will go inside the body. The macrophages will pick up the glycoprotein E and the adjuvant system. Monocytes will be developed, go to the lymph node. From there, the T cells will differentiate and reactivate and activate the B cells, and from there our antibodies will be developed. The graph on the right, you can see 2 curves. The curve on the bottom, okay, the curve on the bottom represent the live attenuated vaccine that was developed many years ago, and the curve with the purple color, this is the one with the approved vaccine with a broader and huge area under the curve. So can we administer the vaccine with other vaccines? Yes, you can do so, but you can administer it with the flu vaccine, with the pneumococcal vaccine, and the Tdap. But preferably, if you give someone all these vaccine in one side, give the shingles vaccine in the other arm. Okay. Okay, it is 91% efficacious vaccine, and new data was published mentioning that even after 10 years, we do still have 81% effectiveness of the vaccine. The vaccine side effects is very similar to any vaccine side effects, so having pain, redness, and swelling, that will happen in the first 2 to 3 days. Other side effects in comparison to any other vaccine and placebo, very close. And no serious side effects were reported. So in conclusion, the vaccine is 91% effective in all different ages. And after 10 years, with the most recent published data, it is effective by 81%. Thank you all for your attention.
Thank you, Dr. Tarad. We started late this session, so we apologize for a little bit of delay. Questions to any of our speakers from the audience? Maybe quick question I have actually to Dr. Batul and to Dr. Trad. I'll start with the easier one. Dr. Trad, the recommendation is 2 doses, 2 to 6 months apart for people above 50 years of age. How often, my understanding that immunity wanes around 4 or 5 years. How often shall we give this vaccine to elderly or to people above 50? Repeating the dose series.
Yeah, thank you, Dr. Sama. So I understand your question was about after 5 years.
How often? Yes, like we give it every 5 years, every 10 years.
Yeah, so there is no booster that needs to be given. No booster should be given or approved. According to the recent data that was published 2 weeks ago, they looked into for how long do the effectiveness of the virus will stay in the body. It is 81%, which is pretty decent for a vaccine that was given 10 years ago.
Okay.
So there is no recommendation for
no need for any booster.
Yeah.
Okay, thank you. So it's a lifelong, even if someone lives long, huh? That's good. That's good to know. Dr. Batul, I was surprised actually. I was hoping we're going to have more data on HIV. Every single healthcare institution is mandated to report HIV positivity to a central body in the MOH, in the central lab to validate the result. So there are no national data telling us how many active HIV patients we have currently in Saudi Arabia?
The last data was announced by Ministry of Health 2 years ago. We don't have any new data. What I have is the data from my center only.
Okay, so whatever you presented to us was the Jeddah data based on the things. And any approximate number, how many in Saudi Arabia are now currently living with HIV? Do you have any approximate number?
It's very difficult to estimate. Like 2 years back or 3 years back, they mentioned it's around like 11, 14,000. But
10 to 11,000.
We don't have
we don't have those
data for this year.
Any other questions to our colleagues or speaker? Can I have just one question about tuberculosis? Dr. Muna, it's nice to see that now we have protocol for 4 months, and you showed some phase 3 trial data. Any authority endorsing this recommendation yet?
Any what?
Authority, like American Thoracic Society or IDSA. So they are endorsing the 4 months regimen to treat tuberculosis.
The American Thoracic, the IDSA, and the CDC.
So now we can...
Yes.
Okay, good. Just going back, are the medications available for that in Saudi Arabia?
No, not all of them, of course. The new ones, none of them.
The bedaquiline or the other
none.
one? Okay. And the same question for Dr. Batul, HIV therapy. What is currently available in Saudi Arabia?
We have
and you showed us some
of the oral that recommended by the international guideline.
Bictegravir,
Gemvoya, Dolutegravir, Descovy, Triumic, approved even Dovato, but we are waiting to be reached to our clinic. So most of the oral treatment available so far.
Okay. Other questions to our
But we need the awareness. We need the support of the general physician and all kind of subspecialty to help us in educating.
As you correctly said, and I see we have the majority are young attendants here and attendees. Safe sexual practices, teach your patients about them, tell them that a sexual partner could look perfectly healthy, but they could have HIV. So this is, I agree, lots of education is needed here.
question to Dr. Noura. What is the biggest challenge you found in starting the antimicrobial stewardship program at Dr. Suleiman Faqih Hospital in Jeddah?
As we said before, the antimicrobial stewardship is a job of all of the physicians. It's not the job of ID physician or ID clinical pharmacist. So maybe the most challenges is to have the education for all the staff, for the nurses, for the pharmacist, for the physician, for the trainee, to make them all involved in promoting antimicrobial stewardship.
One more question for Dr. Muna. Do we have any data on the drug resistance in Saudi Arabia, TB drug resistance?
No, not a data, but the one that's available, it's really way like 10 years or something. Nothing recent. The problem is sometimes we don't have the full panel testing here. We have to send it like to the regional lab or something if we want to confirm it. We only get the rifampicin and the isoniazid. So it's equal to the same resistance that it's available worldwide, but the others, we don't have the resistance for that. Thank you.
Finally, I have to thank all our لسه يا دكتورة دقيقة واحدة. I have to thank all our speakers. Really, thank you. And on behalf of the whole Congress, we want to thank you and we want to give you something will stay as a memory with all of you, just to remember you or to remind you with the headache that I gave it to you during preparation of the presentation and sending me by presentation, and to thank you about your contribution and support for our Congress. Thank you very much. Now, it gives me honor to ask Dr. Samar. Dr. Samar, would you please come? We want just to distribute trophies to our speakers. Dr. Muna? ممكن هنا عشان الصورة مع الكونجرس يعني. دكتورة بتول. دكتورة نورة أزهري. دكتور تيراد. And finally, I'm going to ask Dr. Ziad to come and to thank our moderator, Dr. Anouf and Dr. Samar. Let's start with Dr. Anouf first. Dr. Anouf. Really, nothing can to be said about Dr. Samar and her contribution and her support since the day one for the whole Congress. Thank you, Dr. Samar. Yani, to tell you the truth, that she was the one already supported us during preparation of the whole Congress scientific programs. All the support, and thank you for Dr. Samar. جزاك الله كل خير. شكرا والله يا دكتور. شكرا بجد. Let's have 10 minutes break, but 10 minutes only, yeah? Because we are going to start our last session. شكرا. afternoon. Welcome back. Always we keep the best till the end. We will have now the cardiology session, the last session of our first day of Faqih Congress. And without any more delay, it gives me honor to introduce our great moderators, Dr. Hussam Al-Ghitani, Dr. Arwa. Floor is yours, ya jama'a.
So good afternoon, everyone. Hopefully you enjoyed the conference so far. I'm Arwa Jamal, and it is my pleasure to be moderating the last session this afternoon with my colleague, Dr. Hussam Al-Ghitani. And this session is about cardiothoracic diseases updates. We have interesting topics and well-known speakers. And let me introduce the first speaker, Dr. Majdi Idris. Dr. Majdi Idris, he's adjunct professor of pulmonary medicine at University of British Columbia, Canada, and he is consultant pulmonary medicine at Prince Sultan Military Hospital in Riyadh. Dr. Idris was the first to establish the nucleus of pulmonary hypertension medicine in the region, and he is the founder and the former head of Saudi Association of Pulmonary Hypertension. He is going to talk about updates in pulmonary hypertension management. So please welcome Dr. Majdi.
Assalamu alaikum rahmatullah. Thank you so much, Dr. Arwa, for this kind introduction. So can I just have my slides, please? Okay, so first of all, I would like to thank the organizer for inviting me to be part of this very prestigious scientific event. And my talk today will be about the update in pulmonary arterial hypertension management. I'm just trying to move my slides. Can I move the slides? It's like it's not moving. It's not moving. Okay, it is moving now. Okay, so I'll start by really agreeing on something, that when we talk about pulmonary hypertension, we have to agree that pulmonary hypertension is not a disease per se. It is just a hemodynamic state that we measure as a mean pulmonary artery pressure of more than 20 in the right heart cath. So the first message I'm going to share with you today is that you need the right heart cath to make the diagnosis. And we're going to really talk about this later on, because there is a lot of talk about should we depend on the clinical evaluation, on echo, or in what to do the diagnosis. We need to understand that PH can be associated with many, many diseases, including heart failure, COPD, scleroderma. Whenever you have PH associated with any disease, then the outcome is bad. Now, the second important message is that pulmonary hypertension is different from pulmonary arterial hypertension. As you can tell, that pulmonary hypertension can arise from the capillary area in the lung and can appear from the precapillary area, from the arterioles, especially with lung disease or group 1, and can appear from the postcapillary, especially in heart-related diseases. So when we talk about PAH, we need to know that you need to have high blood pressure, but we need to have a triad of normal left-sided parameter, i.e. the wedge pressure should be normal, and the pulmonary vascular resistance indicating some activity in the precapillary arterioles is actually elevated. We used to call pulmonary hypertension as a primary and secondary. Now this is an obsolete language. Now PH is being classified into groups, 5 groups, and the reason behind that we need to really understand the pathophysiology of each group, and also to understand that we cannot interchange the treatment. So if we use group 1 medication to treat group 2, basically a disease, we increase mortality in those patients. For the sake of this talk, I'll be focusing on group 1, pulmonary arterial hypertension. And that's a disease whenever you have some issues related to the precapillary pulmonary circulation, that there will be an initial injury or hit affecting the endothelial cells in the arterioles, and that leads to the imbalance between vasodilator and vasoconstrictive mediator release in the lung, leading to upregulation of the vasoconstrictor, downregulation of the vasodilator, leading to vasoconstriction. But that's not the end of the story. If that process continued, then there will be some remodeling process. What we mean by that, that the endothelial cells, all layers, intima, media, and adventitia, will continue to really proliferate until the lumen of the artery is occluded. So remember that these new cells are being formed every day. Old cells do not die, so there is blunted apoptosis. If we have this in any other organ, we call that cancer. Cells are formed, old cells do not die. That's exactly what happened in pulmonary arterial hypertension. So many authors call that neoplastic process of the pulmonary circulation. Is it like a big issue? And indeed it is. If you look at the mortality of those patients, if you don't treat those patients, about 50% will die in 2 to 3 years. That's extremely malignant disease. Not only that, comparing PAH to really cancer in general, you would see that it's not only behaving like cancer, the outcome is like cancer. Actually, if you get advanced pulmonary arterial hypertension, that's much worse than any other cancer except lung and pancreas. So please think about PAH as very neoplastic process from its pathobiology, but also from its prognosis. This is our data in Saudi Arabia showing that our patients, it takes them about 28 months to get the diagnosis. Those patients are usually seen by internal medicine doctors for dyspnea. They're seen by the pulmonologist, they call them asthma. They've been seen by cardiologists, they call them deconditioning. It takes them 28 months to be diagnosed as a pulmonary arterial hypertension. And that's really a problem, because if you look at the survival of those patients, it's very clear that those who've been diagnosed late, functional class 3 or 4, the mortality is extremely bad. Those patients who've been diagnosed early, the mortality or the survival is significantly improved. And this is why we need to have a program to trying to pick up those patients very, very early by screening methodology to try to look at those patients at risk, to diagnose them early, to improve the outcome in those patients. Now, the big question is how to diagnose. And if you look at the guidelines, and by the way, this guideline is written by cardiologists and pulmonologists, and they said that we need to go for the steps of care. But for the sake of time, I will just say what is the role of echo in making the diagnosis of pulmonary hypertension. It's very clear from the guideline that the echo gives you only probability, likelihood or no likelihood. That depends on the TR-jet velocity that we look at. And then based on the TR-jet velocity, less than 2.8, no other echo finding, pH is unlikely. TR-jet velocity more than 3.4 by itself, you don't need any other things, pH is extremely likely. Anything in between, you need to look other echo parameter at the level of the right ventricle, looking for the basically size of the RV and RA. Now we have this TAPSE over PAPSE, if you like, ratio of really less than 0.055. We look at the level of the pulmonary artery, and we look at the level of the inferior vena cava. You need to look at all of those parameters to say, is pH likely or unlikely per echo? But really the gold standard, and I would say not only the gold standard, it's not an optional, it is a must. If you need to treat PAH patient, we do not treat patient without right heart cath. Not only because right heart cath will really confirm the diagnosis, it will classify the disease into pre and post really capillary or combined pre and post capillary, and will give us a lot of actually prognostic parameters that we need when we treat those patients. We also can do the vasoreactivity in subgroup of patients who might need to be treated differently from the other group. So again, the third message to you, ladies and gentlemen, today, right heart cath is not optional. It is a must if you want to have a PH treatment center in your hospital. How to treat those patients? Because as we said, those people, they have kind of really imbalance between vasoconstrictor and vasomediators. And at the moment, we have 3 signaling pathways that we are targeting with the treatment. We are using prostacyclin-related medication to really promote the cyclic AMP, which is a vasodilator and inhibits cell proliferation. We also use nitric oxide-related medications, sildenafil, tadalafil, or riociguat, trying to augment the cyclic GMP, which is another vasodilator and inhibits cell proliferation. And we use a medication from the other side to inhibit endothelin. Endothelin is the most potent vasoconstrictor in the body and promote cell proliferation. So inhibiting endothelin pathway is efficacious in treating those patients. I'm not going to go into details about the available medication. This is just like an example to some of the available treatment. Now remember, this is not a common disease, but you can tell how many medications are now available. This field is rapidly developing in the clinical studies. So we have the inhaled prostacyclin, inhaled ilioprost, showing improvement in 6-minute walk distance, riociguat and sildenafil affecting the nitric oxide pathway, again showing quite improvement in the functional class and symptoms of those patients. Bosentan and macitentan in the breathe and Serafin study showing improvement in 6-minute walk distance exercising, and macitentan in morbidity and mortality, and selexipag, which is really an oral prostacyclin receptor agonist, again decrease morbidity and mortality. So we have many medications that we can use as an inhaled, tablet, and also sub-Q and intravenous continuous infusion in very, very severe cases. But nowadays, we even move beyond that, and the study have shown that one drug is not enough. We need to use combination of medication to improve the outcome. So this was the ambition trial, trying to look at what happened in those patients if we use one drug. In this study, they use either tadalafil or ambrisentan versus 2 drugs from day 1, even in those patients with mild disease. And you can see what happened. Combination therapy is the way to go. And that once you get combination therapy, you significantly improve basically morbidity and mortality in those patients. So why do we treat those patients, or really how we assess the improvement? Are we treating the pulmonary hypertension per se? If this is very similar to essential hypertension, where you need to get blood pressure 120/80 or 130/80, whatever it is, the answer is no. We are not treating the number of the pulmonary hypertension pressure. Because I've seen that people come to me, they said, this doctor, his echo showing a pressure of 60 last years, now it is 80. This patient is deteriorating. This is wrong. The pressure could be improving by increasing the cardiac output, which is a good news. Or somebody, the echo was 90 and now 60. They said, wow, this patient is better. Again, this is wrong, because this drop in the pressure could be because of a drop in the cardiac output. So we do not treat the pressure. What are we doing? We are trying to bring those patients into the green zone. And if you look at the green zone, it's kind of goals of symptoms. So we are trying to really keep them in functional class 1 or 2, no syncope, good exercise capacity, 6-minute walk distance more than 440 meters, or if you have the cardiopulmonary exercise test. And then parameter for the right ventricular function. We use pro-BNP, we use echo, we use cardiac MRI, and we use hemodynamics. You would like to keep the patient in the green zone and look at it. None of them talking about the pressure per se. So pressure of 60 or 70 or 80 does not matter. What really matters is get those patients in the green zone. And please notice that even those patients in the green zone, the mortality is still high, up to 5%. So that's not really the best, but really the yellow and the red zone are the bad news. So finally, now the guidelines come and said, okay, so look at your patient, risk stratify them into green, yellow, or red. If the patient is in the green or yellow, start combination therapy. If the patient is in red, start 3 drugs, including IV prostacyclin. very, very aggressive way trying to improve the outcome of those patients. And then after we treat them for about 3 months or so, we see those patients again. And then we follow them based on 3 strata, looking for function class, 6-minute walk distance, and biomarker. Those who are on the green, that's good news. Anything else is not a good news. And if you look at what happened, if the patient after the initial treatment is not in the green zone, that's not a good news for yourself and for your patient. The mortality is really, really bad. And this is why now the newer guideline that was released a few weeks ago showed clearly that if you start green, continue green, that's the good news for your patient. Or if you start anywhere else and go to green, that's very good news. Any other combination is not good. So somebody started green and became yellow, look what happened. We now start adding third drug. Anybody get into the orange zone, we start using IV prostacyclin or subcutaneous prostacyclin. If somebody is in the red zone, we evaluate them for lung transplantation. So really the message here, we are very, very aggressive in treating with those patients from the diagnostic point of view and from the treatment point of view. So my take-home message to you, ladies and gentlemen, is this. Pulmonary arterial hypertension is not pulmonary hypertension. So pulmonary hypertension is very common. 1% of the whole world population has pulmonary hypertension, so millions of people. PAH is rare, however, it's very, very fatal. PAH group has neoplastic features. As I told you that, it has this feature of cell proliferation and blunted apoptosis. It's very like really cancer. It behaves like cancer. It should be treated like cancer. Now, the disease is under and late diagnosis all over the world, including Saudi Arabia. Unfortunately, most hospitals still do not have PH program. So those patients, they come to the really pulmonologist. They say, I don't know what to do for you. Go to the cardiologist. They go to the cardiologist and say, I don't know what to do for you. Go to internal medicine until the patient died. That's not acceptable anymore. Now we have a program, we know what to do, and those patients should be treated adequately. Diagnostic and treatment algorithms are complex and require highly specialized expertise with a center of excellence. Targeted therapy are effective, but should be used within evidence-based treatment algorithm. Combination therapy is the standard of care. Reaching low-risk group or the green zone is the target of care, not dropping the pressure up and down. That's not important. I believe that establishing a specialized PH center in all tertiary care hospitals, including Faqih Hospital, is extremely important and needed. If you look at, for example, in Riyadh City, we have only 3 programs. In Jeddah City, there is some initiatives, but I'm not aware of any real PH program really in the whole city. It needs MDT kind of work, including PH clinician, who could be pulmonologist or cardiologist, PH clinical pharmacist, PH radiologist, PH intensivist, and allied forces or services from rheumatology, hematology, medicine, nursing, etc. And with that, I would like to thank you very much for your attention.
Thank you very much, Dr. Majdi, for this excellent presentation. We will leave the questions at the end of the session. Let's move to the next speaker, Dr. Hussam Al-Ghitani. He is a professor of cardiology at Ain Shams University, and he is a senior consultant cardiology at Dr. Sulaiman Faqih Hospital. He is going to talk about elevating care for patients after a heart failure event.
Good afternoon, everybody. First of all, I would like to thank you for staying with us this late. You are really very courageous people. Thank you all. How does this work? Okay. The green. Okay. Okay, can I have the... Right. Okay, we are going to talk today about elevating the care of patients with heart failure after they have a heart failure worsening event. First of all, you should know that heart failure is a prevalent disease. We have more than 60 million patients all around the world are having heart failure. And this is a number that's much larger than the patients suffering from cancer. And actually, the prognosis of heart failure is worse than the prognosis of breast cancer in females and prostatic cancer in males. And about 50% of our patients are dead within 5 years without appropriate treatment. It's an important cause of health expenditure, and it put a lot of burden on the healthcare systems because it's #1 reason for admission and hospitalization for patients above the age of 65. Heart failure is a progressive disease. Actually, most cardiologists do not believe that heart failure, there's what we call a stable heart failure. It's a progressive disease. So with each episode of worsening of heart failure, the left ventricular function and the global cardiac function is less. When it becomes less, the prognosis comes worse. When he has another attack of worsening of heart failure, again, the function gets worse and the prognosis gets worse. What do we mean by worsening of heart failure? Worsening of heart failure means that the patient is still having symptoms and signs of heart failure despite receiving the guideline-directed medical therapy to the maximum tolerated dose. This is usually experienced by the patients by the increase in symptoms and the need for hospitalization, visiting to the ER to receive intravenous diuretics, or even the need for urgent visit to the ER to assess his condition. Worsening of heart failure is not rare. About 1 in 6 patients with heart failure will develop heart failure worsening event within 1.5 years from the initial diagnosis. And chronic worsening of heart failure accounts for 80% of heart failure hospitalization patients. It's important to know, again, that when the patient is admitted to the hospital with worsening of heart failure, the chance of these patients will be readmitted within a month is very high. It ranges between 50 and 60%. And as you see from the left side panel, that with each hospitalization, the probability of survival gets worse. With the second is less, third less, fourth is much, much less. We have some, let's say, very important trial in the treatment of heart failure. One of them is paradigm heart failure. In paradigm heart failure, the treatment of patients with heart failure was to use ARNI. With this use of treatment of ARNI, the prognosis improved. The primary endpoint in paradigm heart failure was a composite of cardiovascular death and hospitalization for heart failure. We analyzed the patients in this study. We found the patients who had no prior hospitalization for heart failure do much better when they are treated for heart failure compared to those who had admission within the last 3 months. And actually, there is a 50% chance for the primary endpoint for those who admitted within the last 3 months compared to those who had not been admitted with heart failure. Going again to this landmark trial in heart failure, the paradigm heart failure trial, you can see that this trial resulted in reduction of death from cardiovascular events in patients with heart failure by 20% and reduction hospitalization of heart failure by 21%. This is in comparison with enalapril, which was the standard treatment at that time. But you will see here in the shaded area, this represents the area of possible improvement. We have residual risk despite we improved the outcome compared to the standard treatment at that time with enalapril. We still have a large area of improvement. And again, this applies to the newest therapies in heart failure. The SGLT2 inhibitors, dapagliflozin, one of them. This is the DAPA heart failure trial. Again, you will see the treatment with dapagliflozin reduced cardiovascular deaths, reduced heart failure hospitalization, but in both there is still a good chance for improvement. And you can notice that about 16% of the patient will have one of these primary endpoints within 18 months of therapy. This is a combination of all the new therapies in heart failure. In the gray columns are the standard treatment of heart failure with beta blockers, ACE inhibitors, mineralocorticoid receptor antagonist, and in the colored line is the new therapy. On the far left-hand side, you will see that the paradigm heart failure, when we applied RNA, we have improvement, but still we have a lot of area to improvement. In the DAPA heart failure, still the same. We improved the outcome, but we still have a large area of improvement. EMPEROR trial, similar, empagliflozin, another SGLT2 inhibitor, produced the same effect, but we need even still more to do for these patients. The most recent therapies for heart failure, which is omecamtiv mecarbil, which is selective myosin, cardiac myosin activator, was studied in the galactic heart failure. The outcome was slightly better, but still we have a large area of improvement. Our treatment with all these trials I showed you, depending on targeting the compensatory mechanisms of heart failure that are overactive and do more deterioration. For example, we know that sympathetic nervous system overactivity produces initially improvement in the cardiac output, but on the long term produces more weakness of the heart muscle and more stress on the cardiac muscle. So we use beta blockers to target this. Renin-angiotensin-aldosterone system, the same. We used ACE inhibitors, ARBs, or mineralocorticoid receptor antagonists, and recently we added the neprilysin inhibitors in the RNA to increase the BNP. SGLT2 inhibitors, we do not know exactly what they do, but they are beneficial. These are compensatory mechanisms that we try to overcome its overactivity, but there is one pathway that's not targeted before. That's nitric oxide soluble guanylate cyclase cyclic GMP pathway. There is now a chance for improvement because we have a new medication, vericiguat, that acts on this pathway to improvement. Vericiguat, which is a new class of medications in the treatment of heart failure, acts through two mechanisms. Either it increases the sensitivity of soluble guanylate cyclase to nitric oxide, or it acts directly to stimulate the soluble guanylate cyclase. When this enzyme is activated, it acts on GTP to transfer it to cyclic GMP. Cyclic GMP is having a very favorable effects on the heart in patients with heart failure. It improves the myocardial function, reduces the left ventricular remodeling, improves the vascular function, decrease fibrosis, and decrease inflammation. Theory is good, but without a large clinical trial that shows that activation of this system or stimulation of this system will produce a clinical effect, this is useless. We have such a trial. This is the Victoria trial, published New England Journal of Medicine, May 2020. It's a large randomized parallel group, placebo-controlled, double-blind, international phase 3 trial. It included patients with heart failure and reduced ejection fraction, with ejection fraction less than 45, New York Heart Association class 2 to 4 with elevated BNP or N-terminal pro-BNP, and they have GFR 15 milliliter per minute and above. This is the lowest GFR included in all heart failure trials. Patients had to have a worsening event of heart failure. Worsening means that the patient needed to be hospitalized within the last 6 months or needed the use of IV diuretic treatment within the past 3 months. Patients were randomized to receive vericiguat in escalating doses, starting 2.55, then to reach the target dose, which is 10 milligrams once daily, compared to placebo, all of this on the background standard of care therapy for heart failure. So it is patients who have symptomatic chronic heart failure and have a worsening heart failure event. You will see here from the baseline data of these patients that 66% of the patients had hospitalization within 3 months, and about 84% of the patients had hospitalization within the last 6 months. You will see that the majority of patients are in class 2 and 3. This is about 89% of the cases. Very few patients in class 4 and no one in class 1. The mean ejection fraction at the start of the study was 29%. And you can notice here that most of the patients are receiving the standard of care therapy of heart failure at that time. A lot of them, 90% or more, receiving beta blockers, a lot of them receiving ACE or ARBs or ARNI, and mineralocorticoid receptor antagonists are used in 70%. SGLT2 inhibitors was not a standard of care of heart failure at the initiation of this trial. What about the outcome of this trial? The primary endpoint was a composite of cardiovascular death and first hospitalization for heart failure. It was reduced by 10%, which was statistically significant, and the annual numbers needed to treat are 24 patients. So you need to treat 24 patients for 1 year to prevent one event. This is analysis of some secondary endpoint. Cardiovascular death by itself on the far left-hand side shows improvement, but it didn't reach statistically significant. Hospitalization for heart failure was reduced in a statistically significant way. Total hospitalization, again, reduced in a statistically significant way, and the combination of hospitalization for heart failure and all-cause mortality was again significantly reduced. All-cause mortality shows a trend for improvement, but it didn't reach statistical significance. What about side effects of this new medication, of this new class of medications for heart failure? It seems to be that the side effects profile is almost more or less similar to placebo, with patients having serious adverse effects, about 32% in both groups. Two important aspects here: symptomatic hypotension and syncope were numerically more in the vericiguat group compared to placebo, but both of them did not reach the level of statistical significance. Okay, with this data from the Victoria trial that published in a very respectable journal, did this affect the guidelines for the treatment of heart failure? This is the current guidelines for the treatment of heart failure. On top of them, the latest one, which is the American Heart Association, American College of Cardiology guidelines, published earlier this year. It stated that patients who had recent worsening of heart failure, based on the data of Victoria trial, can get benefit from using vericiguat, and they give it class 2B level of evidence B. Again, the previous guideline, European Society of Cardiology guidelines 2021, again confirms that patients with worsening of heart failure get benefit from using vericiguat 2B level of evidence B. Canadian guidelines goes the same. That's to say, patients who had recent worsening of heart failure get benefit from using of vericiguat. Thank you very much for your attention.
Thank you very much, Dr. Hussam, for this informative presentation. Our next speaker is Dr. Mohammed Qutb. Dr. Mohammed Qutb, he is Associate Professor of Cardiology, Consultant Interventional Cardiology, and he is the Chairman of Department of Cardiovascular Medicine at King Abdulaziz University. He will talk about updates in management of aortic valve stenosis.
Good afternoon, everyone. Thank you for the invitation, and I'll be talking today about new therapeutic options for aortic valve stenosis. First of all, I would like to emphasize the prevalence of aortic stenosis. It's estimated that about 7% of the population, over 65% in the United States, has the disease. Which represent about 16.5 million people. The main causes of aortic stenosis are age-related calcific aortic stenosis. Number 2 would be rheumatic fever, which is declining now with the use of antibiotics. And congenital anomalies, mainly bicuspid aortic valve. This is a pathophysiologic specimens of normal aortic valve, which is trileaflet, as you see on the upper left corner. And then you will see the bicuspid in picture B, the rheumatic valve on the picture C, and a calcific degenerative valve in the last picture. Usually, the most common pathophysiology of development of aortic stenosis is similar to development of atherosclerotic heart disease, which is deposition of cholesterol and eventually calcification in the actual cusps of the aortic valve. Usually, aortic valve stenosis is a very indolent disease until starting onset of symptoms. Eventually, patient will be a high risk of sudden death once symptoms start. and their prognosis would be anywhere between 2 to 5 years. And similar to what my colleague mentioned now, according to pulmonary hypertension and heart failure, aortic valve disease, when left untreated, it has worse prognosis than lung cancer and prostate cancer. In terms of aortic valve replacement is the only treatment that improves survival. As you could see here in the blue line, you will see that patients with the bottom blue line, they have the worst prognosis compared to the ones who have no symptoms, which is in the dotted blue line. And, but after treatment, their prognosis improves significantly. What are the options for aortic valve replacement? We have the conventional way of surgical aortic valve replacement, minimally invasive valve surgery, and then a transcatheter aortic valve implantation, which is the main topic of the day today. The prosthetic heart valves are different kinds. We have the mechanical valves, and we have the bioprosthetic valves, which are used during surgical or minimally invasive aortic valve replacement. However, if you see in this slide, it's very important that if you see the blue color represents the patient who are indicated to have aortic valve surgery, however, they don't receive it. And this is, has been repeated and represented in multiple studies. And at least 40% of patients with severe AS are not treated with AVR due to multiple reasons. So transcatheter aortic valve implantation is an alternative method for aortic valve replacement compared to traditional thoracotomy. It is less invasive for patients who are considered inoperable or too high risk for traditional surgery. The first experience with TAVI started in 1992 in study phase, and in 2002, Dr. Alain Crébier was the first one to implant it in a patient who were deemed inoperable. And since then, there was significant revolution in the advances in the structural heart disease program, especially in aortic valve treatment, by multiple randomized trials looking at the efficacy of such treatment. And, and in terms of the FDA-approved TAVI valves, you will see on the right-hand side is the Medtronic self-expanding type, which is used to be called core valve. The newer generation is Evolute R, Evolute Pro, and Pro Plus. And on the left-hand side, you will see the Sapien valve, which is developed by Edward Life Science, which is a balloon expandable type. And additional TAVIs are more available worldwide, in Europe mainly, would be MyVal, Portico, Accurate New, different shapes, different techniques, and mostly falls under two categories, either self-expanding or balloon expandable. In terms of the access site, it started with multiple types. You'll see on the left-hand side transfemoral access. Then the very original techniques were used to do small incision in the apex of the heart to insert the valve, and then direct aortic, which is done through a right thoracotomy, small thoracotomy. Eventually, there were more adaptive and new techniques like subclavian, transcarotid, and even transcaval, but mostly are falling out of favor and becoming more transfemoral approach due to the enhanced technology and improved techniques. In terms of planning this type of procedure and defining which is the best option for our candidates, it's mainly based on multimodality imaging. You will see CT coronary angiography of the aorta itself and the periphery is important, echocardiography, transesophageal and transthoracic, and eventually coronary angiography is very important to decide the line of treatment. The question now is, does TAVI improve patients' outcomes and survival? We'll start with the inoperable patients. The first big trial looking at this was the partner study, and it had two types of patients. Cohort B is the one that assessed inoperable patients. And you will see here all-cause mortality improved at 5 years from 93% to 71% with absolute risk reduction of 22%, relative risk reduction of 50%, very highly significant And very rare in medicine, we found treatments that actually improve survival, all-cause mortality by 50%. If you look at repeated hospitalization, again, dramatic improvement with patients who received TAVI compared to patients who were not treated and left for conservative management. This procedure comes with complications. It's not a benign procedure. So there are access site-related complications. There are acute kidney injury, and also the need for permanent pacemaker, which used to be very high in the beginning of the experience. And it's higher with self-expanding valves that is very close to the conduction system. However, with improvement of implantation techniques and improvement of the devices itself, this incidence dropped significantly from around 25% to 10%. And the paravalvular regurgitation also is another common complication, which also again improved with the newer valves to less than 1.5% in the TVT registry. The stroke is another big and important complication. However, if we look at it, it happens both in surgical AVR and transcatheter replacement. And it used to be, the latest data is showing risk of stroke is significantly lower than surgical AVR, 2.2% versus 5.5% with surgical treatment. And finally, TAVI is generally associated with lower rates of major bleeding and atrial fibrillation compared to surgical AVR. How about the second important group, which is high-risk patients? And those are qualified to be high risk if you do the calculation of STS score, which is the Society of Thoracic Surgeons predicted risk of mortality of more than 8%. Those patients were tested in the cohort A in the partner study, and they, at that time, it showed that all-cause mortality is similar in both group, and aortic valve replacement TAVI is is non-inferior than surgical AVR. The same thing with stroke. With this group of patients and this very old device, this is a very old device, initially there were increase of stroke with TAVI compared to surgical AVR, but at 3 years this difference disappeared. And with newer techniques, as here in the second big trial, core valve US pivotal trial that assessed high-risk patients, I'll show you the risk of mortality was actually improved and is superior than surgical AVR in this high-risk group. So 14% versus 19%. And strokes were again lower with TAVI compared to surgical AVR. The second group is the intermediate risk group with STS score between 4 and 8. There were 2 big trials, SURTAVI and Partner 2A trials, which showed in the SURTAVI arm that in the SURTAVI trial that surgery is TAVR is non-inferior to surgery in stroke or death from any cause, as well as Partner 2 showed actual improvement in terms of TAVI having less primary endpoint of death from any cause or disabling stroke. Following that, there was a big meta-analysis, pooled 4 big trials of 3,000 patients with severe aortic stenosis and intermediate risk score, which showed that transfemoral TAVI actually resulted in improved mortality with hazard ratio of 0.79 in this group, and stroke showed trend towards benefit with transfemoral TAVI compared to surgical AVR, but did not reach statistical significance. And that even pushed the researchers to go to even lower risk patients, which are STS score of less than 4, which used to be traditionally, this is a no-no for TAVI, and now with randomized trials, we show actual promising results. So the big trial in that regard is Partner 3, that showed primary endpoint of a composite of death or stroke or rehospitalization at 1 year was significantly lower in the TAVI group compared to SAVIR, with absolute difference of 6.6%, and non-inferiority and superiority criteria were both met. This is what you see here on the left-hand side of the screen. You see here that the surgery in red and TAVR was actually better in a composite endpoint of death, stroke, or rehospitalization. And also in death, it was actually non-inferior to SAVR as well as in stroke. It is non-inferior to SAVR. The other self-expanding trial of Evolute low-risk trial showed primary endpoint of a composite of death or disabling stroke at 2 years was actually less in TAVI compared to SAVR, and the non-inferiority criteria was met, as you could see here on the left-hand side. TAVI was in the yellow line, and it showed improvement. In terms of also for mortality alone, it was non-inferior to surgical AVR. And TAVI group had significantly lower incidence of disabling stroke, atrial fibrillation, and major bleeding. So now how does that leave us in terms of decision? So if the patient has severe aortic stenosis and has life expectancy more than 1 year, the patient should be assessed for the risk of surgical AVR first. And if they are thought to be extreme risk or inoperable, they should undergo transfemoral TAVI if feasible, or alternative access if transfemoral is not feasible. High risk group, which is more than 8 STS score, again, they will fall under the same category. They will be evaluated for transfemoral or alternate approach. In terms of intermediate risk group, you will see between 4 and 8, if they have accessibility to transfemoral TAVI and absence of any anatomic high-risk features, they actually should undergo transfemoral TAVI compared to surgical AVR. And if not, then they will go surgical treatment. And the last one is if they are actually low risk, in addition to having age greater than 65, and the valve is not bicuspid, and they have no other anatomic high-risk features, then they should go transfemoral TAVI. So in order to make that tough decision, we cannot do it alone. We have to have a heart team approach. It's a multidisciplinary team that consists of the interventional cardiologist, cardiac surgeon, echocardiographer, radiologist, anesthetist, and a big team that decides patient selection, procedure planning, the actual procedure of the implantation of the valve, and then post-operative care. So this is the journey of the patient being diagnosed initially, then seen by 2 independent surgeons to evaluate the risk, then evaluate the imaging with multimodality echo and CT, eventually undergoing the complex procedure. And this is an example of one of our cases that was done. This is actually a little bit complex because it was a bicuspid aortic valve. You see here, this is the aortic root, and then this is the, just to take the initial image of the annulus. Here we pre-dilated the valve, which was heavily calcified, and we used it to size actually the valve because it was a bicuspid valve and it was on the cusp between 2 different sizes. This is a balloon, this is a self-expanding valve that was inserted transfemorally, and you will see we aim at to decide the location of the valve implantation. This is the first initial unsheathing of the valve, it opens. And then this is the final image of the valve when it's implanted in a good location. There is no more aortic regurgitation, and the gradient is almost 0. So the key takeaway messages today is aortic stenosis is a prevalent disease with high morbidity and mortality. When symptomatic, and aortic valve replacement is the only treatment associated with improved outcomes. TAVI is an excellent alternative to traditional aortic valve surgery, but it is associated with relatively small risk of vascular injury, paravalvular regurgitation, and the need for a permanent pacemaker. Expanding indication for TAVI towards low-risk patients with younger age. And heart team is the cornerstone in managing such complex patients. Thank you very much.
Thank you very much, Dr. Muhammad. Let's move to the last speaker, Dr. Uthman Al-Uthman. He's a consultant robotic and minimal invasive cardiac surgery at King Faisal Specialized Hospital. He's the founder and chairman of robotic surgery multi-specialty program at King Faisal Specialized Hospital, and he is also the director of cardiothoracic surgery residency program at King Faisal Specialized Hospital. He's going to talk about robotics in cardiac surgery.
Thank you. Good afternoon, everyone. Thank you, Mr. Chairman and Mrs. Chairman, for the kind invitation. Thank you for the scientific committee. I know it's the end of the day, and I promise to make it as short as it could be with some entertainment. Which one is this? Oh. So I don't have any disclosure apart from I love robotic surgery. In the early days of heart surgery, there was two surgeons. One of them said surgery of the heart has probably reached the limit by nature of all surgery. And some other surgeon, he said, dare you to touch the heart. So thanks God we didn't listen to them, and we just kept going through and pushed through the envelope. Because of this, the cardiac surgery stayed for a little bit behind, and the experiment continued to go. The first heart surgery was done in 1953, and because of the creation of the heart-lung machine. And then after that, the heart surgery started to come through. The myocardial and the cardioplegia improved. In 1983, the coronary revasc was started, the cabbage. Since then, everything started to come through. In 1993, the robotic and minimal invasive was started, and then in 2005, the robotic hybrid approach, which means is a sum between two, cardiac surgery and PCI. So through the whole journey, here's the cardiac surgeon, he's the younger one, he's the small one. And we face a lot of things along the way to get it improved. So for the 35 years, the cardiac surgery continued only through median sternotomy until 1980, which started with minimal invasive and right anterior thoracotomy, and started the minimal invasive surgery. And the key or the sparkling for this one is just since the start of the lab collie. It's initiate and indigenate all the cardiac surgeons to see through this. So what is the true definition of minimal invasive or minimal access heart? It's the size of the incision, avoidance of sternotomy, avoidance of heart-lung machine, utilization of robotics. So it's divided in 4 levels, level 1, 2, 3, and 4. Level 4, we haven't reached to that yet, and just only during the war zone. So this is the evolution of heart surgery. Started with on-bypass, and then off-pump bypass, and then off-pump mid-cap, no sternotomy, and then at the end of the day is the robotic and total endo cabbage. So what is the limitation that was provided by the robot? The robot provided the 6-way motion. It's like you are going in the space. That's why you are using the arm like your arm inside a small hole. It decreased the digital interference between the surgeon hand and the instrument, and enhanced the surgical technique ability, and enabled the endoscopic microsurgery. This is the arm and how it looks like. It's just exactly like the human arm, and you could do it in that one. Mind you, creating such a program, it needs a lot of key pertinent people, personnel, including cardiothoracic surgeon, perfusionist, anesthetologist, cardiac cath lab staff, interventional cardiologist, clinical engineers, and it is a huge program to create. In the old days, there was the Zeiss, and it is out of business now, which is the earliest or the first robot that was used in cardiac. And then this is the Da Vinci system, which is started. Nowadays, there is more than 20 robotic in the market. The Da Vinci has been improved, and this is the latest one, the Da Vinci XI. And I congratulate the Faqiyya group for acquiring this technology. It will be the first in the region. So what we do usually is to connect this robot to the patients, and we have 3-part console. We harvested, we can do anything pretty much what we want from open heart surgery, is either valve, either cabbage, either closing OSD, placing the lead to the heart. And the benefit really of this is it's a minimum access to the heart with the minimum trauma to the patients. You see here we are harvesting the mammary, and it is really very small, tiny holes that you use it to do this complex, suffocated procedure. Here is the end result. And we used to do coronary angiogram for all of our patients when we started the program. So what is the result? We published our local data just recently and our experience in the Middle East. And we created this diagram for all patients who comes through. We divide them to 2: stable ischemic heart disease or acute coronary syndrome. If the acute coronary syndrome happens, there is a STEMI, we PCI the culprit, and then we bring the patient to the heart team and do CT scan and do robotic lima, and then completion of any other vessels. If it is non-STEMI and the patient is stable, we follow the same pathway. If it's stable, unstable, then we will do the PCI to the culprit and follow the same way. We treated over 200 patients. This is from the early of the series. The mean age was 56 patients. And you could notice here there is 70% of all patients is diabetic. And there was no major really contraindication except from previous surgery or a chest deformity. Other than that, we do the robot for all the patients. This is the average operation time is 160, and this is very important in the private sectors. And even in general sector now, after putting the KPIs and all the surgeons, the converting to conventional there was one patient, there was no operative mortality, and there is no post-operative MACE. The need of blood transfusion was reduced, is about 7%. The ICU length of stay is less than 24 hours, and the mean hospital stay is 5 days. Mind you, most of those patients is a hybrid approach with the PCI before or after. So this is the thing, the bleeding is around 2%. So our conclusion, this is the emphasizing the safety and effectiveness of robotic hybrid procedure, which could be utilized. There is a decrease in the ICU stay, hospital stay, quick recovery, and all of that things. The 3 years outcome follow-up data has been carried on, and it is under publishing at the International Coronary Congress. 100% have been clinically followed up, 98% patient with a free from angina, 2 patients were admitted and revealed a patent lima to LAD, and there was only diagonal disease. The survival was 100%. We went on and we checked for the quality of life for the patient who underwent the robotic hybrid versus the conventional. We did the 36 cohort short form assay, and here's the result. The general health is improved. That's the only significant value between the robotic hybrid and the cabbage, and I think it's because of the small population or small sample that we have. This is one of the patients who's post-op day 7 after surgery, having a robotic hybrid, enjoying time with his wife and the family in the cinema. In conclusion, establishment of robotic hybrid program is feasible with the great potential. Robotic hybrid merged the long-term benefit of LITA to LAD plus the revasc of other non-LAD territory. Low rate major adverse outcome is good at 3 years. And the quality of life is much improved in those patients compared to the others. Thank you very much.
First of all, we'd like to thank all the speakers, special thanks to the last speaker, and congratulations for these marvelous results, actually. The floor now is open for discussion. If anybody has any question, we are more welcome. Dr. Mohammed, اتفضل.
Okay, it's okay. No, it's working. I'm Mohammed Sheikh, rheumatologist. I would like to thank all the speakers for very informative presentations. I would like to comment our last question to Dr. Majdi Idris. We face a lot of patients with pulmonary hypertension, and I believe that it was a serious delay in the diagnosis. 27 months, I agree. It is very late for the patient to be diagnosed with pulmonary hypertension. The complication that we know from literature is considered sometimes leading cause of death to at least from perspective of rheumatologists, patient with scleroderma and patient with mixed connective tissue disease. This is a serious complication. Luckily it is rare, but when it is there, I think this will make our life is very hard and for the patient life. This is a serious delay, and also I would like to comment about that on the patient who established high risk with pulmonary hypertension with high detect score, for example, still we are facing some, I would say, obstacles in order to get the gold standard that you have mentioned, the right side heart cath. And the message that we want to raise, it is, as you mentioned, it is not only for the diagnosis, it also will affect our management. So I think such meeting with multidisciplinary meeting is very crucial and important, and it will raise the awareness in the involved specialty in internal medicine, rheumatology, cardiologist, and pulmonologist. What things can improve more and lead us to have an easier access to the optimum care, the right side cath, and also most of these medication already we are using them for some domain scleroderma, for example, for Raynaud's phenomena, and etc. But of course, we need to have easy access. We need to have these centers in our centers. From your experience, what are things that we could do more to improve the standard of care? Thank you.
Thank you so much. This is really a very important question, especially when you mention scleroderma, because really scleroderma and pulmonary arterial hypertension is kind of a statement of death. So those patients do very, very bad. So I think the only way to really improve the access to right heart cath is to have a center of excellence in your center of pulmonary hypertension. So for example, really in my hospital, after struggle, we now managed to have work with rheumatologists, cardiologists, pulmonologists. For example, now scleroderma patient, all of them, they have annual echo and they have annual evaluation, even if they are asymptomatic. Because really screening means that you pick up patients who have no symptoms, right? Whenever there is symptoms, it became now diagnosis. So we look at patients with scleroderma and we do annual evaluation with the DETECT algorithm, and then we did echo. If there's any signals, we go for right heart cath. But and we always, when we discuss with our colleague rheumatology and cardiology, why right heart cath? Because for example, scleroderma can give you group 1 PH, it can give you HEF, PEF, or really myocardial fibrosis, so group 2 disease. It can give you lung scarring fibrosis, group 3 PH. It can give you antiphospholipid group 4. So without right heart cath, how would I classify the patient in group 1, 2, 3, and 4? So again, we keep saying that please, 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 you want to do PH medicine, you need right heart cath. Again, as you said rightly, it's not the diagnosis. I can make a diagnosis of pulmonary hypertension by clinical examination, right? Okay, high GVP, really RV, basically HEAV, that's pulmonary hypertension. But that's not really it. You need right heart cath to classify the disease, confirm the diagnosis, and do prognostic values. So, and again, agree with you, no treatment should be really initiated without right heart cath. We have people, or really some of doctors in my centers, they used to use this medication loosely, and we get increased mortality. So we keep telling people, please don't do that. There's no thing called empiric treatment. Always right heart cath is needed. So thank you for raising this point.
I have a question also for Dr. Majdi, if you allow me. Usually in pulmonary hypertension secondary to group 2 or 3, we usually do optimize the underlying condition, like for example, heart failure or COPD. So we optimize the bronchodilation, and the patient coming for follow-up and is still dyspneic and is still symptomatic. So at what level you would consider to start treatment of pulmonary hypertension, and if you consider when you will start treatment for pulmonary hypertension?
So again, thank you for this question, and I'll say like this, because we have a lot of referral coming from our colleagues from really cardiology. So those patients, they have what looks like severe PH, normal ejection fraction. And when we see those patients, of course, it depends on their really clinical index. Those are usually obese, diabetic, hypertensive. So really HFpEF is very high. And really, whenever the question comes, if this is group 1 or this is group 2, and some of those patients who have group 2 disease, i.e. really post-capillary, with time, they will develop some remodeling process in the pre-capillary component. So they might have what really we call pre and post-capillary really pulmonary hypertension. So those are the ones who have high wedge pressure and high PVR. Now, the question is which one to treat first? Should we treat the post-capillary first or the pre-capillary first? And we keep saying if we use vasodilator therapy, which are the treatment that we use for group 1, so now I am improving the RV cardiac output from the right ventricle. Now that increased cardiac output will go to the left heart, which is already diseased, which is already having high wedge. Those patients get really pulmonary edema, and some of them die. Many really studies using prostacyclin in combined pre and post capillary PH showed increased mortality, and the study was prematurely basically terminated. So again, that's another reason why you need right heart cath, to know if the wedge is high, I cannot use those medications because I'm gonna, it's like somebody with heart failure and I'm giving them IV fluid. It doesn't make any sense. You need to treat the post-capillary component, whether this is really aortic valve or this is ischemia or this is whatever it is. So we keep saying to our colleague in cardiology, please correct the left heart. Bring the wedge down to 16, 17, 18, then I can treat the pre-capillary component. So again, it needs that one. When to use medication to treat those patients is when the symptoms is out of proportion of the primary problem. So for example, if I have COPD patient with FEV1 of 60%, but they have DLCO very low, they are oxygen dependent, they are very symptomatic. So that degree of symptoms is not explained by that severity of COPD. At that time, we do right heart cath, and we might consider treatment. Similarly, if you have somebody with ejection fraction 50%, looks like mild HFpEF, but the patient is very symptomatic, again, we need right heart cath to say, do we need to treat the pre-capillary component? Thank you.
Any more questions? With that, I would like to thank all the speakers for their marvelous presentations, and thank you all for staying with us till the end of this day. The session is closed now.
Speakers, that's why it gives me honor to ask our great moderators, Dr. Hussam, Dr. Arwa, would you please come here? We want to say thank you for our speaker and we want to give them something just to remember us later on. I know that I gave you a lot of headaches, by the calling you and sending many emails and asking for the presentation. But we want to just give you something to remember First Faqih Congress. Dr. Osman, تفضل. تفضل. the beginning with us. I want to thank her personally. Dear friends and colleagues, thank you very much. Really, we enjoyed the first day. We will be waiting for you tomorrow, inshallah. Tomorrow, our lecture is going to start 9 a.m. sharp. Please try to be here early, and inshallah, it will be the same fruitful program like today. Thank you very much. See you tomorrow, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh. Shukran. شكرا لحضراتكم. شكرا لحضراتكم.